I think yesterday's sessions were too exhausting, so nobody has joined yet. So I hope everybody will be joining as soon as possible. So let us start with the today's session, and I would like to invite our session director, Ms. Ranu, and she is an NEC member, IPN India, and she is a public health nutritionist with a vast experience regarding the public health policies and public health, community health basically. So welcome, Ms. Rano.
Thank you, Binu ma'am. Thank you. Good morning, everyone. As the session director, it is my pleasure to welcome you all to the interdisciplinary care in parental and enteral nutrition. As we know that parental and enteral nutrition are life-saving, but their complexity, vascular access, metabolic balance, and gastrointestinal tolerance creates real risks. That's why a true collaborative approach is essential, in which physicians as well as the dietitians and allied health professionals, each being a unique and complementary perspectives. When these specialties work together, we can design individualized nutrition plans, catch problems early, and ensure safe line and tube management. Core ingredient of a high-functioning team includes a rapid, comprehensive nutrition assessment, jointly created care plans that specify routes, formulas, and monitoring standardized checklist for line insertion, line care, and metabolic monitoring. Regular nutrition rounds where the team shares insights and decision supports that reinforce the best practices. In real-world experience shows that the power of this model, hospitals that build dedicated multidisciplinary nutrition teams report fewer line infections, smoother transitions to the home nutrition, and better tolerance of feeds, while community settings have been faster problems resolutions and improved the patient confidence. This challenge is fostering a culture of shared responsibility and committing time for coordinating rounds, but the payoff, safer, more effective nutrition support is clear. In this session, we will hear from the experts who have built successful interdisciplinary models in their settings, in their hospitals, examine practical case studies, discuss concrete steps that will take you all in your own, that you all can take in your own institutions. Now I look forward to an engaging discussions and hope you will leave with the fresh ideas for strengthening teamwork in parental and enteral nutrition. So let's get started. First of all, I would like to invite Dr. Ellen ma'am to chair the session. Ellen ma'am ka slide. Ma'am is the head of the Department Nutrition and Dietetics at Sir H.N. Reliance Foundation Hospital. She is the founder of IPN India Nutrition in Transplant Core Group, and she is the secretary of IPN Mumbai chapter. Ma'am is on the board that Indian Dietetics Association RD board, ESPN certified, and pediatric onco-nutritionist. And ma'am is also IBS certified from Monash University and certified body composition analyst, nutrigenetic counselor, certified diabetes educator. Welcome, Ellen ma'am.
Thank you, Ranu, and thank you, IPN, for having this entire session on enteral nutrition. So today we are going to talk about the interdisciplinary approaches to nutritional support, whether it is enteral or parenteral nutrition. For that, I would like to invite so we'll be inviting the chairpersons. Ranu, if you could do that.
Now I would like to invite Reema ma'am. Reema ma'am is an alumnus of the Department of the Food and Nutrition, MS University, Vadodara. And she is also the founder of the Panacea Diets for the Personalized Diet Plans. She is certified diabetes educator, certified FODMAP dietitian from Monash University, Australia. And ma'am holds a certification in sports-specific nutrition management. She is National Executive Member IDEA 2019 to 2021. and member National Executive Committee, Indian Association for Parental and Infant Nutrition. She is the convener NetProFan Gujarat chapter, FSI, Government of India, and also the member of the core committee for developing obesity quiz, FSI. And ma'am is the co-author of the Healthy Recipe book and member of the National Executive Committee of the IDA and life member of the IDA, NSI, IPN, RSGI and member core group Neuronutrition. Thank you, ma'am. And next chairperson is
शिल्पी वर्मा मैम होते हैं, शिल्पा वर्मा मैम। चलो अभी इस सेशन के थ्रू रीमा मैम है।
ma'am. Now I'd like to.
Can I start?
Yes.
Thank you. May I have the panelist? Is the panelist slides going to be played? Yeah. So, no, Sunita, I need Sunita's PPT. So anyway, Sunita Sahu, may I invite her because who doesn't know her? She is in the Central IPN committee as well as the chief dietitian at Apollo Bhubaneswar. Welcome, Sunita. I would also like to invite Bindu. Bindu, we have been having a little conversation since the past few days, and I'm glad to invite Bindu to this days. Bindu is a nurse by profession, and she has many years of experience in critical care nutrition. I would be happy to have Bindu up. Also, Dr. Kailash, may I invite you, who is an intensivist, and yeah, Dr. Kailash will throw some light on intensive care unit, the happenings. Dr. Kailash, please. So to dive right away into what we are talking today is the interdisciplinary support where enteral and parental nutrition is concerned. Welcome dear panelists, Dr. Kailash, Dr. Sunita and Ms. Bindu. As you all see that our panelist is also a mix of multi-professional and multidisciplinary team, and they it's not only one person who is responsible for the outcome of the patient when nutrition is concerned. So we definitely understand that when nutrition is concerned, we have people of different disciplinaries. Yes, we don't have the pharmacist here, and we don't have many other people who also are very much the need for a multidisciplinary team. However, we'll take multi-questions where, I think all the aspects of an interdisciplinary team will be covered. So when a patient is critically ill, nutrition is not a luxury. It's not something that, you'll go and, or whether you'll make the patient feel that, okay, what would you like to have, or what is your best food would you want to eat to recover fast. So we don't look at it from that aspect, but we look at it from as a lifeline where recovery is very, very important. So nutrition support today is no longer just something that's happening in the background. It's not like yes, the medication is going on, IV lines are going on, ECMO is going on, or dialysis is going on, and those are all very critical for the patient to get out. But today we know that nutrition is a cornerstone which leads to the same goal of patient survival, recovery, and better outcome. And hence we look at what everybody in the team can do to make nutrition its best deal. So behind every well-nourished patient, there not only stands a dietitian, but also stands a very good team, which involves, today we have Dr. Kailash with us, we have Bindu as a nurse, and we have Sunita as a dietitian. And their role is like an orchestra, where each one plays a different music, and that's when the song is composed. So this results in healing, and to begin with, you can take your mics. We'll start with Dr. Kailash, where we'll ask him about, what is his opinion and viewpoint on the multidisciplinary team in the critical care setting?
So, according to me, the interdisciplinary team which have knowledge, so knowledge not only about the, in case of nutrition, not only about calorie or protein requirement, but also have knowledge about the what is the disease as well as other factor which may very important like social, economical and cultural aspect also to decide the nutrition for particular patient, and also have the skill to how to which method is appropriate for particular patient, and what are the practice is local practice. So everywhere is not as same practice. There is different practice depend upon local factor. So these are the thing according to me. So knowledge, skill, and as well as practice.
Thank you, Dr. Kailash. You rightly said that knowledge is a very important aspect in dealing with a patient. So I would take the same line from where you left, and I would put that same question to Sunita. Sunita, where Dr. Kailash said that knowledge is important, in your profession as a dietitian, you know that the scenario of healthcare and intensive care is changing rapidly. There was once a time where GRV was measured, today it is not, with sometimes calories, proteins change. How do you in your profession upgrade your knowledge of critical care nutrition?
Okay, first of all, namaste everyone. As a clinical dietitian, we are talking about knowledge. Definitely means like my aim is to update myself with recent advancement. And yesterday we were talking about these guidelines, and obviously practical experience helps a lot for us to upgrade our knowledge, and this seminar workshop, this kind of seminar and workshop definitely help us to upgrade our knowledge regarding clinical nutrition in ICU setup.
Well said, Sunita, because this kind of gathering where we have something like a SAPIN and we have an interdisciplinary team from so many countries coming forward and speaking what are the best practices that are happening in their setup is what we are looking at. So exactly, Ms. Bindu, where it is concerning a multidisciplinary team, how do you see your role as bridging the gaps that are there, and how do you manage the multidisciplinary team approach for your setup?
First of all, thank you. It's been a privilege to be here in this panel, and thanks for my organization and my director who gave me this chance to participate in this panel discussion. And being a nurse, I'm proud to be sitting here. And first of all, the interdisciplinary team, it matters a lot as a nurse, because the nurse is the one who is there in that chain, who ensures that the nourishment is turns into the healing part. And also it is not only the one person decision, and it is a collaborative team where the team decides what has to be given to the patient, and also it matters a lot. So I feel the interdisciplinary team collaboration is very important. And also it is easy for the nurse to advocate the care properly delivered to the patient.
Thank you, Ms. Bindu. I think she hit the nail rightly, saying that it is not a one-person decision. So it's in a hospital where the patient is in the ICU or in a setup, although we have a driver, we have the primary physician, but what she said is that it's not a one-person decision, and I think that is something which is very, very important to take the team forward to decide a right goal for the patient. Now coming to patient care, care, and understanding what the patient is best. So, Dr. Kailash, I would start with you. What decision, what is your mind map where, what is the route of the patient should be used for feeding the patient? How do you think about that?
So it depends what is the condition of the patient, whether it is outpatient or OPD patient, or whether it is inpatient. And inpatient, if the patient is critically in ICU, whether it is a ventilator or just off with a ventilator. So there are lots of the factors which may decide which route is the best for which patient. So if the patient is during first contact, we assess in the OPD, we assess whether the patient is at risk or for malnutrition, and then accordingly we advise, definitely oral or enteral route is the best route if it is feasible and safe. So these are the factors which decide
Thank you.
which bed.
So what you rightly said is that we assess the patient, and I think assessment is the first step to treatment and an outcome. So without an assessment, it doesn't really make sense to go ahead. Now, Sunita, where we talk about the gut, we say use it. In what scenarios you would think whether a patient needs an enteral nutrition or a parenteral nutrition? What are the scenarios?
Regarding gut, we all know the indication and contraindication for enteral and parenteral, but as per practice and as per guidelines, it's always advisable to start the enteral nutrition first. Certain conditions like pancreatitis, especially necrotizing pancreatitis, and if patient is with like continuous severe diarrhea, then if patient has means like NBM or not taken anything since more than 7 days, in those and severe like ileitis cases, we usually see parenteral to be started, but in all other cases, it's always advisable to start enteral nutrition.
Rightly said, Sunita. We definitely, the routes that we decide is the oral route. If the patient is unable to eat more than 50% of the calories through the oral route, then we think of an enteral route where the patient is fed directly nasogastric. If the patient is contraindicated for nasogastric due to some aspiration reasons, etc., then we also do a nasojejunal feeds, or if it's a long term, then we look at a PEG feed. So that's how we decide the routes. Where Ms. Bindu is concerned, once the route is being decided, what about how do you go about with the monitoring, and how do you communicate to the doctor or the dietitian about the electrolytes, whether it's okay or no, or whether there is some symptoms or something that you see like fever or anything? How is your way forward for that?
Thanks for the question. When it comes to the enteral or the parental feed, these are not the isolated therapies. It is a complex oriented intervention. So here the nurse, she plays a crucial role, because in terms of monitoring, she has to have the clinical judgment, like to know the signs of intolerance, as well as to know the signs of aspiration, sepsis, as well as how in case of any infection, she should know the ability, the clinically oriented, how to address or escalate the concern to the clinician or the on-duty doctor, which matters a lot in deciding which route has to be given for the patient.
Excellent, yeah. I think communication at the earliest is the, takeaway from what you said, that immediately communicate to the right person what is happening. So that the action, if there's a septicemia or there is something, the action which is taken is immediate and does not delay the outcome of the patient. So once we have decided that what kind of collaborations are required with each other. There are patients who do not tolerate feeds at all. So, Sunita, if we are switching on from a parenteral nutrition to enteral nutrition, how do you take the patient through? Suppose the patient is on a parenteral nutrition for a long time, or patient has not had any food, and we want to, we do not want to have a refeeding syndrome. What is your strategies?
Yeah, this is a very typical case, and I would say very critical also. So in that case, our approach will be slowly we will start the feed and monitor whether patient is tolerating, as patient was on TPN since long days. We will first monitor whether he is tolerating the feed or not, and gradually we will increase the feed volume. And the second approach is nowadays these semi-elemental formulas are coming. They are also into picture, means like most of the clinical dietitians are using that, and they also gives good result. So when this transition phase is there, so we can consider about that also.
Excellent. So what you said is an early trophic feed, where we do start the patient slowly. We wean the patient from one route to the other, start with the trophic feed, and then of course if you look at the multidisciplinary team, it's also including the pharmacist who is providing if we have a parenteral nutrition or a enteral nutrition. Also coming to Bindu, you are the eyes and ears of the patient at that time, because mostly the dietitian comes, takes her rounds and goes, or the doctors come, or they have a multidisciplinary round in the morning and they go, but then the entire time the patient is with you. So what are the challenges you face when it's a full ICU and you have limited nursing staff to monitor, to deliver, to administer feeds? What are the challenges and how you manage those challenges?
In terms of challenges, what we have is the training part, which is actually lacking in terms of nutrition. And also there are some limited resources like infrastructure related, where the infusion pumps related to feeding is non-available. Third thing, there are at times where we have to involve the patient attenders, because because there are the hospitals are JCI accredited, so there are some terms and conditions where we have to involve patient and the patient party in the line of treatment. So getting their consent in all the line of treatment, it is very difficult, where the doctors as well as the other support members, they just see the patient and go, but the nurse who is there 24/7 with the patient has to address all these issues regarding all this, whether it is ethical consideration and other things.
Yeah.
Yeah, but
there are so many things. I can imagine, imagine the training that you all must be, putting on to each and every staff there, because it's, of course, rightly said, it's not only handling the lines of the patient, but it's also handling the patient and family education, because if you are a JCI accredited hospital, you would need patient and family education. Okay, so very quickly, I would want to, close this session now, because we are going in for the other session. One last word on, how you maintain a fluid and balance where calories and proteins are required very high, but the doctor will tell you, I have only 500 calories to give you, or 800 calories to give you, but you have to give almost double the amount of, calories and protein. So with fluid, how do you balance that?
Yeah, this situation we are handling every day in ICUs, like cases like ARDS, kidney, means like renal patients, liver patients. So first of all, as we are talking about interdisciplinary team, I would suggest every clinical dietitian in ICU first should consult the consultant exactly how much fluid we can give to the patient. And accordingly, choice may be first, we can choose this like high caloric formula 1.5 to 2 kilocalorie per ml formula, that's one solution. If means like calorie, we can see top of protein we can add in that, and closely we can talk to nurses exactly in other like medications and other non-nutritional things, fluid in which way they are giving, whether we can control that or no, and so that in nutrition we can give that much of fluid. All this approach we can means like look into, and so that maximum and calorie we can reach within that fluid limit that we have to see.
Excellent contribution. One last takeaway from all three of you all, and then Rima has been listening to us so patiently. I'll then hand over to Rima. But one clinical scenario or one incident that has, really where interdisciplinary support has really helped in the outcome of the patient. We'll start with Dr. Kailash.
So there are many, but one important patient I remember is one patient, a young girl, which she had tubercular abdomen with perforation. So we went for surgery, but it was very difficult abdomen. So luckily we brought out some part of the proximal bowel as a stoma, and post-operatively she had wound dehiscence, high output stoma. So with the team of wound care nurse, ostomy care nurse and nutrients, we able to manage with the initially around 1 month for TPN, and after ATT of 1 month we went again for second surgery, and then the distal stem that was left inside, so we take out as a distal stoma, and then we in second we started refeeding through the stoma. So ultimately that patient improved, and luckily she was discharged with good condition.
I liked what Dr. Kailash said. He said that although he took a decision for stoma and for the patient, he relied on planning a TPN with the dietitian and for the stoma care with the nurse. So definitely we see that one person, even if it's an intensivist, cannot manage the patient throughout. He would definitely need support from the other teams. Over to you, Sunita.
Yes, in some cases we need this collaboration from nurses and also doctors. Like if feed volume is not achieved in that day or for certain period of time, we definitely seek help of nurses in the ICU to closely monitor, and if certain amount of feed is not given, we with help of them we try to give them in night feed, or we can discuss with the doctor whether we can start partial TPN for them to achieve that calorie protein goal for the patient or not. And in this way, for many patients, we can collaboratively help patient to achieve his calorie and protein goal.
Excellent. So what I understood from what you said is that when you're not able to achieve your target nutrition, you speak to both of them. You speak to the doctor and say that, okay, doctor, we need to be a little more aggressive. Can we start a partial parenteral nutrition? You also speak to the nurse and say, okay, can we have help from you to feed the patient through the night so that in 24 hours we have reached our target calorie and protein. Excellent example for teamwork. Ms. Bindu, if you could highlight one point.
Ma'am, it is in the conclusion part, so I just want to say the strength of both the enteral, whether the parental feed, it is not a single discipline expertise decision, it is the team approach collaborated decision. So where in my journey I have faced many good outcomes through this team collaboration. So I feel really proud to be part of this team, multidisciplinary approach team, and thank you so much.
Excellent comments, and definitely to conclude this, of course, critical care nutrition is never ending. A collaborative, a professional team working towards a patient makes all the difference. So timely assessment as highlighted by Dr. Kailash, collaborative decision making, what Sunita said, and monitoring complication management as what Bindu said, is important for the quality improvement and outcome of the patient. Over to you, Rima. Thank you for listening to us so patiently. You may take it from.
Yeah, thank you, Eileen, and I really understood how critical it is, you know, interdisciplinary approach for enteral and parenteral care. So we now, thank you so much, and do we move on to the next talk? Okay. All right.
Thank you so much.
So I welcome Dr. Renuka Jayatissa for our next talk. She
will introduce all the chairpersons. I'm waiting.
अच्छा अभी ठीक है
अरे एक सेकंड just give me a second. Just we need to introduce the chairperson.
Now I'd like to invite Ritika ma'am, Ritika Samadar ma'am. Slide. It's Ritika ma'am ka slide. And Dr. Shilpa ma'am. Shilpa ma'am, Dr. Shilpa ma'am. Ma'am to chair the session. And Dr. Ankit. Now I would like to invite Dr. Ankit Sharma. Reema ma'am, it's over to you.
Good morning, everyone. So I welcome Dr. Renuka Jayatissa. She's the Vice Chancellor and Head Faculty of Foods and Nutrition at International Institute of Health Sciences Multiversity. She has over 30 years experience in working as specialist in community medicine, public health, nutrition and clinical nutrition. Head of Department of Nutrition at Medical Research Institute in the Ministry of Health, and as a nutrition specialist in UNICEF. Currently, she's also working as a South Asia Regional Coordinator of the Iodine Global Network, President of the Association of SARC Foods in Sri Lanka, and the President of the College of Palliative Medicine Sri Lanka. She's an honorary member of ESPEN, founder and the chair of the directors and the regional coordinator of SAPIN, founder president of the Sri Lanka Medical Nutrition Association, and the past president of the Nutrition Society of Sri Lanka. Welcome, ma'am. We are really eager to hear you from all your qualifications. We're really eager to hear you.
Thank you, Chairpersons. Ladies and gentlemen, good morning, all of you. My topic is something little different. It is nutrition in end of life. So this is the outline of my presentation. You can see it. I don't need to read it. So when we really look at what is palliative, what is end of life. So if you take the palliative care, now any given time, at any time during any serious illness, if we are going to manage the pain and discomfort from that illness, that's the way that palliative care come up. So when we look at the end of care, so end of care is during the last 6 months or maybe the 6 months of our life, of end of our life, when we are receiving, we don't need to longer receive any curative treatment, but we receive any remedies to ease the pain and discomfort and things, so that's the end of care. So this is the two things now which is really coming up very kind of passionately in everywhere. Why it is coming up, you can see what is death, what was death previously in the past and what is death today. So the death in the past, actually it happened at home with our family members and everybody with the comforts and everything. But now what is happening is, this is a prolonging life and the prolonged agony, and the most of the time end up with the full of tubes and the finally death. So this is what this end of life care has come up, but at the same time this is another thing, because there are so many life limiting diseases. Previously it was not, the burden was not that high, so that is the reason most of the countries like Australia and the US, they have a very developed this end of life care process. But our country is also now facing all these life limiting illnesses with the huge burden. It is not only cancer, because most of the time our part of the world, this is mainly, it was developed for the cancer, but it is not only for the cancer. These life-limiting illnesses are coming up with the other issues like heart disease and the Parkinsonism, all these strokes and the COPD and everything is coming up as a burden of the disease. So this is what this care process has come, as well as the extreme age. So when we look at the end of life, and then if the doctor or GP, if they certify this person's the life expectancy is maybe 6 months or less, so this is a place that the end of life care come. So then if the person live more than 6 years, and then the doctor has to recertify whether what is the kind of extreme, when the kind of the expected death time. So when we look at the previous kind of panel discussion, the interdisciplinary team. So in this end of life care, the interdisciplinary team is very much important. But here the family member is also part of the team, not only our professional teams. And especially it is maybe the primary caregiver is a family member most of the time, but some other places it may be the other caregivers, maybe a relative or close friend or with a paid caregiver. So with that, our interdisciplinary team come up. You can see physician, dietitian, physiotherapist, caregivers, everybody, not even that chaplain. Religious part is also very much important inside this interdisciplinary team. So then everybody will support for the whole process. Then what are the kind of physiological changes near the end of life? So we know now, this is something, I'm just highlighting the things which are related to nutrition. There's a reduced appetite, and as well as a need of the energy, and the altered taste, smells and swallowing, and the nausea, constipation, dry mouth, and the natural decline in the food and fluid intake. This is something happening. Then what are the goals of nutrition? Because today we are talking about the nutrition. And then one is the focus, mainly we have to provide for the comfort, not cure. And then the preventing hunger and the thirst, discomfort, because thirst, it will come up with the discomfort. And the avoid unnecessary interventions, and the respect the patient's wishes and the cultural values. These are the important things in the goals when we are looking at the nutrition. So when we look at these goals of nutrition, we have to look at which has evolved, how it came up. So when we look at the history of nutrition support, you know that it has come up from the 3,500 years ago. But when this other kind of end of care part has come, up to 1960s, this religion-guided end of life decision making for many patients have come up. And then after that, you know, in 1990, establish the right of patients in withdrawing artificial nutrition and hydration. And the present day, we have the ethics of withdrawing or withholding, and then we have the well-defined considerate. Most of the countries, they have well-defined ethical principles. So with that, in addition to that, we have guidelines. So this is one of the guidelines which came up with ESPEN. So it emphasizes food and drink by mouth, which is a basic care. But when the medical treatment wise, that means 3 types we are concerning, that is curative care, palliative care, and dying period. So then how are we going to give the quality of death, and then how this nutrition they explain in the guideline is questionable. So this is the kind of new guideline which has come. The second one in 2025, which came up with the clinically assisted nutrition and the clinically assisted hydration at the end of life. So this is the next new guideline which came up in the clinical medicine. If I really highlight few case studies, now this patient, this is a 70-year female, presented with the advanced ovarian cancer and have not made adequate response to treatment, but the condition is getting worse. And the thing is, but still when we look at, she was malnourished and cachexic. So we have a question, what is the best approach? Then we look at guidelines. So when we look at guidelines, so this is one of the evidences. Now this is a prospective multi-centered randomized control study which is conducted for the advanced cancer. So finally with this survival and looking at the global health and the physical functioning and the fatigue in this study, final conclusion was not to prescribe parenteral nutrition for the patients with advanced cancer with life expectancy under 3 months and when they have the functional intestinal tract. So this is what we look at evidence. So now we'll see the second evidence. In the second evidence, you can see this is coming from Japan, from the 23 palliative care centers. So here they have given the 3 arms, enteral nutrition, parenteral nutrition, and control groups. So what is the conclusion? Conclusion is it's to consider not only of its benefits but also preferences of patients and family members. So this is what then we have to see. Now we have to see some evidences say some other evidences look at the thing. So this is the next one, next case. This is another common thing which is now coming up, dementia. Now this lady is 89-year-old, end-stage dementia with dysphagia, admitted to the hospital with aspiration pneumonia. Then several days after the antibiotic, and then confirms there's a severe dysphagia. For what is the recommendation? Nothing by mouth. And family concern, then family say the patient will die due to starvation. They don't know other things, so that's their concern. So they request the feeding tube placement. So when we look at the evidences with the dementia and the nutrition support, so these are the few things available, but in this particular patient, when the feeding tube is inserted, there's a lot of agitation with the patient, and then as well as because of the agitation, you have to put the patient with the bars and the bed with bars, and then what happens is patients dislodges the feeding tube, and then again reinserting of tube, and the pneumonia get worsened, and then IV tube, finally patient died in the hospital. Whether it should happen. So this is a question we have to say, is it a good care? So the next question comes with the end of life. People are very concerned because they are starving, we have to give something. But anorexia is very frequent, but they don't feel hungry. This is an important thing. We feel that they are hungry, but we know they don't feel hungry, and especially total fast. That is another thing, certain degree of, it will provide a certain degree of analgesia and euphoria due to the increase of the endogenous opioids. This is another good thing with the starvation. But the partial fast, they get the sense of hunger, because sense of hunger it's a discomfort. The second question, motor neuron disease. This is another thing which is coming up now. This patient is 65 years and the MND and who had decision-making capacity. This is what important. And with the PEG, but the patient get the more palliative than the life-prolonging things, as well as kind of improve the nutrition, and but the burden, they increase the nausea and decrease the human contact. This is what we have to inform when they are with the kind of sometimes PEG and they are scared to go out, social life get disrupted, and they get the decrease the human contact, and then but there's no evidence with the life prolongation. So this, what is the decision, then we have to take it up. So this is another guideline, the SMN1. They say once the diagnosis of persistent vegetative state is established, an advance directive or the presumed will of the patient have to be considered. If there is evidence which is applicable for the given case, it has to be followed. So this is a kind of very kind of critical decision-making process. This is what we have to think about. So in the decision-making framework, what we have to look at, we have to assess a prognosis, swallowing, and tolerance. And at the same time, we have to discuss the goals of care with patients and families. Sometimes it may be difficult because of the literacy level of the families. And the balance, benefits versus burden. At the same time, we have to uphold the autonomy and dignity. Then what are the options? When you look at options, the one is clinically assisted hydration. So under the clinical assisted hydration, so then especially rather than giving IV fluids, they are going at the subcutaneous administration of the fluid. So this is the hypodermic lysis, as well as you can give the proctoclysis. You can see in the picture how can the tube inserted to the stomach or duodenum and giving the things, or by giving in the kind of subcutaneous manner. So these are the new things. Then otherwise with the IV fluid, the problem is the organ functions get worsened, at the same time precipitate the cardiac failure, and then worsen the lung secretions. Then the next one is the clinically assisted nutrition. Now here, there are few indications, like if they have the reversible or irreversible inability to ingest or absorb sufficient nutrient, there is an indication. But if the patient is having cancer cachexia, this is not an indication. At the same time, if the patient is having nutrition impact syndrome symptoms, something like dry mouth and the taste disturbances and the oral discomfort, and those are also not indications. So this is what we have to look at. What are the real indications for clinically assisted nutrition? Then the next one is, before starting the tube feeding, we have to always look at whether this patient's quality of life, will it get improved? Or will it improve the functional autonomy? Or will it enhance the survival rate? So these are the three things we have to look at. And at the same time, if the life prolongation, whether it is desirable from the patient's point of view, this is also important, and whether is a benefit to risk ratio favorable. But as I mentioned previously, indications, you don't need to think about all these things if it is indicated. If it is not indicated, we have to think all these things. Then the another part which comes at the end of care, cultural and emotional conditions. This is very much important because food is a symbol of love and care. People want to give something to them before they die. So this is a symbol of love. And at the same time, families, they feel distress when patients refuse food. And the other thing is, they want to, this is a sensitive communication. We have to explain that this natural decline, you have to be with patient, counsel, and explain the family members. Sometimes family pressure is too much, and have to support families emotionally. This is what the interdisciplinary team is necessary. This is what we need, the chaplain, we need dietitians, nurses, and the social worker, everybody in the palliative part. Otherwise, you can't do, one person can't do everything. This is one of the important care part with the interdisciplinary team. Then the ethical perspective, this is very much important because some countries it is going for swine, so we have to see the ethical perspective. And then the withholding or withdrawing nutrition, whether is it a negligence? Actually, it is not a negligence. So that's another part. And we have to respect the patient's autonomy and informed choice. At the same time, aim for beneficence and the non-maleficent. So this is the ethical perspective we have to think. If the countries do not have ethical background, ethical perspective, it should be really have to work with the legal department and the human rights department, because it is much needed in the future. So in summary, comfort and dignity are priorities, and nutrition care should reduce distress but not cause burden. Communication and compassion are key in this part of care, and the teamwork ensures the holistic care. So with that, I would like to end with the compassion in end-of-life nutrition care brings peace to both patient and family. Thank you.
Thank you, ma'am, for that insightful presentation. So today's session reminded us that nutrition in palliative and end-of-life care goes far beyond calories and nutrients. It's more about comfort, dignity, and compassion. Thank you, ma'am. Any questions, anybody? All right, we go to the next session.
Good morning, everybody. Very, very happy to introduce our next speaker, Varsha Gore. Varsha Gore has nearly 25 years of experience in the field of nutrition and dietetics. She's currently the HOD dietetics at Apollo Hospital, Navi Mumbai. She's also the vice president of IAPA in Navi Mumbai. Has lot of credits in terms of research papers, awards, and also has written book chapters. So with this, I would like to call on Varsha Gore, who is going to talk about enteral nutrition, not in the hospital, but moving away from the hospital to home.
Thank you so much, because I think this is the need of the day. And in this interdisciplinary care bundle, what we are dealing, we saw the interdisciplinary bundle, we saw the palliative and end-of-life care, and we are in between. And as a practicing dietitian, enteral nutrition till hospital, we are doing the best and the fullest. And I thank organizers for giving this topic, because we are on the left side, but the car has to drive the other side, and you don't know where our patients go. Whether it's a small setup they move, there are bigger hospitals and setups, there are care agencies which take care of home enteral nutrition, which we are not even aware of. But the same standard line of treatment is much deserved for the patients. And yes, when we talk about this topic, first thing comes the barriers. We should understand what are barriers. If we know our barriers, then we can tackle the other side. A is the communication. Whether the hospital is able to give you the same communication, the same protocol, the same effort what we are giving for patient. At patients, you know, in hospital we say, this is the line of treatment, this is the LOS, and then you go home, and they expect. But how many times we see the readmissions? And where do the patients come from? Sometimes they come with more challenges. So lack of knowledge, skills, management. So overall, there seems to be a non-systematic approach in this quality-driven plan, what we would give in the hospital and have a replica of the same, whichever setting they go. So the objectives remain the same as what we would do in the hospital, the same it has to be followed at home, that the purpose should be very clear to the relatives, to the caregiver, to the patient if you can understand. The indication, contraindication, I'll not get into it, but understanding what tubes are the lines. Simple thing, if you ask your patient, what is the patient's sugar? Malum nahi hai. Temperature, output. So there are so many things, and this is just about the basics. But this is an interdisciplinary approach. We talk about the access line, nutritional management, micronutrients. What does research and evidence say? There's a lot of global research where they have conducted in thousands of people. But how much data we have? Maybe we can have a little bit of a bundle of it, or just case-based approach. So I'll try to put even a case. If time allows, I'll give a real-world experience of 1 or 2 cases as a learning experience. So we all know home enteral nutrition remains the same. The delivery of nutrients, more important is the food and the fluid directly into the GI tract. And yes, when you can use it, we have to use it to the best and the fullest. It's not like when you are hungry, you will eat 10 or 20%, but meeting the goals is very important. Purpose is very clear, and it is a fuel for your body. This fuel allows your body to deal with your disease, infection, immunity, and thus have a holistic approach. I'll not get into the best of the quality of life or infection, but it definitely reduces the health cost, the trauma, the patient's agony, and the caregiver's agony running to hospitals and taking. So we have to have the enhanced clinical outcomes even when the patient moves from the hospital to home. I think most of you all have gone through this. If not, ESPN guidelines on home enteral nutrition gives about 61 recommendations, and it's a paper which we can refer and try to bring some things in our practice if there is a confusion in it. It's a big summary. I've tried to take few of the essential points, and the key elements remain like what are the indications and contraindications, access devices, product recommendations. I think we do that. But delivery of products, monitoring, and whether to terminate, how much to give or not. What are the structural requirements for the home enteral nutrition? What is the team? Who will play the anchor role? Who will be the supporters is required. Clear-cut, severe dysphagia. Sometimes we don't know also whether the patient is suffering, whether his appetite is there. All the head and neck cancer patients, neurological patients, where the gut motility issues are there, and long-term managements of the stroke and the RTA patients. There would be a time when we will have to contradict. Now this is looking at home, not in the hospital, whether the patient gets hemodynamically unstable. There are any other metabolic imbalances. So are we having a check on the biochemical parameters, the output, and the wound management of the patient? So all this is important. We are familiar with this, but little bit understanding, probably a booklet of information, if it can go from hospital to home, will serve as one of the important element of understanding. Like in hospital, we have a booklet. What is the IPD booklet for the patient? Similarly, a home care booklet, which covers the most of the important elements, is much beneficial. These are the different access devices. And then the device definitely, the access is definitely based on the patient's condition. How do you see your patient as? Is it a short-term patient, or then you're going to wean off and then the partial enteral to oral is going to be there, some trials are going to be there, or there is a long-term enteral plan, so whether the PEG feed is required or not. So understanding this, so this is a physician's approach, this is a clear-cut understanding. We have to give a realistic picture to the patient that you cannot have your main route, you cannot use the main highway, but if you take the other highway, it will help the patient to build up in his own health. We cannot, it's just not a tube and the patient, the support of many such devices, because they can help us, whether it is a gravity bag, then you have the tubes, then they need to have separate ports where the medication will go, fluids will go, the syringes, the connectors. So a clear-cut understanding of that. Now once maybe they had seen a gravity bag, but they don't know where it will be available. So there are setups where they give a home care enteral nutrition packages. How much of us are aware of this? How much of us patients receive this? Can you imagine patient traveling to the hospitals like a 200, because we get patients who travel so far, and of course why they come? Because they don't get that quality of care what they deserve in the nearby hospital setups. Administration methods will change. Some are able to take bolus, some need continuous feeding, a cyclic feeding. Now there are patients who will be eating a very little amount of the oral. So maybe the night feeding can be used for the continuous drip method. For some patients, it's just not possible. So during bolus, a short bowel is given in a small time, which will mimic our natural rhythm, and in 15 to 30 minutes. That training, even while giving a bolus feeding or a cyclic feeding, the positioning of the patient, how much time it will take to deliver the nutrients, all is important. Here comes the role of the nutrition support team. Do our patients receive this information? Do they have access to the support team? Typically, they will have a nurse, but nurse said that first patient where I was managing, they were doing like this, so I will do the same thing. Is it the replica? No, it is an individualized approach. So the quality care is, we cannot say a cut, copy, paste, because practically it cannot be a cut, copy, paste method for an individual also, because the line of treatment, how much you would need the nutrition, how much medication and infections the patient is going to have, we really don't know. So there needs to be a titration, there needs to be a monitoring. This can be a weekly monitoring, fortnight, depending upon the case of the patients. Knowledge about the water flushing, if there is a need of pump. So this all comes under the administration. Does our patient have a safe route? Never. And it can if there is a kind of a standard protocol or a method. A patient is not able to eat oral, his degree of malnutrition is moderately. I'm not even talking about assessments. We understand there is a degree of malnutrition and there could be sarcopenia, he could be obese, he may be bedridden, or he may need a physiotherapy support because there will be multiple disciplines involved. But does he get the right treatment or not? But if you are just monitoring about the enteral nutrition, is the patient, they will get alarmed with if the vomiting, there is vomiting, or there is diarrhea, or there is a constipation. But what caused it? How can we deal with it? Who is going to talk about it? So there are vital parameters also which we need to check. The routine, when we make telephonic calls, we ask the caregiver, can you tell me what are you giving the patient? Are you monitoring his blood sugar? Are you monitoring his sugars? For a stable patient, the weight check. And now there are advanced ways of looking at body composition also. But the simplest of things like, the feed is not given because tube blockages are there or displacement is there, and patient stays starved and hungry for a long time. And not only starved, but he's been dehydrated. So the typical complication which really needs to manage, where nurse has to coordinate with the physician and the support team, is that what is the problem? There's a leakage, or there's a granulation tissue around the stoma, and then there's a need of a corticotypical steroids. Is there a displacement of tube, or there's a recurrent infection? So all this needs to be picturized, told, and then the line of treatment needs to be decided. It's not just home enteral nutrition. What I want to connect is, it's the multidisciplinary team, the nutrition support team, which all of us play a role. Role of caregivers. They are very, the relatives when they see in hospital doing all the 6 steps of hygiene and the moments of wash. But the same things needs to be told to the nurse, reminded that how the environment, if you read a detailed booklet, you will also see the environment, the temperature, whether there are pets around, whether hand hygiene is followed, the equipments, whether you are washing the bags, you're changing the bags, are you changing the feed, or you're just adding the feed to the same bag and topping it with. So these can be the minutest things, but they can have a catastrophic reaction. So we have the caregiver knowledge. And I think having a booklet or having a telephonic call with our caregivers and a team at a regimen will definitely support from the hospital to home enteral nutrition. Nutritional management, what are we feeding? Whether commercial, scientific formulas, yes, there are multiple in the markets, but which one is going to suit? Is it going to be the same? We will use blenderized food. There are a lot of studies in this scope of today's plan. I'm not discussing what is good or bad. We have to see the setup, we have to see the economics, we have to understand the availability and multiple things. A combination can be also worked out. In a single situation for the same patient, we are not going to even have a formulas. It's like, we are using different spices in our kitchen. Similarly, you may need a blend of certain enhancers along with your standard kind of formulas, because we are talking about a micro nutrition. Maybe you need an immunobooster, you need a specified amino acid combination, or there is some kind of allergies, then we have to kind of change the formulation. So it will change, and we are all aware about what is standard, what are disease specific, how do you modify your formulas when there is diarrhea, constipation, whether your sugars are under control, or the patient is having hypoglycemia. So how your feeding regimen can change. So all this needs to be trained as part of our home caregivers in the home enteral nutrition. How much to give, when to give, okay, oral is started, there is some trial which is going on. Are they recording it? Then in follow-up we monitor it, and then we pass on, take a typical discussion, and maybe even if practically we may not be able to go, but I think with these days a telephonic or a video call conferencing works if a personal visit cannot be possible. Okay, now I next go to the studies, and did we think, have we done this homework? In my setup I have not done. Frankly speaking, I'm finding it very, very interesting that home enteral nutrition, about hundreds of patients are on tubes, 30 get discharged, 10 come for follow-up, but what happens to them next? Or they get readmitted, or they go for radiation chemo, we are really not. So multiple studies, this particular study is from 2018 to 1600 patients on home enteral nutrition, where 44.2% could achieve their enteral goals and they could have an oral autonomy. But in conclusion, it was very, very clear that of the patient, at least more than 50% had some complications related to tube, whether it is intolerance, the electrolyte shifts, or any other. So this cannot be missed out. So this is the part of the study. Another study which talks about home enteral, this is very interesting. I just thought I will put it that home enteral nutrition in malnourished post-bariatric surgery patient. The role and the goal is achieved, but they are malnourished and maybe they need a top-up of proteins and electrolyte balance, and they had successful results in, by giving the enteral nutrition. There's an interesting study which talks about the home enteral nutrition when planned using indirect calorimetry. When we are doing a predictive equation calculation, but as I said that it's not going to be the same for same patient. And we know in long run, the patient's nutrition requirement goes to 110% of his whatever we have planned. So if you are planning a typical of 20, 25, 30, the patient, what we see is losing weight, he's losing muscle mass grossly. But when we have given a home enteral nutrition where it's guided with indirect calorimetry, which is what the study says in the latest study of 2024, they help to improve the albumin levels, and the total energy expenditure was also monitored, and indirect calorimetry helped to optimize the nutrition care in the patients. So this is about the various research and evidences what we had to say. So several other studies. Now, I just thought, to summarize, before summarizing, we are just talking that home care needs to be done, but what are we doing? So I thought about one of my distant relative who is not in this city, very far off, and they would talk to us. And then, so this patient, when he had head and neck cancer detected, carcinoma of tongue, he underwent the surgery, and then the line of treatment, chemotherapy and radiation, overweight patient, now in the normal BMI, but the recurrence of the disease was there. There was a redo surgeries, and the home enteral nutrition was given. First, there is no acceptance, there are errors, but when the recurrence happened, the family was more concerned, and then they approached a proper, good hospital where, the home enteral nutrition part became very, very much strengthened. He had a G-tube in place. This patient, over 5 years, is also having a healthy, normal life. He goes to his friends for parties. He uses his PEG feed. He is working from home, and that is where somewhere quality of life is there in spite of the recurrent disease of head and neck cancer. The other study is related to a lady who's a 60-year-old who had a stroke, hemiparesis, meningioma, and had a lower body weight, and the BMI was on the lower side, which still deteriorated. They did not have much of help, so they relocated from a smaller city to the city where they had a doctor family, and then they used the setup where, the nursing homes, they could communicate. And then the whole line of treatment changed because they found there were recurrent readmissions and the patient was not getting better. And nobody likes to lose the dear one. So this is how the calorie individualized planning was done, and the lady is doing well because she needs also the active physiotherapy, and with the bolus fluid, she's able to manage her own quality of life. So these are the two studies, what I would like to put it in parentheses. Now there's something interesting from our critical care nutrition, but yes, it is a critical care. It's a commercial kind of a statement where global enteral nutrition, I think all our eyes will pop out and see that, the computed annual growth rate of enteral nutrition market is increasing 7%, that is expected till 2027. And you know why? We all know why, because there's prevalence of the chronic ill diseases, the longevity is increasing, but so is the diseases are increasing, whether it is the geriatric population, the strokes coming at an earlier age or what. So market is growing, but my concern of putting it over here is that these will be the people who will need the home care enteral nutrition more and this kind of a knowledge. So before I summarize, I thank the SAPN and the entire organizing committee for putting this entire event and bringing us all together so we can empower us, our team and the support group to have a better understanding and helping out to our patients. So thank you very much, and I summarize that let's learn with careful planning, training, coordination. There's much more to learn, practice, and have such kind of conferences or small sessions where you can kind of have a better control, learning and understanding of our patient home care. Thank you very much.
Thank you so much, Varsha. Excellent deliberation, and thank you for sharing the SOPs for the HEN, which is the requirement at this point of time. And as rightly said, I think the few key takeaways which I will just like to summarize. One, of course, a multidisciplinary team is very, very important. And of course, the dietitian or the nutritionist is the core to that. So that's very, very important. Second is, of course, I think because, as you rightly said, that because of the high demand, both in the terms of financial as well as, of course, lack of space in the hospital, home enteral nutrition or home care is really increasing exponentially, especially we get to see it in our corporate setups a lot. And as I was just discussing with you, most of the hospitals, we do have our home care system. Like we have our home care system where we have 3 dietitians who are part of the multidisciplinary team who visits our patients on a weekly basis. So I think this is the call of the hour, and dietitians play a very, very important role, not only in providing the nutrition, but also taking care in terms of educating the entire people who are looking after the patients at home, and also in terms of educating to how to use the enteral nutrition at home. So it's a very, very complex but very interesting, and I think a lot of dietitians need to progress from hospitals to probably taking home care. So thank you so much. Do we have any questions?
Wonderful presentation, ma'am. I would like to add certain points to the already comprehensive presentation. One is that the home-based enteral nutrition, the preparation for it should start very early when the patient is in ward. And the first thing we should ensure is that we empower the patient and we empower the attendant. Because like I'm in government setup, I'm in AIMS. So most of our patients are from rural background. And as you will agree with me that most of them are most of the times are not very comfortable with idea of taking care of a tube coming out of a patient. So they're very scared. So one, that anxiety has to be elevated. Secondly, we have to ensure that we talk to them in their own terms, the language they understand. English is not going to suffice. Sometimes pure Hindi, sometimes even try and speak to them in their own dialect or something. Secondly, as you said, there are booklets which are given to the patient. So these booklets have to be in their own language, and these booklets have to have a pictographical representation of what all can go wrong. See, if everything is going right, nobody is bothered. But as soon as something goes wrong, the caretaker goes in a panic mode, and then the nutrition entirely stops. And as you said, they live 200, 300 kilometers. Sometimes they take too much time to come. So we should ensure that these things are taken care of, because once the patient is away, I don't think it is practically possible for a dietitian or a nurse or a doctor to visit a remote village that is 200, 250 kilometers away. So that is the kind of empowerment we should be thinking about well within advance. Thank you.
Thank you.
Any questions from the audience? Thank you.
For our next talk, I would like to invite Dr. Malika Udagedra. She is a board-certified consultant nutrition physician at the Ministry of Health, Sri Lanka. She holds an MD in clinical nutrition and MSc in human nutrition from University of Colombo, and has served as clinical nutrition fellow at Toronto General Hospital Department of Gastroenterology, University of Toronto, and has gained her experience at Princess Margaret Cancer Center during her overseas training. So I would like to invite you for the next talk.
Thank you, Shilpa. Good morning, everyone. I'm Malika. I'm delighted to join you all today from Sri Lanka. My topic is parenteral nutrition beyond the hospital. Basically, I'll be talking about home parenteral nutrition, which is a new concept to all of us. I have no disclosures. These are my learning objectives. By the end of this talk, you'll be able to know about the review the home PN roadmap, which should be interesting to know the little bit of history, and also the initial steps, indications, discharge plans, caregiver education of home PN patients, and also interprofessional collaborations and sustainability, which is very important. This slide highlights key milestones in the history of home PN. So this first successful home parenteral nutrition infusion started in the globe is in 1960. So these two images are very interesting images. The left side, the Washington Medical School, that is Professor Scribner, who initiated the home PN first time in Washington Medical School. And the next slide image is University of Toronto, which is very close to myself. They initiated a successful home PN patient who discharged for the first time in the history and who lived 20 years later. So that is in 1968. So just think a moment, the world initiated home PN in 1968 or 1960s, but still as a region, there's a long way to go where we can initiate these things in the region with all our efforts. This is Dr. Belvin Scribner, as I told you. He is a nephrologist by profession. He initiated actually the home hemodialysis kit. So he used the same concept to initiate the home PN, this pump. So that's the reason that he invented this at the University of Washington, but it was very cumbersome at that point. But he used this for a patient who had a short bowel syndrome after a desmoid tumor and had many complications, who could not survive with enteral feeds. And then he invented this pump, and then patient lived for years, but ultimately, patient passed away after a transplant. So after all, the artificial gut system was developed by Professor Gigi Boy. He's a gastroenterologist at University of Toronto. This novel artificial gut system, this pump infused nocturnal delivery of home PN. This patient lived for more than 20 years. This is a very improved pump where they used compressed air. Furthermore, the early home PN patients, they use this type of portable ambulatory pumps. The day by day, year by year, this home PN system was evolved and to a current status. These are some of the other pictures that I thought of just sharing with you for your interest. Yes. Where the excellence meets compassion, the Toronto General Hospital, in Canada, there are 9 home parenteral nutrition systems, and I was trained at the Toronto General Hospital, which is one of the largest home PN center. And some of my team, as we all talked throughout in the morning, the nutrition support team is a very important. Yes, it is. So for the home EN, even palliative, everyone, we need the multidisciplinary team. Likewise, we had a very nice team at the unit. This slide shows the multidisciplinary team behind the home PN program in my unit, and which is comprised of physicians, we have fellows and specialists and dietitians and pharmacists, and we had some set of objectives of all home PN patients. Basically, we evaluate, we manage these patients, we monitor, and also individualize TPN plans and prevent PN-related complications, organize home care, and so on. I'll talk about that later. Yep. These are some of the evidences. We'll have a closer look at this. What is the evidence? Basically, all these systematic reviews shows if you have a nutrition support team, the outcome is better. Whether it is TPN, whether it is home PN, it's the same. Your infection rate, your mortality rate, and your comorbidities, metabolic derangements, complications, everything is very low if you compared the nutrition support team versus no nutrition support team. Yeah, this is my team. Apart from above categories, we also involve, discuss with the primary healthcare physicians, specialists, and the home care team. With our home PN team in the hospital, we also liaise with other team members. This is just the timeline. When we get a referral, we do patient assessment, and we do home PN initiation, and prepare the home parental nutrition and do the monitoring as a basic sketch. I just take you through my home TPN program in my unit. Basically, we divide this into two parts. The left side, you can see it's the inpatient, and the right side it's the outpatient. So inpatient, we get referrals from Toronto General and Princess Margaret, that's a cancer hospital. Whenever we get a referral, we do the patient assessment, and we finally do the MDT assessment. So likewise, we are getting referrals from as an outpatient. Likewise, transfer of sick kids, that is a hospital for children. When the children are taken to the adult hospital, that's a transition, we get the referrals from them, as well as Ontario Hospitals community healthcare physicians. Any primary physician in the vicinity or the community, if they think this patient needs home PN, there is no functional gut, and if the patient is severely malnourished, they can directly send a referral to us too. Then we do the patient assessment in our nutrition clinic and the telehealth. All the outpatients are being seen in our clinic weekly, but inpatient assessments, like a normal consultation, we go to the patient and we assess the patient, and then we discuss in the multidisciplinary team discussion, which happens weekly, and we take the decision whether this patient is eligible for PN or not. So we optimize macros, micros, fluids, and electrolytes. All the team is involved, as I mentioned to you earlier, and we prepare the home PN. When we prepare this home PN, where the patient is already in the hospital, there are 4 things that we have to consider. One is we finalize the TPN prescription, diet, plus enteral nutrition if the patient is on. We just qualify the management and finalize the prescription. The other one is home TPN teaching. That takes days and days. That depends on the patient's level of education, caregiver burden, and everything. And also we send home PN prescriptions to Ontario Medical Service. That is that's a service who issues home PN. And finally, we arrange home care services and arrange delivery of these TPN equipment supplied to the patient's home. Then, of course, we have to do the monitoring. We do regular blood work, we do clinic follow-ups, and open patient MDT communications. And then even the monitoring, it has 4 parts. We have to assess the patient's nutritional efficacy, body weight and anthropometry, sometimes do the body composition and energy and protein delivery, whether the tolerance of fees and everything. And then tolerance of PN. Then patient caregiver management of infusion catheters, and also finally the quality of life. As Madam Jayati mentioned, it's very important. We really take a very important role on assessing patients' quality of care, quality of life, as well as caregivers' quality of life too. So then finally, we do the reassessment and discuss and decide whether we continue the TPN or whether we have to adjust the TPN or whether to stop TPN or home PN. This is evaluating the transitioning patients from hospital to home, that is within 1 to 2 weeks. Once we finalize the home PN prescription, we again keep these patients for 1 or 2 weeks in the ward, and we do the home PN thing and cycling and everything. Finally, we discharge this patient for the home care. Apart from this team, we need community connections like home care services, laboratories, telehealth, and OMS. And these are the other resources where we provide to our patients. We have support clinic website. Even you all can just download this manual, home care manual. It has everything, how to wash your hands, how to take care of your lines and everything. And also we have home PN support groups that is linked to the Canadian Parenteral Nutrition Association. Then regarding the formulas, we basically almost 100% of home PN is customized, and it's 3-in-1 formulas. We have we add electrolytes and trace elements, additives and multis, and also common other drugs are also being added to this PN, like octreotides, heparin, vitamin K, ranitidine, that depends on the patient. And the delivery stock is just for 1 week. After the 1 week, we have to deliver another set of home PN. So these are one of the practical considerations for patients going on home PN. These are the aims, basically to improve the quality of life, improve the patient's fitness for surgery if they are, and to correct hydrations, correct malassimilations, vomiting, diarrhea. And these are the common indications for home PN in my center. Basically 60% is short bowel. And also radiation enteritis, severe pancreatitis, refractory to enteral, and GI motility disorders, high output fistulas, and ischemia, bowel obstructions, prolonged bowel rest, and bariatric complications. And I'll take you through one case scenario just for your interest. This is a patient I had, a 45-year-old male. He had recurrent colonic adenocarcinomas, previous resections, and small bowel obstructions, who is with a loop ileostomy. He had, on July 17th, he came to the emergency for ischemic bowel and with obstructions and from a distant community hospital. And there is small bowel resections, which is the current bowel anatomy is left with the jejunostomy, 80 to 90 centimeters from ligament of Treitz. So he was discharged with home care. On 26th of July, after 9 days, this patient readmitted to the local hospital with the dehydration and AKI. And fluid resuscitation was done. Home IV hydration is initiated at that point. But still, this patient had a struggle with ongoing high output, 6 to 8 liters of jejunostomy output, deconditioning, poor quality of life, and weight loss. Then the patient, since May, that is assisted dying is legalized in Canada, the patient requested assistant in dying. But what is missing in this case approach? We have to recognize this patient is having the short bowel, and this patient need home PN, and there should be a care plan for short bowel and consultation with support team. Also, we have to give a discharge plan regarding short bowel syndrome management and monitoring. These are missing. Yes, they initiated that, but still, 10th of August, this patient referred to the surgery at an academic center. So the surgical team initiated multiple drugs, loperamides, codeines, and then cholestyramines, octreotides, pantoprazole, many drugs. And still the stoma output was 8 liters. At home, it was sometimes around 10 to 16 liters. The patient was still continuing to lose weight. What is still missing in this case? The need for home PN. The patient is having just 82 centimeters of jejunostomy, and they consult nutrition support team for us, anti-PN and short bowel syndrome management. So at that point, patient had 13% of weight loss with a BMI of 22. And he required 2100 calories a day with 90 grams of proteins. Volume and electrolytes were adjusted, and physicians, we fellows, we managed short bowel, and with the dietitians, of course, prescribed TPN with this support team. We started TPN slowly with the 50% initially, and then with the thiamine cover and all these multidisciplinary approach was initiated. So now what is a care plan for this type of a patient that we do? One is the physician's role or the fellow's role. We do the consultations, we do the prescription, we coordinate the care with the support team and optimize medications. The dietitians, they also review the diet and the TPN prescriptions with us, and they limit fluid limits and anti-dumping sort of a measures, and oral rehydration solutions. We have homemade, home-prepared solutions that they initiated those stuff. And the pharmacist, they optimize drugs. Sometimes this polypharmacy, unnecessary drugs, they reduce the drugs, and the nurse supporting team and optimize. Finally, we initiated this case, and the caregiver has a very good role. We started teaching about aseptic principles, GI and vascular anatomy, a little bit of basics, and complications of PN, underlying diseases, new skills to manage this home pain. Those teaching we do even when the patient is in the hospital. So we give 3 sessions and 5 sessions from the nurses and 3 sessions from the fellows to the caregivers. So this is the reason why this programs are successful is it's due to this MDT, NST, and this caregiver collaborations. So what are the other practical considerations for transitioning these patients from then hospital to home? Yes, we have to manage skills. We have to improve the patient's caregiver skill on hand washing, sterile techniques, dressing changes, how to discontinue, how to connect to TPN machine, and how to flush the line, how to manage the pump, and how to basic troubleshooting activities, and also the polypharmacy, how to manage their drugs, and how to timing of drugs is also very important. And to manage these patients, before that, we assess the physical fitness of these patients, and also the vision, hearings, dexterity, and psychological motivations, and home environment, and social support, and everything. This mainly done by our nursing team, but we also assess and whether then only we approve this patient to be eligible for home PN. Yeah, this is nurse's role, and basically she involves at any point of this role where I don't need to repeatedly mention. This is the trajectory. We started PN, we increase with the PN, we increase little bit of PN gradually, then stoma output came down, then we adjusted electrolytes, and further the patient, we started PN cycling, and stoma output was reduced further, and then we finalized the prescription and we sent the patient home on August 11th, and with 3 liters of PN with 1 liter of normal saline, and patient returned to work with a desk job after a few weeks. These are some of the discharge criteria that we also go through once we discharge these patients from the clinic. And also the other practical considerations is like follow-up is very, very important. Even we ourselves, we do the follow-up call every weekly for first 6 months, and then monthly. It's follow-up calls. The patient is getting 3 follow-up calls per month from the team, 1 from the pharmacist, 1 from the clinical fellow, 1 from the nursing team. Likewise, we have it's sort of a family. We know about each and every patient very well. And this is also the same thing. We have our specific protocols for each and everything. If you go to the website, you can just download. We have all the protocols which is uploaded. And these patients, we are keeping very good relation with every patient, with the community dietitians, the stoma care people, social workers, and psychiatrists, and we work as a team. just for your interest, I thought of just sharing my patient's yeah. That's real patients, but the image is different. These are the patients' real stories that they come up with our conference. And yes, home PN is life to someone. And I think as a region, we can do a lot of things. They define this home PN as like family. Some people say the home PN is joy, uncertainty, fear, alive, freedom, happiness, and everything. So final slide. This is a flower, nice flower, which is blooming deserts in California, Arizona, and Nevada. This name means desert mariposa lily, which blooms after a spring rain, and but it still blooms, like even in deserts. So just as flowers, they bloom in these deserts, hope and our innovations, they can flourish even in the most challenging conditions. I apply this to the region, the SAPEN, and also all the SAARC countries. This is doable. Even we can like get together and we can do this. We can serve people. There is a set of patients where we can initiate this home PN and save lives, and also to save the nation and the region. So it's a necessity. So thank you very much. I would like to take one moment to thank SAPEN Congress and IUPN chapter, the Delhi chapter, and all the pioneers and the participants. And I'm so fortunate to come here. Thank you very much for all your welcoming and all the gestures. Thank you so much. Any questions?
Thank you, Dr. Mallika. It was wonderful deliberation. You took us through the protocols. These are, like, as you said, 60% of short bowel syndrome, also intestinal failure, certain GI cancers. These are very long-term chronic case scenarios which need nutritional support, and HPN is a way in which you can provide not only nutrition support, but independence, as you showed in your receding slides, that it is very, very necessary. They feel empowered, they are taken care of. Multidisciplinary approach is the goal, and every multidisciplinary team, the whole aim is healthcare and to support the patient to the fullest. You showed us, and as Sir said, in how in EN also you need to prepare the patient, you need to prepare, you showed us the entire community that needs to be prepared to take care, and further this management. And as you rightly said, in SAARC in India, though it's not a very common practice, because so much of not just the protocols, but this much of team coordination, yes, how much we can provide to different strata of patient care that we are looking at, but it is definitely a way where we need to think is doable, which you beautifully showed, and is one of the ways that is coming up as the need of our. And I would like to take this opportunity to remind all of you here that in the upcoming ICNC, we have as the pre-Congress, the ISPEN LLL, and we have taken home parenteral nutrition care in adults as one of the course modules. So we need to train ourselves to be able to be the part of the multidisciplinary team that takes care of patients. With that, I would like to ask if there are any questions for Dr. Mallika. Thank you. I think you explained so beautifully that I think everybody in the audience is thinking how to use it in their practice.
After that wonderful session, it is now my privilege and honor to we welcome on stage Professor N.R. Das sir from Department of GI Surgery and Liver Transplantation, AIIMS, who is also an organizer of this conference. He will be covering two topics. One is surgical routes and summary of EN, and another one is best practices in EN and PN catheter management and complications. These were the topic assigned to Dr. P.K. Mishra and Dr. Karthik, who unfortunately could not be with us today. Over to you, sir.
Am I audible? Yeah. Thank you, Dr. Ankit and the chairpersons. I am here to represent these two persons. One is on my left side is actually my mouse's son, my mentor, and but both of these guys are from Maulana Azad. He is the first batch of GI surgery, Maulana Azad, and he's the last batch of our institute, recently passed out. He is in Rajiv Gandhi, and today morning I came to know that he was the topper in 2022 NEET SS. So Dr. Mishra is a pioneer in one of the ways to put a catheter into the abdomen, that is PEG, you must have seen, but he's been doing since last 20 years in Sant Paramanand Hospital, mostly to the neurologically deprived patients. And his unique method takes only 10 plus minutes, which to other people takes at least half to 1 hour. So he's expert in this, so you'll have his video, and most of the slides they had given to me. I myself was unable to understand properly, so I made some of my own slides. I just finished at 10 a.m. today, and I'll just mix up this. The topic was the innovative way to put a catheter. That's a new method, relatively new, and the other one is a catheter care, which is very important in my opinion, and I'll establish how important the catheter care is. So how do we decide as a clinician how to put which type of catheter? The best way, of course, is the mouth. If it is working and rest of the GI tract is working, nothing better than a mouth feeding, that all of us know. And if there is something problematic here in the pharynx, you cannot put a tube here, you can only put a tube here. The next choice is, of course, the stomach. And we very rarely put a tube here into the duodenum. There is bile, pancreatic juice coming out. If there is a leak, there is a very difficult situation. So we never encourage a tube duodenostomy, though at times we do it. And then this is the duodenojejunal flexor. If you do it beyond this, if you put a catheter and feed, the pancreas will not be stimulated. So the pancreatic juice will not come out much more. So in cases of pancreatic problem, particularly the pancreatitis, we always prefer to do a feeding beyond the pylorus, beyond the DJ flexor, so at least 20 to 30 centimeter beyond. And the stomach can be approached by a nasogastric tube, or a open gastrostomy, gastric tube, or a percutaneous method, which I will be going to show on his behalf. And then this one also, even endoscopically, you can do a jejunostomy also, operation also, jejunostomy, which you saw yesterday, madam was showing. And this is how we decide. If there is a benign lesion of the esophagus, mostly we do not advise a stenting, because the stent has its own complications. So if it is a malignancy one, we mostly advise stenting. And stenting also helps in giving chemoradiotherapy, chemotherapy to maintain the nutrition. Otherwise, after chemoradiotherapy, sometimes fistulation occurs, sometimes stricture occurs, they may not be able to take. So this is the basic of deciding how to have an enteral access. If no enteral access is possible, then we go for a total parenteral nutrition. If the enteral feeding is not enough, if the person is not taking properly, or is unable to eat, and his GI tract is not functioning properly, then of course we go for a total parenteral nutrition. So what is this PEG technique, percutaneous endoscopic gastrostomy technique? So one, we know that by surgery you can do it very easily, put a tube here and take it out, and that functions as a tube gastrostomy. So how this one PEG technique, what is being done? First you put an endoscope through this, and then push the endoscope, push the stomach towards the abdominal wall and illuminate. You can see where the stomach is opposing the abdominal wall. Then from outside, you put make a hole, put a guide wire or the stylet, and then pass a catheter through that. And there is a knob here, and there is another knob here. So both of them are compressed to fix the tube, and the tube remains inside. This is how it is being done. So this is the video in his voice. So this is a 9-minute video. I'll cut short a little bit. I have the video separately you can use. No, it's one. Continue.
I'm present to do this myself. Due to some misunderstanding, I'm not in Delhi, but Dr. Das has very kindly accepted to present it on my behalf. As I was initially asked to make a video presentation on PEG, it forms the bulk of this presentation, and some material has been added later to cover for the change of topic. So in this video, we will see the percutaneous endoscopic gastrostomy being performed following the steps as shown in the slide. There are two patients in this video. The first is a patient of ALS on a ventilator, and the procedure was done in the ICU. And the second is a patient of CVA. The procedure was done in the endoscopy room. First, we perform a full upper GI endoscopy looking at the esophagus, the stomach, and the duodenum. Then we come back into the stomach and locate an appropriate area on the anterior wall. The lights are then dimmed, and we look for transillumination on the abdominal wall skin. This is very important to avoid injuries to the liver or colon. The transilluminated area is also jabbed with the finger while observing the impulse on endoscopy. The chosen point is marked on the skin as here with a plastic needle cover. There are many kits in the market. This one from Cook Medical is the one we use, and the tube size is 24 French. The parts of the tube are, starting from the right side of the screen, the inner bolster like a cup, which lies inside the stomach and prevents the tube from falling out. Then there is the bumper, which is a disc that sits on the skin and fixes the tube to it. Between the inside bolster and the outside bumper, the stomach wall is drawn up to the peritoneum to prevent any leakage. The kit has everything required to perform the procedure. I should say had everything, because the newer kits lack some items which are usually readily available in hospitals, and this is done to cut the cost of the kit. Here the abdominal wall is being prepped with chlorhexidine swabs around the previously marked site. Then the sterile drape is applied. Here is the mark on the abdominal skin made previously. Local anesthetic, which is another item missing from the newer kits, is injected at the designated part and deeply instilled up to the stomach. A small incision, slightly bigger than the size of the tube, is made. A needle with a cannula is inserted. A blue-colored looped wire is inserted through the cannula. Meanwhile, the cannula has been caught with a snare by the endoscopist. When the looped wire comes inside the stomach, the snare is slid over it and closed to catch it tightly. The scope and the wire are withdrawn together and brought outside through the mouth. The tube, which also has a wire loop, is fixed to the blue loop by passing the bolster through both the loops and pulling them apart. The tube is lubricated, and by pulling the wire from the outside, it is drawn through the esophagus in a reverse manner through the stomach until the bolster goes up. This is observed by the endoscopist for correct positioning. The tube is pulled to snugly impact the bolster against the abdominal wall. The centimeter mark next to the skin is noted, and this should not change much later during the use of the tube. It's usually at about 2 to 4 centimeters, depending on the thickness of the abdominal wall. The tube is then detached from the blue wire by cutting through it. The outside bumper is slid over the tube and approximated to the skin. The clamp is slid over the tube, which is then cut at an appropriate length, and the feeding adapter attached. This has channels for feeding and medication or washing. The whole procedure takes 10 to 15 minutes. This patient care manual comes with the kit and is handed over to the relatives. It has the patient's data, batch number of the tube used, and the endoscopist's telephone number. It also has detailed information on care of the tube and feeding instructions, which should be read by the caregiver. Sometimes, if a patient doesn't like a long tube, a low-profile adapter can be used to replace it after the track has matured, but such requests are not common. After tube blockage, the commonest complication is dislodgement of the tube. This patient returned a month after the tube was placed and demonstrates the commonest cause of displacement. Despite complete instructions, caregivers continue to stuff gauze pieces under the bumper, perhaps because sometimes there is a little secretion around the tube. Over a period of time, this gradually lifts the tube out, leading to what is known as the buried bumper syndrome. This can also result from too tight a position of the external bumper or by strongly pulling.
So I'll change here because the rest of the videos are not there. He was just telling what are the complications. So patient education for any type of tube or catheter they are using is so important. I've seen in the periphery just to change a feeding jejunostomy tube, people are demanding 500,000 rupees. We teach our patients very well. We teach them about the complications, the problems, how to know that the tube is not in place properly or so. They are all managing well and I think saving a lot of money. Now, where we not to use the enteral feed is to see if the bowel is inflamed very bad or there is peritonitis. You can see here there's a obstruction features, the huge gas distension of the bowel. This is where the stomach is, and there is evidence of a perforation. All these are contraindications to putting this type of to practice. Whenever you watch or go to see a patient in the ward, the first thing to note is the Ryle's tube, the markers are there. If the tube is well inside the stomach, the second mark has to be near the nose. That's what you need to see. You aspirate and see if it is. You can see this is the stomach. This is the stomach bubble, and the tube has gone into the C loop of the duodenum. There, if you aspirate, a lot of bile will come out, and all the time the nasal gastric output will be very high. So you always first time check the X-ray. Where is the tip of the? So most of the time we send the patient to X-ray, then forget to follow it up. That is all of us our duty to see where the tube is and point it out. Ideally, the tip should have been here somewhere. The examination starts from the nose itself. If it is remaining for a long time, you see here the half of the nose is completely covered with plaster. Sometimes you will find both the nose are practically covered and patient will be breathing through mouth. And this is a very common problem. The tube is lying straightway like this, or it is fixed to the bed seat or fixed to his dresses, and patient remains like this all the time fixed. So this is called pithing of the patient. Patient can't move his head on either side. So this is the best way to fix. Another problem, particularly in ladies, we have to resort to plastic surgery because they are so tightly fixed to the alarnagy. This has very little, the cartilage has little circulation, so there would be scarring, cut marks. So very careful whether they are very tightly fixed. So this is the most ideal way. And again, fix this one just behind the ear for double fixation, so patient can move his head either side. And routinely we apply boroglycerin to these areas, regular mouth gargle. Sometimes they complain of pain in ear. It's because of the eustachian tube blockade or inflammation, regular gargling. Apply ghee if it is not there, or mouth paints, that would help. If the mouth looks whitish, there could be fungal infection, very common, and they should be treated. This is a normal case of nasojejunal tube. You can see stomach, the duodenum, and it has gone in beyond the DJ flexor. So this is a normal position. There are many abnormal positions you must watch. One of these is one of my publications in Anesthesia Journal, where it has gone into the bronchus actually. And one feed was already on with this one in the bronchus. This is another one where after the tube has been pushed and then it was pulled, there was a knotting inside and nothing was going inside. So it was one of the blockades. And there are many other complications. Here in India, I don't know about the SAARC countries, in many patients we use Foley's catheter as a replacement for the feeding jejunostomy tubes. And we inflate about 5 to 10 ml, but we have reported very serious complications in 13 patients where in-house the patient attendants used to feed through 3. It has a feeding port, it has a balloon port. This will inflate the balloon. The patient attendant was infusing through the balloon itself, and it burst open, bursting the bowel completely. So there were 13 cases we reported. And migrations, so at times in the morning they find that no tube, we find they are inside the intestine. Ultimately they can pass out through don't worry, if it is not, take an X-ray, if it is not knotted or twisted or it's not stuck, then they can pass out through the motion. Just you have to take another X-ray, next day, don't give any purgative, nothing, carry on normal things and it would come out. If it is not, at times you need to go for endoscopic retrieval or surgery. Not too much of dressing, as I said, very minimal dressing is required. Never ever tell them to apply Dettol to clear Savlon, Dettol, etc. to clear the area. Simple, normal saline, or take a good bath and do a dressing every 3rd or 4th day. Even this is there, even nasoenteral feeding tube can be inserted by the nutritionists or the nurses. This is also there. Now, there are various complications described. Some of them I explained. One you must see for fungal infections, skin excoriations, aspirations, rapid feeding, refeeding syndromes. You all know that. Finally, a word about the total parenteral nutrition catheter. 2 common complications I will describe. One is very important, is catheter care. Every 4th day or through a see-through plaster, see whether there are drops of pus here. It's very common. Or it is redness around it, or redness around the sutures which they have taken. So this should be very clearly cleaned by normal saline. If you apply spirit or Dettol something, they can go into the circulation. So be very careful. Apply Neosporin eye ointment or some very thin bore ointment around it, and plaster is every 3-4 times. Never ever handle with a raw hand. Always use a sterile gloves to use this, because once infection goes through this, 14 days of antibiotic therapy is a must for the patient. One very common problem occurs in ICUs is we do it so frequently, the x-rays are done, we just focus on the lungs, focus on the heart or abdomen, we forget about the catheter. So the TPN catheter is this one. This is the this is the IVC superior vena cava, this is the SBC superior vena cava, and rest of the heart. Sometimes you'll find this one will be going well into this. This is wrong, or if it is very high, it is also wrong. So you have to see that just remains at this level. If it is up or down, the patient may have arrhythmias or other problems which you inform the clinicians immediately. And while this is there for a longer period, you must watch for thrombophlebitis of these areas. If it is tender, redness, immediately inform, and immediately this has to be removed and put in some other sites. Every 10th day, ensure that this is changed. 10 to 14 days, this has to be changed. And same catheters, there are 3 ports. Ensure that the specific port for specific infusion. Never ever draw the blood from the site where you are infusing or infuse the drugs and the feeding or the TPN on the same site. This should not be done. So finally, this is just to change the picture. This is my own gardens. See, tubes and catheter care is an essential for a good feeding for a patient. Now, in the hospital, you can be a part of the team in watching out how to take care of the catheters, catching the complications early. If there's something going wrong, informing the clinicians, you have a very, very vital part in that. More than that, if you are sending the patient home and there is a catheter care needed at home, you must educate the patient. We have a group with our nutritionist of the patients. They used to inform everything going well or not. Every weekly, are they gaining weight or not, and whether their catheter care is being proper, water intake is proper or not. So this is what is important. So to know that, you must know all the complications that are associated with this. There are a huge number of them, but these are the common things which I discussed. Thank you, all of you, and thank you, organizers, for that.
Thank you, sir. Thank you so much for this wonderful presentation. If there are any questions. Thank you. And I very vividly remember, sir, you telling us in our first year about the central line, especially that the line that nourishes should not be the line that harms. And this is what we strive to achieve routinely in our clinical practice. Thank you, sir.
Thank you very much. So on behalf of the organizers, I thank Dr. Das for presenting this one and accepting a memento on behalf of this.
There is a cameraman now.
No photographer for me. Seen what is there. What is it? Thank you.
Thank you so much, sir.
So before we break for the tea, we have 2 important announcements. First is we would like to acknowledge our thanks to our industry partners. So we want to extend our heartfelt gratitude to all our nutrition industry partners for their invaluable support and collaboration for the SAPINCon 2025. I thought if I'll do at the end of the conference, most of us would leave. And that is not the right time to acknowledge their support, which is actually, very, very important for, the contribution which they have done for enriching this academic gathering and inspiring us with their meaningful things which they have displayed and the innovations in the patient care which they have been coming up. So that is the time we need to acknowledge when all of us have been present over here. So thank you for being the integral part for this conference. I would also like to request our national IAPN India President, Mr. Shiv Shankar, to kindly come on the stage.
And I would also like to request Mr. P.C. Vijayakumar also to come on the stage.
Now, I would like to invite anyone from the Freshness Kabi, Sun Pharma, and Dr. Reddy.
One by one.
Okay.
Let Freshness.
Okay. We are thankful to you for the participation and for your support. Next, Sun Pharma. Oh, Sun Pharma team, please come forward. Thank you all for your support. Next one is Dr. Reddy and team. Anyone from Dr. Reddy? No.
Dr. Reddy's is not there?
No. Dr. Reddy and team? No. Now, Hexagon and team? No one is there.
Anybody from Dr. Reddy's?
ये मैम क्या है?
Okay, Novitius?
BTS के. Then Hexagon and team? अच्छा core 11. Next one, core 11. Anyone from core 11?
Yeah, they're there.
Hexagon and team? Okay, please come forward. Okay. Hexagon and team, thank you for your support. Okay. Manish. Okay. Please. And Manish is here from Dr. Reddy's.
Okay, come.
Dr. Reddy. With Dr. Reddy. Yes, please. Body stat. Azura का लिया मैं कोई आया ही नहीं. Anyone from Azura? आगे. इसका Nucigenix. Thank you for your support. Nucigenix and team. Anyone from Nucigenix? Okay.
Green dress. Green bag.
Okay. Thank you for your support. Body stat. Anyone from body stat? Next, in body. He's coming. No, in body is there. But my body stat is in.
Anyone from body stat? Acha, okay.
True Healthy and team. They are coming. No, True Healthy and team. Next one is Mankind Pharma. Okay. Thank you all. Thank you for your support. Shilpa ma'am.
Can I request Dr. Shilpa Verma to be on the stage? It's tomorrow on 3rd of November, but we are celebrating today because she is with us today.
We sing happy birthday to Everyone, I would like to request, kindly be seated. Kindly be seated. Let her cut the cake. We don't want to delay our sessions. We have a break for just 15 minutes, please. Otherwise, we will not break off and we'll continue with the sessions.
Thank you for your support.
ब्रेक नहीं करते हैं ना सेशन क्या है हमारा ऊपर बुलाओ ना उसको सेशन लेगी अपना स्टार्ट करेंगे So we are not breaking for the tea break since we already celebrated. So we'll move on to the next session. For that, I would like to call upon Ms. Binu Bhatia. Kindly be seated.
Good morning, everyone. Good morning, distinguished delegates, esteemed speakers, and colleagues. It gives me great pleasure to welcome you all to this session on Potpuri, which represents the medley of various things. So today we will be discussing on enteral and parenteral nutrition, a topic that lies at the very heart of modern clinical nutrition and critical care. So nutrition is often called the fourth vital sign. It sustains life, supports healing, and shapes recovery. Today, in this Potpuri session, we will explore a blend of insights from the physiological foundations of enteral and parenteral nutrition to cutting-edge approaches in patient management, in pediatrics. Our distinguished speakers will share this expertise and innovations that continue to redefine nutritional therapy. So let's make this an engaging and enriching session for all. Now it's my pleasure to introduce our chairperson to begin with the session, Dr. Patta Radhakrishna. Welcome you, sir. So, Dr. Patta Radhakrishna, Director Surgical Gastroenterology and Access Surgery from Chennai. He is a Chief Admin for the Learning General Surgery FB Group. Dr. Karunesh Kumar. Dr. Karunesh Kumar, Consultant in Pediatric Gastroenterology, Hepatology, Nutrition and Liver Transplantation from Apollo's Children Indraprasth Apollo Hospital, Sarita Vihar, New Delhi. Dr. Anuja Agarwala, ma'am, Founder and Director, Nutrition Foundation of Genetic Disorders, Genetic Metabolic Expert, Personalized Nutrition and Wellness Consultant. She is a country representative of Society for the Study of IEM Dietitian Group and National Vice President of Indian Dietetic Association. Dr. Richa Shukla, registered dietitian with an extensive experience of more than 25 years as a consultant medical nutrition therapist, European ESPN certified dietitian, and she is also Food Map certified dietitian. Dr. Alankar Tiwari, Consultant endocrinologist and diabetologist from Varanasi, Director, Dr. Alankar's Clinic for Diabetes and Endocrine Care, President, IPN Varanasi Chapter. Ms. Charu Dua, Chief Clinical Nutritionist and Diabetes Educator, Amrita Hospital, Faridabad. Ms. Sandhya Pandey, GM and Chief Clinical Nutritionist, Medanta, the Med City, Gurgaon. She is having more than 27 years of experience as clinical nutritionist. On the behalf of organizing committee, I welcome you all for the session. I would like to ask Dr. Patta Radhakrishna to introduce the speakers for the session.
Yeah, good afternoon and welcome to this Pat Pauri session. I have a great pleasure in introducing Dr. Biju Pottekar, a man of very few words and a huge action. Biju is the professor and head of surgical gastroenterology at JIPMO, Pondicherry. He is also the national secretary of the Indian branch of the IHPBA. He is a national EC member of the AMASI and is also a member of the State Organ and Tissue Transplant Organization, SOTO, Government of Puducherry. Member, Expert Committee on Liver Transplantation, Ministry of Health and Family Welfare, Government of India. And also a member of the Expert Committee on Artificial Intelligence, ICMR, and a whole lot of other responsibilities. He rarely stays in Pondicherry. He'll be traveling, attending these meetings all over the country. And without much ado, I'll invite Biju to talk on the topic enteral peritoneal co-therapy, strategies and clinical insights. Biju.
Thanks for inviting me. These are some of the traditional thoughts we carry. Enteral routes always better. Oral route always better than jejunal. Parenteral nutrition has some complications. So we caught up between parenteral versus enteral always. Whenever you take a literature, we always see versus, and the trials are hugely biased based upon that. We also have a mental block of prescribing everything based upon a 24-hour calculations. Okay, these 24 hours are basically for drugs. The metabolism is like that, but it hardly ever applies to nutrition. Okay, so we are trying to artificially fit this 24-hour calculation to nutrition. Nutrition has slow metabolic response. And the course of 1 week, 2 weeks or 3 weeks, a scientific course, we never think of that. And all the trials, because of various reasons, always targeted short-term goals, not long-term goals. Most of the therapies are instituted in trials on 3 weeks or 4 weeks basis, never long-term. But what has been changed in the last 10 years? We understood more about parenteral nutrition. Basically, the understanding about its metabolism and its effects has changed our mental bias against parenteral nutrition. Little bit got changed. We know that this is a parenteral drug directly infused to blood with no control. We have complications. The complications became quite manageable now. So we were very afraid of complications earlier, but now we are not so afraid of complications. We know complications are going to happen, especially infection. So we ended up using high-end antibiotics, especially even to manage complications of parenteral nutrition. Also peripheral nutrition came into picture. So we started living with complications of parenteral nutrition because of the extensive nutritional effects it gives. So a decade back, we used to put lot of contraindications to parenteral nutrition, and most of the contraindications currently we are trying to change into from absolute to relative contraindication. So if you ask today what is the absolute contraindication for a parenteral nutrition, we can practically say it is almost nil. Okay. Practically there is no absolute contraindication. So that is the context in which you are trying to put parenteral nutrition exactly in the same way as enteral nutrition. We are not afraid to give enteral nutrition. So as of today, please do not be afraid to give parenteral nutrition as well. This is a conceptual change we have to inculcate. And when you think about enteral versus parenteral co-therapy, what you essentially used to think was you had to stop one to start the other. But that is not the case. Our biblical word is nutrition is a must and root is secondary. So irrespective of the root, nutrition has to go. So how it is given, you can give it simultaneously very well. You can also give it sequentially, one after another. This sequential can be on an hourly basis and a day-to-day basis, as well as on a weekly basis. So you have a simultaneous sequential, and also some patients belong to EN dominant therapy. So you know some patients who have a FJ tube or other tubes, you decide that they should be on primarily on enteral nutrition. We need some catch-up nutrition or gap nutrition, supplement with PN, and the other way also. Some patients are actually on enteral nutrition predominantly, you can also supplement on parenteral nutrition. So why this demand of co-therapy is coming now? Now the treatment, you can't wait for treatment. Okay. The treatment is time now. Let us say cancer. The cancer, you have so many therapies are going on. If it is not executed on time, the benefit of all your effort goes waste. So you have some timeline. So within that timeline, like how you treat infections with antibiotic, nutritional therapy has to be executed. And when you put the has to be word, your therapy route becomes secondary. That is how the advantage of parenteral nutrition comes. So timelines of therapies are important. We talk about prehabilitation and post-habilitation. As of today, at least in my department, we started using parenteral nutrition as part of prehabilitation protocol. Okay. So what is the meaning of this? You want to subject this patient for chemotherapy before surgery. The oncologist will tell you that he is not fit for chemotherapy now nutritionally. But to execute that chemotherapy, we have only 3 weeks, make him fit. In that scenario, you can always add a parenteral nutrition therapy. We have patients where we never resorted even to FJ, completely put on parenteral therapy, subjected the patient for neoadjuvant therapy, did surgery, and patient went on well. Enteral nutrition may take time, parenteral nutrition may not take time. So as I said earlier, indications for TPN became very, very relative. So in that situation, you can always add a oral addition. We were talking about a patient who was taking on oral, you are adding parenteral nutrition. Now you imagine the scenario of the other way. You have a patient with a relative intestinal obstruction. You have a patient who is not tolerating, little bit moderate amount of gastric residual volume coming. In that patient, you can always infuse some form of oral therapy. So an ideal patient will be receiving some form of oral therapy and some form of enteral therapy, which is a very stable, nutritionally very stable scenario. So why patients with cancers are very important? Because now we had a concept of something called a multidisciplinary therapy, where a single patient is receiving chemotherapy or radiotherapy before surgery and after surgery also. So surgery comes in the middle. So you have a neoadjuvant therapy, surgery and adjuvant therapy. All these 3 you need a nutritional balancing. So now you plan nutritional balancing. This therapy will go for 3 months, nutritional balancing for 6 weeks. We are hitting at 4.5 months, which is not practical in most of the cancers. So an intense nutritional therapy before surgery is a must now in all these patients. Hence, as I told, at least some of us are resorted to parenteral preoperative nutrition therapy to execute a chemotherapy before surgery. So adding some EN or PN is always beneficial despite the so-called absolute contraindication for enteral therapy, which became relative contraindication in this era. So gut might be available but compromised, and this patient can be managed with an added PN, situations like paralysis, obstruction, bypass bowel, and even in short bowel syndrome. So for example, currently we have a patient where 140 centimeter bowel resected, high jejunal output. Despite all the measures, we know that the jejunal output will come down. But how will you manage the initial 2 weeks? So, day 1 onwards, we started on parenteral nutrition. Manage him on parenteral nutrition. He will have infection, we know. That infection can be managed with antibiotics. Why it is important? Because to maintain if you don't start nutrition parenterally in a patient who is not taking orally in the beginning, what is going to happen to the gut? If you don't maintain nutritional integrity, when the patient is otherwise ready for an enteral nutrition, his intestinal mucosal barriers might have atrophied by that time. Okay. This is not related to oral feeding. If you don't maintain a metabolic nutritional balance within the bloodstream, his intestinal barrier function will go. So, when he is ready to receive the oral nutrition, that time the absorption will not be there. That is why to maintain the integrity also you need to start on parenteral nutrition early. And nutrient loss also you have to replace. So, we have a real bedside problems like prescription delivery mismatch, okay, especially in oral nutrition. Parenteral nutrition can always measure the prescription delivery mismatch. So, when you have a co-therapy giving both, you will have nutritional problems, so will have difficulty how to attribute the problems to which therapy and how to wean in what proportion. This is a real problems we encounter. So, in co-therapy, advanced enteral, what you want to do finally is the patient has to go back to complete enteral therapy. That is your aim. So, advanced enteral feeding gradually as per absorptive capacity, supplement PN, continuous feeding and avoid deficit based on a 72-hour calculation. Why this? We at least follow the 72-hour, not 24-hour, because 24-hour if you put calculation, lot of catch-up nutrition will develop. So, you again prescribe for next 24 hours, again catch-up develop. So, instead of that we use a 72-hour formulation and 72-hour therapy, and EN therapy sometimes plan won't meet overall weekly target. In that case you can always supplement with the parenteral nutrition therapy, and this is important because some of the critical therapies like as I told chemotherapy and surgery has to be initiated in a very time bound manner. And another advantage is now we know that greater emphasis is given to micronutrients as well. So, simply feeding on either enteral therapy or parenteral therapy is not enough. That is why the mixed approach always prefers now, because that is the only way to fulfill all the components of macro and micronutrients. And we have some slow evidence emerging, especially on the micronutrient side. If you give a co-therapy, it gives a very good advantage. So, peripheral, we were afraid to do something and give something to the central lines. That was one of the worry. Now, we have peripheral parenteral nutrition way out. We have long catheters going from the cubital vein directly to the near the superior vena cava. So, you have a long access, but the puncture site will be quite low. So, it will reduce the infection. The sterility measures are gone in a very exponential improvement way. So, you have less central line related infection. So, when you give a transition to full enteral feeding from co-therapy, so now this patient is receiving enteral as well as parenteral nutrition. We know our aim is to convert to complete enteral. It has to be really slow, it has to be reduced to really very slow rates. Never be in a hurry to stop TPN on a fine day morning. Okay. Why? Because now we have no reason not to taper TPN. We practically hang our bags more than 24 hours always. Now some of the companies came out with 500 ml solutions which can be administered even in 8 hours. Some more patients we are completely converted because these 500 ml solutions or 1 liter solutions really match with the nursing shifting hours. So, it gives us some advantage, and continuous therapy has to be tapered, as I told, very slowly. So, cyclic PN has some advantage. So, the advantage of PN is in a given particular day, in complex nutritional scenarios, you might have patients where that particular day he has received a parenteral nutrition and next day he has not received a parenteral nutrition. So, that situation is highly practical. We can create that situation. You come for rounds today morning, you realize that there's a big amount of catch-up nutrition the previous day, it's not a very good idea to tell the nurse that you give 2,500 kilocalories through oral route. That patient may not tolerate. Instead of that, you add some 500 ml or 700 ml parenteral nutrition on that particular day with a clear advice that don't give it tomorrow. So this can really be done. So this therapy can be altered in a customized way. So we have evidence that it improves overall outcome and faster recovery. So as I told earlier, you will have a EN dominant patient and PN dominant patients, and you categorize this in a practical bedside way. So you always assess the progress of EN and wean over 3 to 4 days. Okay. Whereas in PN, parenteral nutrition, so you have to, when you wean off the enteral nutrition, you don't do the same in the parenteral nutrition. Parenteral nutrition not so toxic as I told earlier. You maintain the parenteral nutrition 3 to 4 days and see it and slowly taper it and stop it. So one of the patients, I'll take you an example. So this is a pancreatoduodenectomy, pancreatic cancer. The parts removed are head of the pancreas, duodenum, distal stomach, complete duodenum, and the parts of jejunum. This is a complex surgery. These patients, we know that this patient needs chemotherapy in the post-op setting. So this is the estimated post-op requirement. High protein is because of the complex surgery. An entire GI system is disturbed. So what we expect normally in this patient is, you have a tube put preemptively, thinking complications, so feeding access. This patient developed what is called a pancreatic leak, external pancreatic fistula. Okay. When you develop external pancreatic fistula, some of the patients will just get away with that without much problem. Some of the patients will become really sick. So this patient ended up in inadequate oral intake and started having oral ulcers. So the philosophy in this patient is, we never think of a parenteral nutrition after a post-pancreatoduodenectomy, because you know the expected recovery. Very few patients, they becomes complicated, but you have a feeding tube there. But day 11, patient started vomiting multiple episodes, had delayed gastric emptying, which is one of the complications in at least 20 to 30% of the patients, but it recovers. This is what we expect. So you expect the complication in the initial 10 days or 11 days. After that, it is expected that the patient is going to recover. So nasogeneral feed restarted, 60 ml per hour, increased gradually. Okay. Now the day 20, so this patient has a leak. The day 20, he has diarrhea. NJT concentration had to be reduced. Okay. Now what really happened? You know that this patient was only on enteral nutrition till day 20 by oral or tube feed. So there was a hyponatremia. So day 21, this patient had disorientation, vomiting, suspected aspiration. So this aspiration is related to delayed gastric emptying. Okay. So when he aspirated, he shifted to ICU, stopped nutrition on IV fluid. Now he is on IV fluid. So at this moment, his stomach is not functioning properly. He has a complication. There is delayed gastric emptying. Feed is not going properly. Now that is part 1 only. Now imagine the patient at day 21. Now he is carrying a huge nutritional deficit. Okay, that's the problem here. So we never thought of it beforehand. He ended up in a huge nutritional deficit. He has 3-4 anastomosis inside. He had this lung problem because of the aspiration, and he's ended up in ICU. So this is the message of this patient. Parenteral nutrition started, increased to 200 ml, 600 gram protein per day. So even if you advise the maximum dose of enteral nutrition in this patient, even if there is good access and no delayed gastric emptying, this patient will have a extremely delayed recovery, because we have a lot of catch-up nutrition now required. Okay. So what might have happened? Imagine a scenario where we have started anticipating the problem. We have started this parenteral nutrition right from the beginning. This patient would have been a very different scenario, but our protocols are evident. We didn't permit that. So this patient ended up in tracheostomy. Nasogeneral feed restarted. Day 32 developed metabolic acidosis, hyperkalemia, hypertension. So, in order to avoid or mental hesitancy to avoid metabolic complications or infection related to parenteral nutrition, we ended up in avoiding parenteral nutrition, finally ended up in parenteral nutrition. This is the usual scenario for complex situation, and we should remember that this patient has to receive chemotherapy at least within 3 months of surgery. So, he is on co-therapy now and on NJ feed with parenteral nutrition and electrolyte balance, everything maintained. Okay. So, these are some of the group of patients you get in a very complex scenario. So, my message is, please do not hesitate to start parenteral nutrition even in small amount. The cost involved with the parenteral nutrition, if you take the indirect cost of not starting it, will always be higher than the cost of parenteral nutrition, especially in cancers and complex surgeries. Some of us at least use parenteral nutrition very extensively, pre-op setting, intra-op setting, as well as post-op setting. We even very recently also one of our patients actually got shifted to operation theatre with a nutrition bag, and anesthesia person was asking, at least you should have sent this detached from the bag. Please don't add confusion to me. Okay. So, thank you very much for the kind attention.
Thank you, Biju. Yet another revolutionary concept from you. I think a lot of us do use a combination every now and then, but is this evidence-based, or are there any guidelines where you use TPN when EN feasibility is there? Because we always believe that whenever there's an enteral a path, that's what you use, and parenteral when enteral path is not possible.
Some evidence is there in severe acute pancreatitis, where you use both together, but our spectrum, our experience is mainly in patients who undergo surgery. Okay. The reason is now because of the neoadjuvant therapy, which we start, almost 50% of patients actually require neoadjuvant preoperative therapy. We have some targets, and we eventually ended up in using it, We had to create evidence for that, but we actually measured the inflammatory parameters like TNF alpha, interleukin 6 and interleukin 10. TNF alpha, interleukin 6 are negative predictors, interleukin 10 are positive predictors. We always found that interleukin 10 levels are at a very good level at the time of surgery. That evidence we have, at least was, okay, but it has to come in large numbers.
Yeah. Any comment from the chair or from the audience, please? Yeah. Can you take a microphone and... Can you switch that microphone, please?
Yeah, you're audible.
Yeah, can I have the microphone then?
Considering the hang time of the TPN bag, how you consider the cost effectiveness? I mean, the leftover will get wasted, or how we use it on the next day?
It's not cost effective as of now because the cost is not half, exactly half. But the benefit, see, in healthcare, we have a problem of mental block of calculating cost only based upon that action. But the cost is always indirect. 1 day hospital stay, even in public sector, 1 day ICU stay costs 15,000 per day. In public sector, completely free hospital. Okay, that's the indirect cost. So if you calculate that, it's always be cost effective. It always, but you want a small add-on on a particular day. You can't add a 2-liter bag and hang on it because now you are bound with the bag. Patient is bound with the bag. Here is a situation where you add on just like an IV fluid, give it for next 8 or 12 hours, one shift is over, forget it. Next day morning you give. This gives you some calories. This is a definite way of giving some calories. That way we started using it express.
And sir, my another question is, if patient is transited to oral feeding and the patient is not meeting the protein requirement, if the calorie and protein requirement both are high, we are meeting the caloric requirement but not meeting the protein requirement, at that time can we use the amino acid solution as through peripheral?
Yes, so we also use amino acid solution. Some of the situation the other way also is there. We also use high concentrated dextrose solution also. So both can be used. So amino acid solution as a separate bag, you can always add on. But only thing is you have to measure the other components like sodium, potassium, magnesium in the blood. So patients should not end up in electrolyte excess. That is what we have to see.
Thank you, sir.
Yes.
Thank you, sir, for such an eloquent presentation. One question, quick question, the 5-day calculation. Because we are all doing 24-hour calculation. So how do you prescribe that? That would really help us to go in that direction.
So when we advise the nurse, we advise two things. We tell them, see, this is our prescription for the next 1 week. Fine? So they have to understand what we are going to give for the next 1 week. Then we will tell that this is what we require in the next 24 hours. Okay, so you have two prescriptions. You have a 1 week calculation or 5-day calculation. This is our target. And by this time, the patient has to receive this much calories. Let us say 8,000 kilocalories in next 5 days he has to, or 7 days he has to receive. Now you split up it and tell that 24 hours we are supposed to take it, you are supposed to give this. If it is not received, please don't discuss again. You know 200 kilocalories balance on the previous day. Please escalate it. So she will try to make it your 24 hours to achievable in two components on day 1 and day 2. But at the end of 48 hours, she will tell that, okay, by 48 hours, I have received your 2 into 24 hours requirement. If not achieved, again goes to, this is the only way practically we are learned. You ought up to using 24 hours, you forget that component, you will again have a pseudo satisfaction in the next 24 hours.
Sir, thank you so much for answering and responding to it. And I love the idea, earlier also you mentioned that it's not just the guidelines, but every patient is different. So you need to know the guidelines and then implement it as per the patient. But when you're talking about 5 days, my question is about the challenges, sir. As dietitians, like you said, it shouldn't be just a prescription. And when we are prescribing, if orally or enterally and parenterally, the total volume which is going is very important. And if the nurses are going to do, looking at the Indian scenario, sir, and the challenges that we are facing, what about the challenge of maybe fluid overload or hypoglycemia that can happen? If we consider these kind of considerations that they can match up or match up the feeds later or the volume can go. Anything that we have to
I told in the beginning that we know we have problem with PN, metabolic problem, hypervolemia, hyperglycemia, all these things are there. So at least in my unit, we are not worried about 200 glucose. The patient, because if you don't do that correction, nutrition correction right now, it's going to delay his treatment. So we are very much okay with the 200 glucose, with insulin, with TPN. It will not differ us to give another parenteral nutrition. We try to manage it.
I think there should be a very close communication between the surgeon and the dietitian whenever you have. Otherwise, there will be a bit of confusion. I think that requires a lot of practice. Thanks, Biju, for a very novel concept. Thank you.
So, good afternoon, everyone, and thank you for the opportunity. So, next I would like to invite Professor Arun Singh. He is a prominent figure in the field of neonatology with an extensive career and many publications in the national and international papers. He is renowned for his pioneering work in developing the sick newborn care unit, which has been adopted widely, and also he has conceptualized modern labor rooms with human lactation management center or milk bank, and also early intervention centers in India. He has also designed and implemented a screening and management program for all children from birth to 18 years for more than 60 health conditions. at zero cost to the parents across India as the founder and chief technical advisor for this program called RBSK. I'm a pediatrician, I don't know about this program. Previously, Dr. Singh held the position of head of neonatology at AIMS and IPGM at Kolkata, and his expertise access to the technical advisory roles in multiple states in India. Welcome, sir.
Thank you. Thank you. So first of all, I would like to thank everyone for inviting me. So usually this happens that most of the programs in India, and especially in the government sector, are not widely circulated. And then what happens, the states change the name. So if you are in Kerala, RBSK can be called Hridayam or Shablam. So if you are in Bengal, it will be called Shishu Shati. So that almost adds more to the confusion, but that was one of the things where we thought of the country's program of screening and managing. So today's topic is the challenges of enteral and parental challenges, especially in newborns. Now, this, if I put in the last 4 decades, there has been a lot of changes. There was a time when nothing was available for newborns. Anything to do with parental nutrition was only for adults, and as someone was discussing, the 500 ml. So today I'll be talking about the challenges of enteral and parental feeding and what are the strategies by which we could successfully do it. So you see, when a newborn is born and when he's a preterm, the first few days are very good because it feels as if the child is going to make it. And by 3rd or 4th day, you have a abdominal distension, stoppage of feeds, and then the situation goes on and on. So, some few things we have to understand, that the gut is immature. There is a hormonal and immune function which is also disturbed. And the most important is that the baby is born. Unlike the adult, every organ is developing, but most important is the brain. 100 billion neurons, they require nutrition. So you can't say, okay, wait for some time, stabilize, then I'll give you the nutrition, because that means this 1 day of 1 trillion corrections per second of the neurons are going to miss out. And this is something which we never thought about newborns. We always thought of newborns in terms of survival and not the quality of survival. So enteral feedings or parental feedings is not only about survival, but it is also about the cognition of the child. Now there's a whole list of problems which we get: gastrointestinal immaturity, NEC, a dreaded thing, delayed feeding initiation, feeding intolerance, inadequate human milk. And this is very linked. The moment the mother sees her baby is sick, the breast milk will stop. And very late in my life, I realized that milk is not in the breast, it is in the brain. So when I was developing my AIMS, what you call the milk bank, I don't call it a bank, it is a lactational management center. One of the most important thing I found, the day the baby improves, the lactation improves. So we started trying to work with the brain of the mother, trying to address her concerns, and that was helping. So feed intolerance, inadequate human milk, regurgitation and aspiration, electrolyte and nutrient imbalance, lack of feeding protocols and infection. So there's a whole bunch of clinical consequences which you might be aware. Now let's put one problem at the other. What is the solution? When I was a medical student graduating or even doing my post-graduation, delayed initiation was almost an answer. So first few days, the baby would only be receiving dextrose IV, and we would wait. Sometimes the milk is not coming. Few solutions. I think the most important solution is, whether it is a C-section or a normal delivery, if you want to avoid giving formula milk, which is not the best for the brain. So today I'm not talking about survival. I'm talking about the story why we are a Homo sapien. If I cannot protect the intelligence of a baby, I can't call myself a neonatologist. So one of the most important thing is just put for 1 hour skin to skin contact. The simple measure will help to initiate feeding. And I will also show that in the last decade I have been doing research, physiological cord clamping and intact cord resuscitation. So even if the baby requires resuscitation, don't remove the baby from the mother. Begin minimal enteral nutrition. Now it is well accepted, which we call the trophic feeds, because you have to stimulate the gut within 24 to 48 hours. And gently advance, because there's a feed intolerance, 15 to 25 ml per kg per day. But I don't think there's any formula for it, and I'll come to it later. One of the things which the nursing staff would always say, sir, you gave 2 ml and after 2 hours I could aspirate 2 ml. Now this kind of aspiration and residual, gastric residual causes confusion. So don't just go by the volume, see the baby's performance, and sometimes you don't need to take such actions. And sometimes you say that the milk which the mother is producing needs to be fortified because the needs of a preterm baby. Now see, this is what at AIIMS Jodhpur. So you can see every baby, the moment you light, these are the 9 stages. This not only helps in the nutrition to the body, but also nutrition to the brain. And you'll be surprised that no one needs to tell the baby where is the breast and where is the nipple. The vision is poor, but the smell is much better than any one of you sitting in this hall. So actually the baby moves, finds the nipple, and can grasp. So these are actual videos which is created. So this early initiation of breastfeeding within the first hour after birth is a very, very important thing, and there are studies to show that skin to skin contact, what people call even early KMC. The next challenge was about cesarean sections. Now you see in our country, some of the southern states are running 80% C-sections, and the private labor room deliveries have almost disappearing. What happens it? The usual story is the baby is born, cord is cut, the baby goes to what is called a nursery, the mother goes separately, we say give rest to the mother. This, I think, is the biggest cruelty we could ever do to the human being, because the baby knew only one person, the mother before birth. So in Calcutta now we have done almost 10,000 cases, both in the periphery and one of the oldest medical college in Calcutta. What we are doing is, even if you are having a C-section, we keep the baby on the mother, and this trolley has been designed without cutting the cord. This trolley is a height adjustment, it can rotate, and you can see on the photographs twins born, both are on the mother and the cord. So the cord is also giving nutrition, and nutrition is not lipid, protein and carbohydrate. Nutrition is also oxygen. So what was happening? All the mammals, the placental, oxygen was very important to the brain. So the mother told the baby, you remain inside, you are getting the oxygen, ECMO oxygen, through the umbilical vein. When you go out, the cord is good enough, the placenta will not separate. Go out and take your breath. Once you have established your oxygenation, give me the signal, and then you'll say, is this art or is this evidence? So we started measuring that when does the placenta separate, and what we call the physiological, once the baby establishes his respiration, then only the placenta. So leave it to the mother and the child rather than. So this is also a nutrition which is coming, and not only oxygen, but other things also comes. So Now the problem is regurgitation and aspiration. Most of the death certificates in the newborns will say the baby has aspirated and died. Let us understand one simple thing. The whole Western world did experiments saying, is continuous feeding better or is intermittent bolus feeding better? And they came up with the conclusion that perhaps either it is the same or in some ways continuous feeding is, or the intermittent feeding is better. So one day I started thinking, the baby size is increasing, the stomach size is also increasing. Can we make use of both? So I'll come to it later. The nutrient deficiency, fortification has to be done, but we are still fortifying not with human milk, we are fortifying with cow's milk or some other species milk. Hygiene and preparation. Let me tell you, even if you are preparing any formula feed in any NICU, don't prepare it in the ward. Use a clean place because this feed can get infected. Remember, your container, you are not boiling the milk, you are just heating it. So once the organism is contaminated, the baby is going to get. That's another part of the talk, but yes, I could tell you, there are a lot of talks where we found that the milk itself gets contaminated. So this should be done ideally in the lamina. So when should we initiate the feed? We have talked about the preterm infant. The mother was supposed to give a lot of nutrition, you didn't. One of the ways I would say, don't cut the cord, allow the last minute nutrition from the mother to come to the baby. Once the baby is born, start doing trophic feeding. There's a lot of meta-analysis saying that don't keep the baby nothing per mouth. Early initiation is much better. It decreases the mortality at discharge and especially also at 28 days. The duration of hospitalization is also lesser. There's no effect on NAC. So the bottom line is start feeding very low birth weight infants from day one. Usually, even if the baby has asphyxia, respiratory distress, you can still go with your trophic feeds. Don't stop the trophic feeds, which is 12 to 24 ml per kg per day. Now, I was talking about this continuous feeding versus intermittent. You can see there are some disadvantages of continuous feeding. Nutrient loss, delayed, longer time to reach full feeds, blunted hormonal response. So at AIIMS Jodhpur, and I can say this is not evidence-based, this is personal experience. So initial 72 hours till the stomach size increases, I give continuous feed. And once the feed starts climbing, then we switch over to intermittent. So it is not one versus the other. You could use both because when you are using continuous feed, the gastric stomach size is increasing, like the entire weight is increasing, the stomach size. And so once you think that the stomach size is now good enough to hold, it is better to move to intermittent feed. So you could use both of it. Though the Cochrane review, again, as I said, they have compared one versus the other. They have not compared one with other. So how rapidly should we feed? Well, these are all, again, figures. You have to see your baby and decide, but less than 1,000 grams, 18 to 30 ml, greater than 1,000 grams, 30 to 40. The bottom line is the stomach size differs in both these two. So I have talked about starting minimal enteral feedings, unstable. This is not a contraindication for using minimal enteral feeding. So try as far as possible not to stop feeds, enteral feeds. And be very sure to start early parental feeds because once the calorie loss is there, once the baby goes into a negative nitrogen imbalance, the problem is also with immunity. Then you will find that the sepsis is coming up. If there is a huge weight loss, the baby is already low weight, it will be very difficult for you to do the catch-up growth, especially in terms of nutrition. So I will very quickly go on to say you have to use HMF. It is Still, I'm waiting for the day when human milk fortifiers, it had come, but I think for some reason it was withdrawn, so that we can prepare dried milk from human milk itself and fortify it. But once the baby is close to about 100 ml per kg per day, you need to add this. So what we can do is start an initial continuous feed with 0.5 ml per kg per hour, give it for 72 hours, and then you can move to 1 ml per kg every 2 hours. So you can make the both use, but don't give MEN for more than 4 days. You have to advance very quickly. Some of the problems of TPN, I was listening to the interleukins and cytokines problems. In TPN in newborns, there are various problems. To start with, you have a vascular access issue. There's a catheter-related sepsis. There's a metabolic complications. Now you need to draw blood. There's a 1 kg child which has hardly 80 ml of blood, so you can't be drawing blood every day. All these challenges are there. So the hepatic complications, the nutritional, the infectious risk, the gastrointestinal consequences, and the practical and logistics. So I'll come very quickly to what we can do. Please prefer a peripheral inserted central catheter versus central line. I would say a PICC line is much better, at least in newborns. Which material? Either use silicone or polyurethane. Don't use polyethylene. If possible, use a peripheral line, choose appropriate catheter size, and confirm the tip position. I know one of my residents who had catheterized the umbilical vein. Don't reposition once you have fixed it, because it can perforate. And if you are giving TPN, this can go into the peritoneum. So be very careful, this can cause a death. So if you find that the position has changed, it is better to come out and re-put a cath rather than trying to navigate it or reposition it. Heparin could be a good thing. It has brought down culture positive CRS cases of 0.5 to 1 unit per ml in your TPN. Strict aseptic technique, perform insertion. So here you have to train your nurses very well. There should be a transparent dressing. We should be able to see it properly. And don't use this line for anything else excepting TPN. So don't start testing your bloods also from the same line. Adhere to central line associated bloodstream infection bundles, minimize line manipulations, and use closed nucleus systems. So most of the things which you know, but when you choose... Yeah.
Sir, I think we already, the time is over, so we'll have to quickly summarize.
Yeah. So most of the things in the TPN, there are 3 things which I would quickly say. If you are using amino acids, use it from day 1. When you are choosing your lipids, but don't use adult amino acids, because they contain higher taurine and cysteine, and this can be very, they lack taurine and cysteine, and they contain very high glycine and methionine. When you are using lipid, the 3rd generation lipids are found to be better because it contains omega-3 amino acids. The thing when it comes to the glucose, I think also don't be afraid of high hyperglycemia. You can control it with insulin. The most important challenges which we are still facing is we are still using adult MVI. The industry has not responded with neonatal MVI till date, and this is very, very unfortunate. The other thing is, if you are measuring the osmolality, don't use calculated osmolality. Calculated osmolality, and there is a difference between osmolality and osmolarity. So always have a freezing point osmometer that exactly tells you, because there are a lot of osmoles which cannot be calculated by the calculated. So the message is the osmolar gap is very, very important when you are doing. You have to do your triglycerides level, you have to repeat the bloods, but again, as I am saying, that go more on enteral than parental. Parental is just buying time, and it is not one versus the other. So if you are on TPN, don't stop the enteral. At least the minimum enteral nutrition should be started. You could switch over from continuous to intermittent once the size increases, and keep sure you prevent sepsis. Thank you very much.
Thank you, sir, for a very nice and detailed talk. Any questions from the audience or any comments from the panelists?
So just a comment, I mean, we as dietitians don't really get to see neonates so often. And it's very exciting and very interesting. We would love to hear probably later at a longer stretch. It was a great presentation. Thank you.
Also, the concept of MNICU is actually increasing in India now, and in our hospital also we have MNICU. But I do visit in a neonatal ICU once in a month, but not regularly, because we generally as dietitians don't see. So it's a gamut between the doctor and the nursing. But now the dose for dietitians in MNICU is also increasing in India. That's what I can comment.
It took so much of time for us to understand that if the baby was with the mother for 9 months, it could jolly well stay later on also. So sometimes, you know, history takes so much of common sense evidence, and I really appreciate that if you keep the mother and the baby is going to recover faster, the nutrition is going to be better. Don't be afraid of keeping the mother next to a sick newborn.
So, Dr. Singh, we were always a part of the neonatal team that you know in AIIMS, but I just want to, you know, for the sake of the dietitians, we could always say that so much of volume per kg, but, you know, there's a lot of confusion in actual body weight and expected body weight. What should you consider while calculating the requirement?
So we should go by the expected body weight and not by the actual weight, because there can be, we all know that after birth there is a weight loss. So, and that will lead to a lot of calorie deficiencies.
Yeah, because, you know, different protocols say, Sam, you go by actual body weight. So it's just for the sake of the dietitians,
I thank you very much for bringing up a very, very important point, because sometimes the weight losses are very extreme, and especially when you are working close to the desert, which I had experience in working at Jodhpur, which is very close to the Thar Desert. The weight loss is much more than what has been prescribed in the books.
Thank you, sir.
Thank you. Thank you.
So at the outset, I am thankful for the organizers for inviting me here, and I have a pleasure of introducing the next speaker, Dr. Lekha Sridharan. Dr. Lekha Sridharan has certified SPIN LLL in nutrition assessment, sports, cardiovascular diseases, cancer, critical care, renal, GI disorders, metabolic disorders, and a whole lot of things, and FODMAP training, Monash University, Australia. Her current position is Head of the Department of Clinical Dietetics, Apollo Children's Hospital and Women's Hospital. She's a National Vice President of IPIN, India, and she's had oral presentation in SPIN, which recently happened in Prague, and also poster presentations in various conferences. She had been a keynote speaker in Fancy Conference in Atlanta, USA, and a host of other oral presentations nationally and internationally. I welcome you, Lekha.
Thank you, Doctor. Thank you, Anuja. At the onset, let me thank SAPCON and IAPN India Delhi chapter for having me here. So for the next 15 minutes, I'll take you through the challenges and strategies for artificial nutrition in pediatrics. Before I start, I would like to know how many of you practice pediatrics over here? Yeah, so we have few over here. Fine. So I'll present the scenarios where we have the practical difficulties and how we can manage. So to start with, we all know that nutritional support is very much essential, and for that, especially in ICU, you require at times enteral and parenteral, even in pediatrics, right? And the main concept is they have in children, there is a higher metabolic demands, and the reserve what they have of energy is very less. So in critical care, when they are there and we are not feeding in the right time, that becomes more challenging. So We all know what is the golden standard for getting the calories. It's indirect calorimetry. But we don't have that in our scenarios in most of the hospitals. Hardly few, 1 or 2 hospitals in India have that. So what do we do if we don't have indirect calorimetry? We use certain formulas. So the challenge comes over here. Sometimes with the manual calculation when you are doing, either it is leading to underfeeding or at times it leads to overfeeding. So when there is underfeeding, there you can see lean mass loss can happen, immune dysfunctions, it is a chances of higher mortality. At the same time, if you are going to give an extra calorie, then again like hepatic steatosis, or it could be a reason for even prolonged ventilation. So, and we also know if you are not feeding well, the malnutrition is becoming even more higher at this particular point. So what do? We have to make it as an individualized planning. So it's like each age group also, the child will have a separate calories. It's not like an bracket calories, like say how we have for adult, we say around 1,500 or 1,800. It doesn't remain the same in pediatric. With the age group and again with that particular child, the calories will differ. So when I say you don't have the indirect calorimetry, you can use the Schofield, Food Agriculture Organizations or WHO. So these are the few of the equations which can be adapted. Remember, you will not be using the White, and the Harris-Benedict equation wouldn't be suitable for your critical care children. So this is the Schofield equations, but I would again say that when we are practically seeing also in our scenarios, when we opt for these formulas, these also lands up in having an extra calorie. So don't just specifically go with that. This is just a backbone for you to understand how to calculate, but this alone wouldn't be the right way. I'll come forward how you have to do. The next question comes about when to start the feeding. So ideally we say about like, all the Espagan, all the guidelines recommends about like 24 hours within the admission you can go for the feeding. But do we really start that? There could be a delay in that. 24 to 48 hours is the best time to opt for your enteral nutrition. You have to be cautious in feeding, especially the scenarios when you have severe burns or like congenital heart disease or like a shock cases. There you have to be little more cautious. A close monitoring is especially required in infants when they have a risk of neck. And early support of EN can otherwise be opt for because it will help for the gut integrity and reduce the infection risk. Not only that, you will be able to attain the energy and protein target. The increased ventilator-free days can be seen. There is a decreased length of stay and the reduced cost and reduced mortality can be seen with the enteral nutrition. So this is the key point what I want you all to have it in mind. When the child is there in your ICU, you have 3 phases, right? So the acute phase, that is the initial phase of the first 2 days. So here you can see metabolic instability. So your target of giving the whole calories, okay, that shouldn't be happening over there when they are in the acute phase. So with the actual weight, you are having the target goal. So sometimes when your child is less on weight and you need to give an additional calorie, say around 100 to 130% of the RDA might be required to catch up the growth if the child is going to be undernourished. So that goal should not be happening when they are in the acute phase. So go slow at this period. The next period, which comes as the second phase, where there is significant muscle wasting, but this is more little bit of a stable. You can increase. Only in the recovery phase, that is like, the later part, that is where the target goal of the catch-up when is required, you use over there. This is mainly because to avoid any refeeding symptom in the child. So as I say, the acute phase, remember you are going to avoid overfeeding. Recovery phase, the resting energy intake is actually double than what is there in the acute phase. So this point has to be remembered. Coming to protein. So ideally you go for protein 1.5 grams per kg in the acute phase would be right. And you can step up to 2 to 3 grams per kg. Then again from center to center also it varies. They don't start with the 1.5 grams of protein for all child. It depends slowly. It started with 1 gram and a step to 3 grams. Very rare occasions where you require extra more on the nutritional status to improve, even up to 4 grams are gone in specific reasons also. This is another important thing. you need to understand about the carbohydrate and glucose infusion rate. When you're talking about like TPN and all in pediatrics, this is something which is very important. So you have to ensure with the weight and with the age, you have glucose infusion rate, what you're going to give is very important. So as you can see in the acute to recovery phase, there is a change in the amount of glucose what you're going to give. So there are formulas available nowadays, all app-based also there. Earlier it used to be like we have to write it and calculate find out how much is the glucose infusion rate. Now you can get it in the online itself, where you'll be putting the dextrose and other solutions which are being used, and you'll be able to find out how much is the GIR and even the osmolarity. So this needs to be checked out when you're giving the TPN plan. Now let's see about certain challenges which we often come across. So there are at times the challenge of feeding interruption. This could be like the child is going for some procedure. So they keep them NBM, they are not feeding it. And so what happens ultimately the next day, you're calculating the whole day's goal, you will be lacking on getting that feed. What we can do is, like if they have stopped in between, the next feeds, probably you can increase on the volume to meet up that requirement can be done. And at place when the delivery methods has to be changed, the child is not able to tolerate the bolus feed, shifting over to continuous could help. And even in the scenarios when the gastric feed is not working out, you think about going for the transpyloric feeds. Certain main concerns what I see is about the availability of formulas. So it's not like in infants we do go for the breast milk, but the scenario, it's an older child, 1 year, 2 years, and specific cases like you have inborn errors of metabolism and you want to exclude certain nutrient, macro and from that, and you don't get the formula. So what do you do that? So this becomes extremely challenging. So based on the availability, it takes time sometimes to get. Nowadays certain companies have come up with certain IEM product also. Only thing you don't get it in a regular basis. It might take 1 or 2 days and then you can suit those products. And coming to the formulas, the ideal one, the normal regular polymeric formulas are suitable, which can be given for the infants and for the children. Only in the scenario when they are not able to tolerate the polymeric, you think about going for a hydrolyzed formula or like a semi-elemental. If not, then think about going for the elemental. So it can be a slow process of changing. Administrative prokinetic agents also help. So this way you can meet up those challenges. So gastric residual volume, notice it's like it's not needed, that it's not mandatory that you need to look in terms of GRV. So this, when that interruption can be prevented. Most of the scenario, there was a period when, because for the GRV calculation, the feeds are being stopped. So if this interruption can be stopped again, you will be able to get that calories, like the lag wouldn't be happening. So the other barriers, what I would say is like, each unit should be having an enteral nutrition protocol being set for their units, so that you can plan out like when to start the feed, what formulas to be given. So this stepwise protocols, when it is set for your unit, it becomes like, it's easier to follow. Same in my center also, it varies from one consultant to one consultant, like each will have their own opinion about starting on the feed. So creating a standard enteral protocol based on the guidelines and getting the approval from a whole of the PICU team or your cardiac team will help you to get the nutritional requirement being met for the child. Coming to parenteral nutrition, like adults and for the older kids, you have the 3-chamber bag, which becomes very easier. You can calculate it and give it easier. In pediatrics, like since we don't still have the compounding TPN being done in much extensive, like separate TPN has to be given either like with the aminovins, dextrose and the fat separately. So one way this is good, the requirement what you need is easier to meet like that rather than using the adult 3-chamber bag. You're going to use the adult 3-chamber bag, you will lose more on the volume and the rates are higher. The same if you're going for the separate thing, like say for around 500 to 800 rupees, you will be able to finish. The same if you're going for the bag, it costs you around 2,500 to 3,000. So you can use a separate compartment when it is going to come for TPN. So this is about complication and management. Few sir already explained in his previous slide. Just to give you a quick view, like you have hyperglycemia, you think about reducing the infusion. dehydration, look into the osmolarity of the feed. That's very important. Monitor the electrolytes. You have hypo or hyperkalemia. Look, frequent monitoring is very much important. Hypernatremia, you'll have to adjust the volume of the formula fluid. And then if you have hypophosphatemia, chances of refeeding, it's an alert for you, right? So you have to even look into the phosphate level. Club C could be because of the central line uses, aseptic care and timely replacement is needed. Most the other scenarios when the dietitians are often called for diarrhea. The diarrhea comes and the first they say, what is the feed going on? Is there a problem which is there? That's what first thing being asked. So you will have to look into is it because of the feed intolerance? So as I said earlier, you'll have to switch on the formulae being used from the polymeric to the semi-elemental. Look into whether it's a lactose-free formulae what you're using. This adjustment can be done so that the child will be able to tolerate. Sometimes the medication being mixed with the feeds, that also again to be looked out. The feed has to be separate, the medicine what they have to give should be separate, the mixing should be avoided, hand hygiene can be looked into. Ideally if you have a laminar airflow, under preparation of the feeds over there could be the best thing to be done. Nausea, vomiting can be the reason of concurrent administration of medication. That could be even delayed gastric emptying, and you can even see constipation being present. So the strategies what you can use is monitor for whether there is any GI distress being there, adequate hydration and fiber. At times we do have the additional fiber being added to the feed when the child is having constipation. This can be looked, this I've tried for the older kids like above 1 year of age. So next coming to aspiration, which the sir already explained about, you will look into the signs of reflex and intervene promptly considering the prophylactic use of the H2 blockers or even the proton pump inhibitors are there. Tube occlusion can also be there, so flushing protocols to be maintained. So when you're formulating that EN protocol, the flushing, the tube flushing, how hourly it has to be done, ensure to have that also being mentioned in that. Pressure ulcer needs to be looked down. Regular skin assessment to identify early signs of pressure ulcer needs to be there. So what I would like to conclude is there are times when artificial nutrition sometimes become difficult, like say for example you have a child with Kyle leak and you know that you want to give full 90 or 100% of MCT based product and you don't have it available. So then of course that becomes a challenge for the dietitian, but then again in the market what we have like the 90 or 70% which is available, probably you think about using that. So such changes can be done from our end and can be used as and when required. And there are the scenarios when we are not able to meet the requirement through the oral diet. So you think about adding those ONS, and that scenario can be done. So a multidisciplinary team is important, and as we were speaking earlier, the presence of why the dietitians are not there in the NICU, our involvement along with the doctors. Once you start doing and you know the protocols are there, the dietitians will also be able to start doing the NIC rounds. It's similar to what we are doing in the adult scenario, which from my center, the 6 months old juniors also have started doing. So our presence, we understand the guidelines, we take the step of making the protocol, that becomes easier for us. With that, I conclude. Thank you all.
Thank you so much, Lekha, and I would definitely, the involvement of the dietitian is really very important, even in the neonatal ICUs, and it is really a very big support, right? And that's why, AIMS had been a really high density, so we were always involved.
Yes.
But then what I want to say is that, of course, guidelines is there as a backbone, as you rightly said, but each case is so different that on the spot you have to make a decision. So I think on the side training for the dietitians is very, very important to learn. It's not just doing a course and say, okay, I'm certified and all. So I really want to put this in for all the dietitians that on the side, along with the doctors, training is very, very important.
Even we do our rounds like that only, mandatory with them. Then it becomes easier. You can also learn. Thank you.
Sorry, I have one question.
Yeah.
A lot of time in pediatric patients, achieving protein targets are easy. Because, so the calorie targets are high, protein targets, even if you go 2 or 3 grams, it's not as high. How do you manage that? Because we struggle to achieve calorie targets, not really protein. Proteins is all right.
Nowadays, with the current formulas what are available, I'm not facing that problem. But in infants it's there, then we use the HMF. For older also we have now protein as like 5 grams, 10 grams are available as formulas which can be mixed to the feeds. So you can just get connected to me, I can guide you on that. So that can be done. Yeah. And even, yes, Charu?
Yeah, so first of all, I would like to congratulate you on a very elaborate talk. And I agree that making protocols with PICU team is really important. That's actually going to turn the balls, because otherwise dietitian takes the round in silos and the doctor and the nurse separate work. So I just wanted to know, how do you manage the reassessment of these patients? You would calculate the calories, you will calculate the proteins on a daily basis, and you may also calculate the fluids also. So that can be done because guidelines are available. But doing a reassessment of these patients, how are you managing? And is there any age-specific thing that you're doing other than the tools which are internationally available, which may not be validated in India? So
Is this is where that phases come. Like as I said, in the acute phase, when you're planning the calories, no, that is lesser. So you have the target which is going for your recovery phase. So when you're doing the reassessment, your target calories of that phase, you have to look into whether you're able to meet or not. So if you're not able to, your suggestions of the plan will be accordingly. So the phases will help you over there. So we have a separate format assessment sheet for our PICU, where I have put it like, the acute phase, how much calorie, the next table is how much, like that we have a protocol which is already been made in my ICU. So the 7th day of my reassessment, I will look into whether the recovery phase I have met. And that's one of the quality monitor also what I have kept, to ensure that, that work gets over.
That makes sense,
that
because
makes
if
sense.
you
Then the
plan your goals,
assessment have that will help you.
Thank you, Lekha. It was a very comprehensive presentation there. Just one question, I think, just to extend what Charu asked. I mean, there are a lot of dietitians who are sitting here, they may not be using the equations that you just spoke about today. Do you want to emphasize or highlight whether to use these or your ICMR, how to compare and give them an idea on that,
For
please?
the ICU purpose, if you're going to think in the acute, you start with 40 to 50 calorie per kg you start with, and then you go up to 70 to 100 calorie per kg. I wouldn't be going with the equation. That's what I said. It's just a backbone for you to understand. But for each individual kid, it differs. And that's like, in the low you start, and it varies like that. Slowly you can step up. So as I said, you make the plan, acute, stable, how much you need to give, and then we give like that. 40 to 50 starting per kg should be the ideal way to start. And then you can step up. But if the child is like in a better stage, that again depends upon stable, and then how the pre-nutritional status was. It can go up to even 50 to 60 calories also in the initial period. ICMR RDA calculation is for the normal healthy child. Okay,
just about
so
to
that
say
is who are well nourished, and they who are there in the ward well nourished, you go for the RDA. EAR, you think about if you are thinking about a community nutrition for children or something, and then you look into take the EAR. For a critically ill who are undernourished, from the RDA, 110 to 130% of the extra calories you will have to give them.
Yeah, that's what, you have to make
Change
your
it.
own targets
It's
of the
changed.
child depending on his condition and how critically ill he is. This is only for the healthy individuals.
Yes.
Please don't go by the
Not
ICMR.
RDA.
Yeah.
Thank you. Thank you.
I think we'll move on to the next talk. At the outset, I would like to thank the SAPNCon organizers for having me invited here, especially Shilpa, Shiva, PC sir, thank you so much. Would like to invite our next speaker, Dr. Himanshu. He is from New Delhi, and so he'll be speaking on he'll be giving us basically an overview of guidelines on enteral nutrition and TPN. I'm so sorry, I don't have the interest slide or the information, so I really can't comment, but he's from New Delhi. Over to you, doctor, for the talk.
Thank you. So I'm thankful to the organizers for having me here. And after those two very good talks on neonatology and pediatric nutrition, now we move back to adults. So overview of guidelines on enteral and parental nutrition putting into practice. So globally, 30 to 45% of hospital adults are malnourished at admission. And medical nutrition therapy which include not just enteral and parenteral nutrition but also counseling as well as oral nutritional supplementation, has been found, and there are trials that have shown it associates better outcomes and lower
Just one second,
mortality.
please. Just one second. There's a technical glitch. We'll have to just hold on.
So the talk will be regarding nutrition hospitalized patients, what to do in first 48 hours, what to do in the next 3 to 7 days, and what is the concept of prescription protocol. And these were the guidelines that were reviewed during this talk. So first, a case. We have a 35-year-old male admitted in our ICU with acute pancreatitis due to biliary etiology. He has presented to us day 3 of illness, and he had respiratory failure which required mechanical ventilation. His weight was 70 kg and height was 165 centimeter. So how to provide medical nutritional therapy to this patient? So first step is nutritional screening. We have to see the height, weight, BMI, look for evidence of any sarcopenia. If there's any suspicion of malnutrition, then a complete nutritional assessment has to be done. And subsequently, malnutrition is determined based on the GLIM or the Academy of Nutrition and Dietetics criteria. So this includes if there has been any significant weight loss in the last 3 to 6 months, regarding BMI, is there reduced muscle mass, and what has the patient been taking orally before the disease. And finally, a nutritional intervention plan is made for the hospitalization. First, oral diet is preferred. However, if it is estimated that in the next 5 days, the patient will not be able to consume up to 75% of his calories, then he switched to enteral nutrition. And if enteral nutrition is contraindicated, then parenteral nutrition is considered. On follow-up, patients are monitored with weight, regarding their sugar monitoring, their daily electrolytes, and once they improve, a discharge plan is given. So the key targets in hospitalized patients are, as given in SPIN guidelines, are 20 to 30 kilocalorie per kg per day with protein of 1.2 to 1.5 gram per kg per day. And the first line is oral nutrition. However, if the patient is not able to take orally, then we switch to enteral nutrition. So both SPIN, both American as well as European guidelines recommend that if there is inadequate oral intake from 5 to 7 days, then you switch to enteral nutrition. However, this is for general patients. In critically ill patients, if the patient is not able to consume nutrition in the first 24-48 hours, you start enteral nutrition. And this is same for whether the patient is admitted in oncology, whether they have a neurological disorder, whether they have chronic kidney failure or chronic GI disease. In GI disease, since there is concomitant of malnutrition may be there, malabsorption may be there, so or they may have IBD, then exclusive enteral nutrition concept is also there. So first 48 hours, usually low dose enteral nutrition, that is less than 1000 kilocalorie or up to 60% of caloric energy needs is given for critical ill patients. However, if in well-nourished patients who are low risk for malnutrition at hospitalization, if it can be assessed that they'll resume oral nutrition in the next 5 to 7 days, then no enteral nutrition may be given. Coming to the next day 3 to 7, if at this point enteral nutrition is contraindicated, then parenteral nutrition is started. So initially, while even guidelines had shown that majority enteral and parenteral nutrition have similar clinical outcomes, however, multiple meta-analyses have shown that enteral nutrition is with lower infectious complications, and thus even as initially enteral nutrition is recommended. In the ASPEN guidelines at this point recommend that 12 to 25 kilocalorie per kg should be given in the first 7 to 10 days. However, clinical judgment is very important. For example, in diseases like acute pancreatitis, in which there is an inflammatory storm, there is hypercatabolic state, or in medical patients with multiple comorbidities, calorie amount of up to 25 to 35 kilocalorie per kg can be given and should be given. Then concept of supplemental parenteral nutrition. Even if the patient is not able to take full dose enteral nutrition the first week, parenteral nutrition can be considered on a case-to-case basis only. The ASPEN clearly writes that average critically ill patient will not be harmed by waiting a week to initiate supplementary parenteral nutrition. But in patients who are severely malnourished, supplementary parenteral nutrition can be commenced even in the first 7 days. In parenteral nutrition, both mixed oil, IV lipid emulsion as well as soybean oil IV have been found to have similar outcomes. Similarly, fish oil containing as well as without fish oil have been found to have similar outcomes. And there is one caveat that beyond 7 to 10 days, the essential fatty acid requirement is there. A deficiency occurs beyond 10 days. So mixed oil ILE have higher essential fatty acid content, is lower than soybean oil ILE. Regarding root, gastric access is standard. However, if there is persistent feed intolerance, then post-pyrotic feeds, including in form of nasojejunal tube, are considered. And continuous feeds are preferred over bolus feeds, since bolus feeds are associated with diarrhea and with increased gastric volumes. Regarding types of enteral nutrition, currently polymeric formulas are recommended. However, in patients who have severe GI disease, have severe malabsorption, semi-elemental formulas are also considered. Both Aspen and Society for Critical Care Medicine recommend against routine use of elemental and semi-elemental diets. Then the concept of delayed enteral nutrition. If patients have uncontrolled shock, uncontrolled hypoxia, hypercarbia, or acidosis, or have had an active GIB which has not been controlled, have overt bowel ischemia, then the enteral nutrition is delayed till the medical condition is first sorted. And then beyond 48 hours, enteral nutrition is gradually commenced. Similarly, the concept of low dose or trophic feeds, which may initially given to critically ill patients and are also given in therapeutic hypothermia if there is intra-abdominal hypertension not amounting to abdominal compartment syndrome, and in patients with acute liver failure. So energy and protein targets from day 3 to 7, the guidelines recommend that these be assessed based on indirect calorimetry. If that is not available, then from mechanical ventilator, the VCO2 can be found, and using that, the resting energy expenditure calculated, and subsequently the energy targets given. However, since Eva Medi Center, this is not currently available, so 20 to 25 kilocalorie per kg per day is the target, and isocaloric nutrition is advised. Similarly, protein targets, both guidelines recommend from 1.2 to 2 gram per kg per day protein. And they also observe that there is paucity of trials with high quality evidence regarding the specific protein for different diseases. And of these, the diet, 50 to 60% should be carbohydrates and 20 to 30% lipids, with the rest around 20% being with proteins. Regarding the role of oral glutamine, the guidelines recommend that they are currently evidence-based for only two main indications. One is severe burns and one in critically ill trauma patients, in which for critically ill trauma patients, they are to be given for the first 5 days. However, if there is complicated wound healing, then they may be extended to up to 2 weeks. Micronutrients should be provided with all parenteral nutrition, and vitamin D status has to be checked, which is usually done. In patients with sepsis, early enteral nutrition is advised once the patient is hemodynamically stable, and then progressively the amount of intake is increased to reach the targets. In obese patients, the predictive equations are inaccurate, and thus adjusted body weight is used for protein as well as calorie determination. If feed intolerance is there, then drugs recommended are either IV erythromycin, QID, or metoclopramide. Monitoring initial 48 hours, blood sugar has to be monitored 4 hourly as per the guidelines, and electrolytes have to be monitored daily for the first 7 days, and once the patient is stable, the frequency can be decreased. And finally, when not to give enteral nutrition, if there is hemodynamic instability, bowel ischemia, high output fistula, GI bleed, intractable vomiting, severe malabsorption, or high aspiration risk, the enteral nutrition should be avoided. Or suppose there is a fistula, then if the access is achieved distal to the site of fistula, then enteral nutrition can be started. Similarly, parenteral nutrition should also be avoided if the patient is hemorrhagically stable, or there is severe hyperglycemia, uncontrolled electrolyte disturbances, or severe bloodstream infections, and even in severe liver diseases. So the Korean guidelines published this year have given this format of prescription protocol. So this is like the baseline chart, and then there is a follow-up chart. So the dietitians and even the nursing staff can be involved in this. Then once the dietitian gives the instruction, it can be uniformly followed for the patient. This is also objective documentation and will help in following the trend about how much feed has been given, what was advised. So this should be monitored daily for critically ill and post-op patients and anesthesia patients, where for stable hospitalized patients, the guidelines recommend that it should be given as per the institute's protocol. So like coming back to our case, patient with acute pancreatitis who got intubated. So initially, since 25 to 30 kilocalorie per day has to be given. So 1750 kilocalorie was there. So similarly, protein was around 90 gram was advised. It was via nasogastric tube. Continuous feeds were advised. Initially, the rate of infusion was low, around 30 ml per hour, which has to be gradually increased every 4 hours till a target of 70 ml per hour. Flush feeding has to be done, and we have to document it, like 30 ml has to be flushed every 6 hours, and head elevation has to be done. Then on follow-up, while gastric, old SPEN guideline as well as in the Korean guidelines, gastric residual feed checking has been advised. Although multiple studies have shown that routinely it should not be done, but in patients who have feed intolerance, it can be checked every 4 to 6 hours. If it is more than 500 ml, then we can wait for 2 hours and then reassess. Similarly, tolerance to feed has to be monitored every 4 hours. And then body weight checking initially has to be daily, and then subsequently it can be increased. What should be the frequency of lab tests can be documented here, and that the other instructions can also be given in this protocol. So summarizing, medical nutrition therapy is an integral part of care of hospitalized patients, and what feed has to be given depends on the clinical as well as nutrition status of the patient. And protocol-based feeding and regular follow-up lead to improved clinical outcomes. Thank you.
A very comprehensive one, but done very quickly. Thank you so much for that. It was an overview of the last 2 great learning deliberations that we have for the last 2 days. Everything put together here for us in an easy way. I wouldn't really ask any as such question, but would want to know in your setup, or you know how one can be dealing with the challenges when it comes to these guidelines and having them to be implemented. Are there any challenges that you're facing, especially when it comes to doctors and dietitian coordination also? And when the doctor has some preference, but the dietitian has to follow a nutrition protocol and what is good for that patient. And of course, keeping in mind all patients as individual patients and then deciding.
Yeah, so you're very right. Frequently, we go to the patients on rounds and we tell them, and they say, dietitian had said this, so now what should we do? So obviously, at each individual level, even among 2 dietitians, there can be some difference. And the guidelines are also not very accurate for each topic. So if there's a proper protocol, there's a written protocol that this has to be done, and this must be discussed with the dietitian, the nurses, and the doctors. So there will be uniformity, and then the patients will be also better able to grasp what he needs to do. That will also improve compliance for the intake of these.
So there should be a more multidisciplinary role, and when you take a round, it has to be a round which has the dietitian, the physician, the doctor, and the nurse, everybody there in the team, and discussing a case before going into it. Thank you so much. Is there any question or comment from the chair or the audience?
I have a question, right? See, in an Indian scenario, we generally don't work in a closed ICU setting. Certain hospitals are open ICU setting, which actually adds on to the complications discussing. The dietitian goes at a different time, the doctor comes at a different time, and nobody is actually bothered. Even the guideline says that 70% of the nutrition goal has to be achieved by day 7. That's what the guidelines say. But in none of the formats or none of the regular monitoring thing, that aspect is noted down. Actually, we are doing and we are capturing this, and few learned dietitians would definitely be capturing over here. But what is equally important that I wanted to know from you, what is in your opinion important? 70 to 80% is monitoring is required or no, and then how are you reassessing? Sometimes you're overshooting the calories and the protein requirement, but you're still seeing a muscle loss happening, or you are even prescribing more, which is not required because of indirect calorimetry not available in our hospitals. So I've asked you multiple things, and I know it's a topic which can go on and on.
Yes, you are right. So my first point is obviously the rounds are taking a different place. They need to be more coordinated. Second, since mostly we see GI patients, they never overshoot their targets. There are always feed intolerance is there, always some absorption is there, they're always undernourished, even during the hospital stay. So regularly they have to be reinforced that they need to consume the feeds, and a proper chart has to be there in the file. Like there's an investigation chart, there has to be a nutrition chart as well, contain a calorie intake that was there, what was the protein intake, which is frequently with the patient, but it has to be documented in the file also. So that suppose many of our like pancreatic, they stay for 3 months. So what was the weight initially? Has the patient how much has the patient deteriorated? What was the calorie intake initially? Is it gradually increasing? Even if it is not still the target, is it gradually increasing? Because the patient is now able to eat well because his pain has decreased. If the patient is on an improving trend, we can be assured that we should continue the same efforts. He will gradually improve.
Seeing that the patients are getting malnourished during the hospital, are we noticing that? Because we are actually not able to meet the 70% of the goals. That's what I'm also saying. One place we are going over the board. In GI patients, the situation is different, but ultimately they're leading to malnutrition. That's what I wanted to know. 7 days, 70% to 80%. That's what the guidelines talk about, and monitoring. How is the multidisciplinary team monitoring that? That is also very, very important.
No, I'd just like to comment. So in India, what I feel, because I'm a pediatric gastroenterologist, what you said just now, we don't do. No one does. We just talk about it in the conferences and we don't do. Especially because whatever happens in NICU, there the dietetics part is completely taken over by the doctors. The reverse should happen in the adult. I don't think adult gastroenterologists, no offense, or the physicians are bothered about the nutrition. In pediatrics, it's 50-50. Whatever the condition of the child, we talk to the dietitian, we ask them to do this and do that, and you know, kind of formulate a plan for the child. So what I feel, whatever happens depending on the medical condition. 4 दिन और देख लेते हैं, फिर देख करके नहीं होगा, then we will do that. You know, then we will do that. That's what happens.
Sir, I think you hit the nail just right there on the head. So this is what is true and the practical scenario, and that is all we are trying to probably bring about when we're talking that these are guidelines, but they need to be put up into the practice. And like you were showing different forms, she's mentioning there should be more things where we can address if the person is in the deficit or probably going towards malnourishment. And I think that should be a part that the dietitian should be taking over and should be calculating and letting our doctors and our physicians know about. And that's the whole coordination point comes into picture when it has to.
Just an anecdote, we had a patient, post-liver transplant patient, and the adult surgical colleagues were asking us to give the child target 25 kilocalorie per kg feed, because that's what the guidelines say. I told them, are you nuts? So because the child needed almost 200 kilocalorie as a target per kg, because as per the expected weight, and the surgical team was not very happy. So adult side, I don't think nutrition is at all as far. Because pediatrician nutrition is kind of our, at least 1/3 of our, you know, whatever the, in every aspect we have to calculate weight, height, you know, growth and everything. So nutrition, even if you don't want to do it, we have to practice.
I would like to comment over here, right? I asked this question only, I wanted to actually dig the Pandora box, and I wanted this discussion to happen. Because things are changing, and I'm talking about MICU particularly, right? That's why open versus closed ICU, I asked the question. When you have an open ICU situation, you need to talk to the consultant, you need to talk to the critical care team. And dietitians generally don't have that much of time. So that compromises. So if you start having a closed ICU when you're interacting with one doctor, this reduces. Second, if dietitian takes a lead and starts capturing the goals, like we have taken a QIP of such in our hospital, so you are seeing that from 50% of the goals which were being met, it is going to the 70%, because the clinician does not have that much of time to give time to the nutrition. It is the role of the dietitian. And that message I wanted to give to the team over here, that this lead has to be taken by the dietitian, and definitely PICU and adult nutrition. Like as a chairperson also, when we switched from pediatric talks to adult talks, so we also have to do a click. So pediatrics and adults are two different game scenarios, and we have to be very careful in what we are practicing.
Thank you so much.
Although the time is over, I just wanted to make a point that, public and private sectors are so different. I am sure, you are from AIMS, only one dietitian who is there, and that's why the time is different, and she has to see the whole lot of things, OPD, wards, clinics, and take a round. She can't coordinate with the doctor. And I know when 88, way back I joined, I was made to, attend the rounds, clinical rounds, which was good for me. But then in that day, I could only attend one unit. because the head of the department will take rounds for one unit. From 9 to 1, I was supposed to be in the round, so I could not see anything else. So this is an occupational hazard. We need to have more dietitians then.
You have to have a team.
Right.
Like we.
I think we'll wrap up here. Thank you so much, Dr. Himanshu. We can go ahead with the next session, please.
So for the next talk, I would like to invite Ms. Harita Shah. She is Chief Clinical Dietitian at Apollo Hospitals, Hyderabad. She has been Secretary IAPN Telangana Chapter for 2022 to 24. She is Convener IDA Telangana Chapter 2019 to 22. And she is Member Board of Studies for Osmania University Nutrition, Faculty Amity Online University, IGNOU and Metaversity. She has been author for Chapter for Enteral Nutrition, formerly in the book for Critical Care Nutrition by IFCCM Pune, and Nutrition Care in the Rehabilitation Setting, Apollo Book of Clinical Nutrition. She has been awarded the Leadership Award in Nutrition by IAPE in 2020, and she has done Nutrition Day Audit Survey by ESPN University of Vienna. She'll speak on decoding myths about enteral feeding in critically ill adults and giving the practical strategies.
Thank you. At the outset, I'd like to thank SAPIN and IPN Delhi chapter for inviting me here. Thanks to the chair for helping me and supporting me in this session. I think my job is very easy today because I just have to sum up the entire talk that has happened. This module has been wonderful with Dr. Singh talking and guiding us about MICU, and I really take note of that. Thank you, sir. Dr. Biju also very beautifully mentioned about how we need to identify which dominant feeding that we are going to inculcate for our patients rather than stopping one and starting one. Most classically, almost in every ICU, we see that one feeding method, whether it be PN or EN, is stopped and only then the other is initiated. And therefore, a continuum of care is definitely lacking. And thanks for bringing that about. And that's a point that all of us can take home, start implementing it, talking about it, and see whether we can do that continuum of care and understand which one is dominant and not forget the other. So I'm going to take next 10 minutes just to overview. Each and every speaker has spoken about these myths, and I'm just putting it all together. We all know that we have a wide range of malnutrition in all our ICUs. Could be ranging anywhere from 38 to 78%, depending upon which kind of a setup we are. If you're in a tertiary care, if you're in a corporate hospital, you see less burden of malnutrition, whereas if you're in more of a community hospital and a general hospital, you definitely see larger patients who are coming in with malnutrition. India as a society has both the burden of obesity as well as malnutrition, which coexists, and therefore, right on day one, we need to assess and understand what kind of a patient we are dealing with. Do we have a patient who's well nourished on hand? Do we have a patient who's moderately at risk? Or we already have a severely sick and severely malnourished patient on hand? And based on that, of course, our strategies will be very, very different. The skeleton in the hospital closet has been described ages ago. So I found this paper which was published in 1974, which is talking about malnutrition as a skeleton in the closet. And even today we are describing and we are battling for the same. So we have a long way to go, and therefore both clinicians as well as dietitians need to understand the real existence of this and see how we can contribute. If you already have a malnourished patient, all that we can do is prevent further deterioration during this short stay that they are in the hospital, and see how we can support them with continuum of care if they are going to be on enteral while they go home. Of course, I'll just address few myths. The first one is delayed feeding. Always there was a concept of, go slow, take time, see if the patients get clinically better, and then think about feeds. And now we all know that early enteral nutrition, as early as 24 hours or 48 hours, is what we are aiming at, keeping in mind that intolerance could happen if you're starting very, very early. Bowel sounds is something that even now in some setups are still looked for and feeds withheld. And this is a common misconception that we have. And therefore, we need to understand that they are no longer the right method, and in fact, feeding could stimulate motility, and enteral feeding itself can stimulate and improve gut motility. Professional guidelines very clearly talk about it, and I think many of us have already adapted to this. I wouldn't put it exactly as a myth, but always we should not consider continuous feeding being superior to bolus. It really could be very, very situational. And the evidence now very clearly coming out that there is no significant difference, at least in terms of mortality or in terms of the number of days that the patient stays in the ICU. And therefore, if the bottom line could be that if your patient tolerates it, he's doing well, you are able to adequately feed the patient to greater than 80% of your targets, then you are good to go, and you will be the right person who's going to decide whether you're going to feed continuously or you're going to feed intermittently. High gastric residual volumes were considered. Guidelines said that if it is greater than 500 ml, you try and control your feeding, reduce your feeding, or try and change the formula that you are going to use to see if that is better tolerated. But we know now that it is an outdated practice. Earlier, we did have protocols even in the hospital where you re-aspirate the feed and check. And then we also were very confused about whether we do it for all our patients, we do it for some of our patients, do we do for every feed if you're doing bolus? And if you're doing continuous, when are you supposed to re-aspirate? Now, with better, clear understanding, we know that we need not check GRVs for all our patients. Even if it is 500 ml that is re-aspirating, you do not stop. You try and do your prokinetics, you try and reduce the volumes, you try and then probably switch to continuous. And even if there are higher volumes or intolerances, then only you think about stopping the feed. So the whole idea is there should be no abrupt stoppage of feeding patterns, and you try as much as possible to continue your feed. Procedural paucity or stopping of enteral feeds is something that we all come across very, very regularly. Prolonged preoperating fasting, especially from midnight, is usually seen and very much unnecessary in most of the patients. And if you see this happening, probably that's when you step up, go back to your different surgical teams and see if we can decrease and shorten this space. Some of us, we still use clear liquids, and that can be post-operatively reduced. However, pre-operatively, you can continue to use clear liquids to at least 2 hours before the start of anesthesia. Solid foods could be permitted up to 6 hours before starting of anesthesia. So, generally when surgical timings are posted, keeping the patient NBM from midnight is common, but that surgical timing may also be delayed. So you have extended hours of NPO status for your patients. So therefore, discussing this as a protocol and trying to achieve the 6 hours feeding protocol for solid feeds. We all know that perioperative carbohydrate loading is something recommended by the ERAS protocol, and based on which patient that you are identifying, we could look at incorporating this as well. Another myth is if your patient is on vasopressors, you do not feed this patient, is the common understanding. Especially the dietitian probably would want to inquire, understand how and when can I feed. But if you're purely going by the physician's prescriptions or the intensivist prescriptions, we will see in the ICU that most of the time we get NPO status orders. And then you have to inquire, understand at least small trophic feeds can be initiated or not. So the idea is you start low. You begin with low volume trophic feeds, which could be 10 to 20 ml per hour. At least it will feed your gut and prevent gastric dysmotilities. It will, and then advance gradually, increase the feed volume, and monitor closely for signs of intolerance, if any. So as the vasopressor dose comes down, we could probably look at increasing your enteral feeds, and that can be the balance that we can achieve. The last part of my talk is summing up what all the speakers said, that when enteral nutrition is unsafe, while every guideline will talk to us about go ahead and feed in 2 hours, 6 hours, or in within 24 hours initiate your feed, we all have to understand that sometimes enteral feeding could really be life-threatening, and therefore we want to be very, very cautious. We don't want to blindly push our policies and protocols, and we know exactly when enteral feeding could be very, very life-threatening. So there are two, I'm just breaking it up into absolute contradictions and relative contradictions. Absolute contradictions is when enteral nutrition should be stopped immediately and would pose an immense risk either for perforation or it could be a life-threatening aspiration. In relative contradictions, you would want to use your clinical judgment, be a little cautious, see if you want to change the type or rate of feed. What are the absolute contradictions? You have confirmed intestinal ischemia, where there is a necrosis risk that is there due to the enteral feeding, and immediate cessation of urgent of the feeds and urgent surgical evaluation and referral may be required. You have mesenteric ischemias, where feeding may precipitate or further progress to full thickness necrosis. You want to be aware of it. This is a condition which commonly seen in the ICU, and you want to be very, very careful, and you don't want to push feeding during that time. Other contradictions could be complete mechanical obstruction, where EN raises the intraluminal pressure proximal to the obstruction and could lead to perforation. GI perforation with peritonitis. Many of them have spoken about it, and we know peritonitis, if unattended, could be very, very fatal, and therefore identify the source control and abdominal washout is immediately required. If you have a high output enterocutaneous fistula, where the outputs are greater than 1.5 ml per day with uncontrolled sepsis, EN increases the fistula output and further exacerbates the fluid and electrolyte derangements. In such situations, you would want to completely stop and quickly switch to PN if you have a severely malnourished patient. Aspiration is something that we have commonly seen, and this again is a absolute contraindication, where you have an unprotected airway with recurrent aspirations, where in spite of all the measures that we have taken, we could have ensured that there is head end elevation, we have given prokinetics, we've even given post-pyloric feeding. In spite of that, if there is recurrent aspiration, then you want to stop EN, secure the airway, and refer to a ENT surgery immediately. Another common condition is tracheoesophageal fistula, which happens much later. That means you have successfully fed the patient enterally for maybe 2 weeks, 3 weeks, and then the patient is having airway compromise. The tracheoesophageal fistula could be a clinical presentation where a long-term mechanically ventilated patient is experiencing recurrent aspiration events despite all the measures. You will need to do a contrast esophagogram, which could reveal a TEF and abnormal communication between the esophagus and the trachea. So whatever you're feeding into the esophagus could be going into the trachea and could be causing recurrent aspirations. And if this is there, you immediately stop feeding the patient as well. Other conditions could be uncontrolled hemorrhage, which is an ongoing GI bleed with hemodynamic instability. In such conditions, you monitor thresholds, you look at your hemoglobin checks if there is active bleed, and stabilization of vital signs, guide timing for feed reintroduction post-intervention. So if you have relative contradictions, which could be seen in severe shock, you could start with trophic feeds and escalate based on how the vasopressors are being de-escalated. in relative contradictions, you will see that either there is intractable vomiting or severe diarrhea. In such situations, obviously, you will try giving semi-elemental feeds, giving elemental feeds, or bringing in feeds, elemental feeds for extremely sensitive GIs, which are available in the market, or in very high GRVs, or even in post-operative delayed gastric emptying. But these are relative, which gives you some opportunity to go cautious, to monitor the patient at your bedside and then take a decision. There could be others which have been mentioned, like you have NG tube misplacement, severe fecal loading, coiled NG tube, the picture which Sir already showed, and all these could also be reasons where you want to prevent enteral feeding, or you go very cautious on it. Tube misplacement is very common, seen in about 2% of the population, could lead to 30% of mortality risk, and this is highly preventable, 100% preventable if we are looking at the right thing. So if you have severe abdominal pain, high output drainage of the feed or the bile, respiratory distress with secretions after feeding, or GI fleed, you would want to take immediate actions. Thank you so much. So the key takeaways would be, you identify what are the absolute contradictions, which gives you clear indications when to stop, relative contraindications, which tell you you want to go slow and you want to be very, very careful and monitor the patients twice a day, and early recognition and intervention obviously saves lives, and you want to reassess the patient as often as you want to. Thank you.
Thank you, Ms. Harita, for such a lucid talk, busting the myths around enteral nutrition. So, any questions from the House or Chair?
So what is the preference, cyclic or continuous? Because in Indian scenario, we all know, and the guidelines keep saying continuous feeding, and we all know it's well established. But still in a lot of ICUs, and with a raise of hand, can I ask the audience here, how many of you have continuous feeding in your ICUs? So probably 10%. How many of you have cyclic? When I say cyclic, which means that you give a physiological gap of 4 hours or 6 hours, so you feed till 12 and then you start at 6. Okay, so I think majority of us have cyclic feeding. So maybe one of the reasons that my ICU, and in our ICU also we have cyclic feeding, well, in my previous hospital we had continuous, so I know with practice that there hasn't been any contraindication per se, we can feed both ways. But one of the reasons that the doctors say is they're worried that the aspiration risk is far high, they want to give physiological break, the metabolic control probably is better. Lately we're also talking about parenteral nutrition getting, making it cyclic rather than continuous. So your take on that?
Yeah, I totally agree with you. Then I'm also exactly saying the same thing, that we can't follow 100% of the guidelines, and therefore you would want to decide. And also when you are looking at data now, data is not saying that continuous is doing far better than bolus or intermittent. Therefore you could choose. Usually you have to step up or change from intermittent to continuous, or rather from bolus to continuous, when you see feed intolerances, and there it really, really helps. Or you would want to give a continuous feed in the night and keep it open for oral intake for the patients during the day. Even in PN, as you mentioned, definitely intermittent feeding, IV infusion helps, because it does not give you the overload of the lipids that you're giving, or it gives some time for the carbs to settle down. Of course, you want to be careful that the patient is not on any continuous insulin infusion as well, because then the risk of hypoglycemia could go up if you're playing around with the timings that the patient is getting. And though we have we're thinking about a very idealistic situation, it doesn't happen like that in real life, and there is a very, very high risk of hypoglycemia.
Another thing that I think we need to as dietitians monitor, because we all spoke about prescriptions. So we all are talking about prescriptions, identifying what is the requirement, acute phase, then as you go on recovery phase. And one of the things that we also want, the effort trial that we're talking, I hope you all have read the effort trial, where they've actually seen the calorie targets and recommendations. Look at the CRP. Because CRP is always available in his dietitians if we understand that number. If the CRP is more than 100, that means the patient is in acute catabolic state. The patient would not benefit so much with a higher calorie. So probably go slow, because then you have to do like yesterday also we had this conversation. We do not know when is the patient transitioning from acute to the recovery phase.
Exactly.
There is no clear demarcation to say 1 to 2 days. There may be times when the patient progresses on 4th or 7th day. So I think the take home for all of us would be monitoring, because every day is a different day, and this 5-day concept is beautiful. I think we can all try doing that. Thank you, Harita. It was really wonderful.
Thank you.
Yeah.
Thank you, Ms. Harita, once again for the wonderful talk. We'll move to the next talk.
So at the outset, I would like to thank SAPN, and I would like to thank you, PC Sir, Shiva, and Shilpa Square, Shilpa Thakur and Shilpa Verma, for giving me this opportunity. And the topic that I would be chairing is very close to my heart. And a dear friend, Zamrood Patel, who's a chief dietitian in Mumbai and does not need any introduction because she's a noted name, would be presenting on the topic reformulated tube feeds. So she has a lot of academic activities in her kitty, and she's a chapter convener in Indian Dietetic Association, chapter guide and co-guide for graduate and postgraduate students at SNDT University, Mumbai. And she has presented many lectures in national conferences and seminars, and she has a list of awards both at national and international levels. So over to you, Zamrood. And when I talk about reformulated tube feeds, lot of things come in the mind. Are you talking about blenderized versus commercial, or only commercial reformulated? So let's hear it from you.
So firstly, at the onset, I'd like to thank the organizing team for having me and giving me this topic. So to answer your question, Charu, we come from a corporate setup, and at my setup we are 100% scientific formula. So my talk is also focused more on the enteral tube feeds which are available in the market. So can I have my slides? Yeah, thank you. So indeed, these from yesterday I am hearing, and I have really gained a lot of information on enteral, parenteral. We do practice it on routine basis. And the first thing then when a call comes from a ward or an ICU that the patient needs to be fed enterally, the first thing that comes is a standard polymeric formula. So we all start with that, and guidelines guide us for it. But today in scenarios where we have to be specific, and I again will talk about PC Sir's talk of precision nutrition yesterday where he spoke. So probably today these reformulated tube feeds are important in this type of scenarios that when we see, and case to case basis probably we may need to add them. So what are reformulated tube feeds? Basically these are modified enteral formulas designed for specific nutritional needs of patients with particular diseases. Probably it could be disease specific, metabolic disorders, or physiological conditions. So you may have to alter in these reformulated feeds the macronutrients, the micronutrients, osmolarity, or probably the energy density. So there is a wide spectrum that you see when you see the reformulated feeds over here. Now, why do we talk of reformulated feed over the standard feeds? Why are we looking at those? Probably to get a better GI tolerance. And Lekha wonderfully in her talk said that the moment there is diarrhea, the first call goes to the diet department that what have you fed? So probably to get a better GI tolerance, probably you can create a better, you can have with this reformulated feed a better type of protein or the volume of fiber that you can give. You can optimize nutrient composition for specific diseases. Now I see more of transplants, I see more of renal disorders, liver disorders. So probably these type of scenarios you may need to treat with the proteins. So probably if you have a formula where you just have to calculate and see rather than using the standard formula, this formula would really help us to get the right nutrition for our patients. Replace older ingredients with clean labels. So now here the example is use of resistant starches today in the diabetic formulas. Okay, and again you need to align it with the new guidelines. As guidelines change, Obviously, we don't say that they are the gospel truths that we need to follow, but they are the ray of knowledge that we get, and we can follow them, and we can again use them for the benefit of our patients. So that is why you need to reformulate these feeds. Now, when we are talking of the need of reformulation, possibly you can see that it could be disease-specific needs, it could be the fluid restriction. So probably sometimes in the ICUs, like in our transplant ICUs, when we go for our rounds, we keep asking, okay, this is the total volume that the patient has to receive. So what is my share? How much feed do I have to feed? Because I have to give a high calorie, high protein to the transplant patient. So for fluid restricted patients, again, this really helps us. Again, when there are malabsorptions, like if you have a diarrhea probably from a polymeric formula, I may shift to a semi-elemental peptide-based formula. So there is a need for all these reasons to prevent hypoglycemia or hyperglycemia, the protein needs. So there are vast number of needs because of which today you need these reformulated tube feeds, and this is basically the key composition that you really see. Now, when I'm talking in terms of proteins, so earlier we had whey, we had casein or soya, but today there are blends available. So today there is a lot of products in the market which are plant-based protein products which are available. Different compositions of proteins today we have, it is getting us availability to for our patients. The type of fat that you used to get, you only got long-chain fatty acids. Today you have products with omega-3, you have products with MCTs, which are useful for our patients. Again, for carbohydrate, I already specified. For fiber, today you have soluble fiber added to the products. These are formulas are available. And again, the micronutrients. So a lot meets the patients that had, and we used to keep, calculating in our diet plans and trying to put things here, see formulas. Today, a lot of flexibility we get with the use of these formulas which are available in the market. Now, when I'm talking of the methods of reformulation, basically, as I've told you, you could have modular components, like if I have a standard feed, I may just blend for increasing my protein, some supplement which is already available to add the protein, or probably even mixing or dilution of two scientific formulas. This normally, in our setups, we normally do it with our liver and kidney patients. With the standard formula, we try and use another formula. So blending can be done. You can adjust the concentration, so you know exactly what is the osmolarity of the products. Like supposing somebody has a diarrhea, I can change the dilution of the product. Or if I have to concentrate another, maybe I can reduce the volume that I have to use. So that's how I can basically use. And Charu, what you were asking, even in long-term use of enteral nutrition for home-based that we practice, even your blenderized feeds, use of these reformulated tube feed formulas can be incorporated. But probably a word of caution here that you need to be doing is, you need to know the tolerance. When you introduce these things, you need to check the tolerance. You need to check the tolerance. You need to know the biochemical profiling of your patient. You need to do your assessment. So it's not that you just do nutritional screening and assessment. You need to reassess. That's there that you need to know about. And not only reassess when you're talking about the composition of your feed, but also the intake output. Many times, when we go to the ICU, the first thing is we see is the intake output charts also for our patients. That's very important. Again, the safety protocols, everybody knows these feeds need to be made in an aseptic environment. You can cause contamination to them. Again, you need to check the compatibility of the different ingredients that are there in that and whether your patient tolerates it. That's also important. And again, you need to know the viscosity of the product. Now, having said to that, there are limitations of these reformulated tube feeds. The biggest one is the higher cost. And I would here love to talk like what Biju sir said in the morning. Everybody sees the price of the product. But overall, when you have to recalculate with the length of stay of the patient in the hospital and all, probably this would not look so big. But again, availability of these products. There are many centers. We come from metro cities. We have access to many things. But when we look at 2-tier, 3-tier cities, these products may not be available. Again, there is a risk of over or under supplementation. So you need to make your prescriptions very well. You need to know what is the nutritional requirement based on your assessment, and based on that you need to calculate, and then you need to, when you're planning and giving these formulas, you need to see that how much the patient will tolerate. That's very important. And again, the palatability, because some of these reformulated formulas may not have a good taste. And again, in Indian scenario, if I have to look for an Indian patient, the first thing that is always asked, मुंह से नहीं खिला सकते क्या? So that's the first thing that you hear. So sometimes even that taste and is something that you really need to look. But looking at the benefits of these reformulated tube feeds, it's something that is giving us today dietitians that flexibility that you can reach your nutritional targets. That's very important. For example, for a disease-specific one. So in renal cases, I take that. Even in liver patients where you need to add. So today MCT is available, you can add, and there are formulas today, reformulated liver-specific formulas which are available, which are high in medium-chain triglycerides, which are good for our patients. It improves the tolerability of the patient. That's very important. You can give the right prescription to the patient, and that is something that is supported today with evidence. That's very important. And again, when you're talking of the fluid and energy management, earlier we used to have products which were there standardized, which would only give this much calorie and this much protein, and I quote here Shiva. Yesterday Shiva in his talk beautifully showed that for 3 cases, one standard formula, can it be used or it cannot be used? You cannot use it. So today we have the flexibility because of these products that you can actually make individualized prescription. That's very useful for us. So again, talking a little bit, when you're talking of reformulated tube feeds, today there is a huge use of plant-based proteins in these type of feeds, and definitely if you look at the traditional formulas that we had, they were milk-based, casein, whey. Of course, we did have soya, but now today we do have these formulas which are more plant protein based, and they are doing good for our patients. Again, when you're looking at it, people who have lactose intolerance, or you have a lot of people with different allergies, milk allergies today, probably you may not be able to use the standard formula, so you can use these plant-based reformulated tube feed formulas. Again, today a lot of vegan and vegetarianism is going on, so people, you respect their values, and you have today products available that you can give. And these plant-based ones are higher in fiber, so they are good for your gut health also. So these are the basic uses of this or benefits of a plant-based. So what are the common plant-based? So I was aware of soya isolates, peas protein, rice protein, oat protein, but when I was reading literature, I came across this potato protein, which they say has an excellent amino acid profiling and is hypoallergenic. So probably these are some of the newer products or the plant-based proteins which we are getting products today, and of course these products are available in the market. If you look at the micronutrient composition, it is similar to your other products that you have, enteral products which are there for proteins, fats, but only thing is even fiber today it is there. So only a word of caution when you're talking of micronutrients. Because when you talk of plant proteins, they are deficit in certain nutrients, micronutrients like iron, zinc. So you may need to look at these feeds, and these feeds need to be fortified on, again, if these products are available, the bioavailability to the body when you're using this is something that is a challenge. So probably when you're looking and picking these plant-based protein feed diets for your formulas for your patients, you need to pay attention to the micronutrients reformulated feeds. So there are an n number, but today technology has made it simple for us. These products, these micronutrients can be added. You have a vast variety of these formulas available in the market that you can actually use for your patients. Now only, as I've already earlier told, the indications, probably people with allergies, people who are vegetarian, and probably people like who have renal or hepatic or onco patients who require specific amino acid patterns. Probably these type of feeds are really going to be useful for us. Only the points that you need to consider, that when you are blending even different plant proteins, you need to know the compatibility and how well they are blended. And again, whether your patient is going to tolerate that, you have to again see all these factors when you are going to use these feeds. Benefits, as I've already said, this has a higher % of fiber, so it is more gut friendly, these plant proteins, and we should be looking at them today to get a better quality of proteins for our patients. Now, I've spoken about reformulated tube feeds when you're looking at the plant-based, and the second aspect that we need to cover is when you're talking of special disease conditions. So when you're talking of special disease conditions, probably again this is a boon for us. To be very honest, when we are seeing our liver ICUs, our transplant ICUs, our renal ICUs, probably these special formulas really help us to plan and give the right nutrition to the patient. I've just put a few slides on some disease specific that we routinely use. Renal. So in renal you have two parts, you have dialysis and CKD. So when you're looking at a CKD population and you need to use a reformulated one, it's a low protein formula. But this formulas, both, whether it's fine for dialysis, it's a high protein. But these are modified when it comes to the fluid. These are having low electrolytes, so that is something that you need to pay attention. So even a word of caution when you're trying to modify, like somebody has a low protein, like many times it happens pre-dialysis they have that formula, and post you need to change it and you need to explain this to the patient. Similar is the case with hepatic, where you need high protein, you need to give more of medium chain triglycerides so that the energy requirements can be fulfilled, and you need other micronutrients which these formulas are fortified. Again, we had a case, somebody discussed about pancreatitis, probably there you need a semi-elemental peptide-based formula, and we have these products available in the market. For diabetes today, you have reformulated formulas. Instead of using maltodextrins, they are using resistant starches and other substances, adding the right type of fiber. That is also helping us. Again, for cancer, Shiva beautifully explained yesterday how to pick the formula. Even so there are certain ingredients or molecules that need to be there. For example, omega-3 for anti-inflammatory property. So these type of special formulas in special disease conditions should be utilized, rather than only sticking with standard polymeric formula. And even if you're using that, maybe you can just blend the two together. So this is just to show you the gist, that clinical benefits of these formulas which are available. So to summarize, reformulated tube feeds are targeted nutrition therapy. These feeds reflect clinical nutritional needs of our patients. Monitoring is very essential. At every stage, monitoring and assessment needs to be done, and this is a way of actually proving the precise nutritional management and giving the exact precision nutrition for your patient. So thank you for your patient listening.
Thank you, Zamrud. You have actually captured everything really well. So before I go to the audience, if they have questions, we somehow or the other practice this reformulated tube feeds. Even in Kyle-leak patients, you don't have a standard formulas available. Correct. So you need to meet the protein requirements and low-fat requirements. So I just wanted to know from you, between the doctors, nurses, and the FNB, like even if it is a steward who's making the formulated formula, how do you ensure the communication gap and the compliance to these reformulated formulas is what I wanted to know from your experience.
So if you are asking me, all these feeds are reconstituted in our wards. We have a special area, and this is not done by the FMB team. This is done by the nursing team. So that's why we normally have the same protocol what we were discussing. We give them the plan for the day, and we have two rounds in the hospital. So not to miss, or to have a communication, because the morning nurse you inform and you go that this is you have to give, and afternoon the shift changes and the evening person may do. So to avoid this, I think this multidisciplinary team and our commitment to seeing these people at least twice in a day, minimum twice in a day, is something that I have been using, and documentation. That's very important.
Agreed. What I am seeing is with every talk moving forward, a need of a nutrition sheet, because every talk is leading to that, is the demand, not only the critical care sheet, but a complete nutrition sheet where the nurse does their job, the doctor does their job, and the dietitian does their job, and communication would improve. So I would like to ask audience if they have any questions, or any chair who would want to make any comment.
I think the one thing I wanted to put this for everybody, what we do is we actually calculate the dose. For example, if you're saying 6 scoops, that is 50 grams. Yes. Then we see how many boxes. So the dietitian can easily, if you have HIS, you can check how many boxes were indented. As you prescribed, we have BCMA, which is barcoding. So we actually prescribe it on the system, and then we see how many boxes were consumed. So irrespective of whatever is written, if you prescribe one box, whether one box was consumed or not, and it ensures that whatever you've documented is actually done. So you could also do that. Rather than checking whatever, you see if 4 boxes were to be finished in 4 days, were 4 boxes were indented, did the pharmacy give that much? So that's something that you can do.
Yeah, good.
Exactly. So the nurses are supposed to be, in our hospital also we have bedside recomposition, reconstitution. So what we do is the nurses are supposed to write the date and time of opening. Normally they do write expiry. They're used to writing expiry for medicines. We tell them they must write the date and time of opening. So once you know it was indented and opened at, let's say, 10 o'clock in the morning, the next day I went on rounds and the same box is still there, then how is it? So on day-to-day basis, you can check that. And if you want to see cumulative, then you can easily see ki 3 din mein kitna use hua. That's what our doctors check, that's what we check, and that's what nurses are also auditing. So that can be one way of checking the compliance. Thank you.
Yeah, we do the same, Sandhya. For our hospital, I would like to thank Zamrood for a wonderful talk. And I would just wanted to give a message to all the dietitians. There are some doctors, especially in tier 2 cities, and there are still doctors who talk about blenderized formulas. Though I'm not against blenderized formulas, they are also equally important. But monitoring of any formulas that you do, whether it is reformulated, whether it is 100% commercial, you need to add value and you need to read and upgrade yourself so that when the doctors are there on the rounds, you are able to tell and you are able to value add as a dietitian rather than just following what the doctors say. So thank you.
Thank you.
Over to the new session.
So it is an honor to be the part of this conference. Thank you organizers, SAPNCon, Shilpa Verma, Shilpa Thakur, all of you, and thank you for having me here. I would like to introduce Ms. Ipshita Chakraborty. And again, she needs no introduction. She's been here with us for a long period of time. Her experience spans over 27 years. She's the HOD of Dietetics Department, CMR. Her qualifications, you can see, covers pretty much everything, and she's worked in various leading hospitals in her career and has held multiple LLL certifications from IAP and ISPIN. And she's also a FODMAP certified dietitian. So thank you so much, Ipshita, and looking forward to an excellent presentation that I'm sure you are going to deliver. Thank you.
At the outset, I would like to thank SAPN organizing team, Shilpa, both the Shilpas, Pisisa, Shiva, of course, I can't find him in the hall. Oh, you're there, I'm so sorry. So, and of course, organizing such a beautiful event. But I am the last speaker before lunch, so I am standing in between a sumptuous lunch is waiting for all of you and my talk, and that also I'll be talking on IBD, which is again related to GI. So we all know what IBD is. It's characterized by flares of inflammation with a periodic need for increased medication, and sometimes it requires surgery also. The etiology of IBD is partly attributed to a deregulated immune response to gut microbiome dysbiosis. Different studies have revealed that microbial signatures for different IBD subtypes, including ulcerative colitis, colonic Crohn's disease, and ileal Crohn's disease. The precise pathogenesis of IBD remains unclear because not many researchers are still required for that. But the most accepted hypothesis is that environmental factors trigger an abnormal immune response against the gut microbiota in genetically susceptible hosts. Various environmental factors could affect the intestinal microbial homeostasis. So diet and microbiome, so different diets because of the social media and because of some subject knowledge also. So lot many types of diets are also used by people like Western diets, Mediterranean, semi-vegetarian, anti-inflammatory, FODMAP diet. Lot many diets are there, gluten-free diet, but it directly cannot have a direct effect on IBD. So its exact mechanism by which the dietary intervention affect IBD still remain unclear. Some plausible explanations are like the diet may modulate mucosal barrier function, which is critical factor in the pathogenesis of IBD. The diet may be involved in the inflammatory response and immune functions. The diet may contribute to shaping the gut microbiota and its metabolites. So malnutrition and nutritional deficiencies in IBD, because IBD patients, when they land up in hospital and ICU, and even before that, when they come to us for, to the doctors in OPD, even for, they meet us also, they are already malnourished, because whenever they are having some symptoms regarding some GI symptoms, they stop eating so many things and they apply their own thought process, they are already malnourished. So data suggests that malnutrition may affect approximately 65 to 75% of with CD Crohn's disease and 18 to 62% of patients with CD, this adult patients basically. So what can be the reasons, like suboptimal energy intake, increased basal energy expenditure, malabsorption, and GI nutrient losses. So malnutrition in IBD patients can result in severe adverse clinical outcomes like higher mortality rate, increased length of stay in the hospital, surgery, infection rate, and even though like thromboembolic events than those without nutritional deficiencies. So malnutrition, we all know that is a predictor of poor prognosis in hospitalized IBD patients. So this is a little busy slide, I'm just skipping it, I'm going to the next slide. IBD increases risk of malnutrition. So this is, you can say it's a vicious cycle sort of a thing. The reduced in nutritional intake, anorexia, nausea, pain, restrictive diets, increased nutrient losses, malabsorption, diarrhea, vomiting, fistulas, intestinal protein losses. Some surgeries can be there which, because of which some reduced absorptive areas and short bile is there. Medications, corticosteroids, food-drug interactions, drug-nutrient interaction is there, and increased nutritional needs, inflammation is there, post-surgical situation is also there. So in hospitalized, 40 to 70% are reported as malnourished, and 20 to 50% of IBD patients in OPDs. So there is a study, Canadian study, which showed that malnutrition in IBD patients increased their hospital mortality, length of stay is increased, and of course, in combination with everything, total cost of hospitalization increased. IBD patients with low albumin, like higher rates of wound infection and anastomotic leak, increased risk of anti-TNF failure. So importance of addressing this disease-related malnutrition, dearth of studies about the utility of nutritional support, better supported in other at-risk population like cystic fibrosis, aggressive nutritional rehab is required which increase the average life expectancy, surgical cancer patients and hospital malnourished for elderly. So these are the malnutrition, why this is required basically. Why to address malnutrition in hospitalized patients. Challenges in recognizing malnutrition in the hospital, then Aspen and Academy of Diagnostic criteria like weight loss, loss of muscle mass, fat mass, edema is there, insufficient energy intake, and we usually use hand grip dynamometer to check the decreased function. So most of the time this is not exactly, this cannot replicate whether that particular person is malnourished or not. So this is Crohn's and Colitis Foundation pathway, screening, who are at risk, assessment, intervention and monitoring. So after screening all the IBD patients, usually malnutrition must is used for those patients. While screening who are low risk, no action is being taken, who are moderately at risk. Assessment like PGSGA is used immediately or can consider observation or education or follow-up within 1 or 2 months. If it's high risk, nutritional status immediately has been checked. And PGSGA, if it's within 4 to 8, the routine checkup, and if it's more than 9, it has to be considered, and dietitian assessment, multidisciplinary intervention, dietary education, counseling, enteral and parenteral support needs to be decided, and last but not the least, monitoring is extremely needed. Most of our hospitals are either NABH accredited or JCI. So I believe in that. If nothing is documented, that means you have not done it. So whenever we are assessing a patient, we are addressing the patient, we are prescribing something to the patient, it has to be documented, so that, as all our chairs are also saying, that doctor, dietitian and nurses all are not together in the ICU because of maybe dearth of manpower, maybe because of time management and all, we are not always together. But there has to be documentation in which has to be, so that doctors, whenever they are coming, they can see what dietitians have prescribed. Even nursing can follow what we have prescribed. So these have to be followed specifically. So now comes to the therapeutic strategies in IBD. Enteral and exclusive enteral nutrition. So this term used when describing use of enteral nutrition through an enteric access and through some device, which is we call the feeding tube basically. Common access device, nasojejunal, gastrostomy tube, jejunostomy tube, not many tubes are also used. Generally used for those where adequate nutrition is not possible via oral means, can provide any amount of calorie intake depending on the oral intake adequacy. There is no sufficient evidence to support the use of disease-specific formula for IBD. SPM says that polymeric formula is absolutely fine with a low-fat polymeric formula to be given to this sort of patients. But we need to look into the blood workups on a regular basis or regular intervals whenever patient is undergoing any blood test, so that depending on that, we can decide on the formula if it's needed, what Zamrud was saying just prior to me, that it can be changed depending on the blood parameters. And exclusive enteral nutrition generally prescribed via oral route but can be offered via feeding tube also. No other food or oral means are allowed. 100% calorie intake is consumed via oral supplement or polymeric enteral support product. Oral nutritional supplement should be calorically appropriate and meet estimated needs for protein. Does not need to be an elemental formula. As I already said, okay to use intact protein formulas also. This American Gastroenterological Association in Clinical Practice Update on Diet and Nutritional Therapies, they have said that EEN, exclusive enteral nutrition using liquid nutrition formula, is an effective therapy for induction of clinical remission and endoscopic response to CD with stronger evidence in children than adults. But ESPN also saying here that IBD diet, there is no specific IBD diet where remission can happen. So once a IBD patient, we can't say it's like sort of, even these days diabetes also we are saying remission of diabetes. So the IBD also we have to, that particular patient have to consider that person is an IBD patient and they have to continue his or her life accordingly. So EEN is a nutritional therapy that involves consuming a complete nutritional liquid formula as a sole of source of nutrition for 1 to 12 weeks. Formula is usually taken by mouth, can also be infused via enteric tube. So the selection of the formula depends on the indication of use, patient history, allergies, budget, tolerance, taste, ingredient preference, and of course availability of that product. So induction of remission already I have spoken about. So corticosteroid therapy has traditionally been used to induce remission in active IBD, while often effective and short and long-term side effects including hyperglycemia, fluid retention, changes in mood, insomnia, hypertension, glaucoma, cataracts, osteoporosis, avascular necrosis, not many things can happen. So EEN provides an opportunity to limit steroid exposure and has the added benefits of nourishing the individual, correcting dysbiosis seen in the active disease, decreasing inflammatory cytokine production, and promoting mucosal healing. EEN can be particularly beneficial for those desiring to avoid steroids, those who are intolerant to steroids, and of course who are pregnant. So practical applications, that is being already discussed. The optimizing success with EEN therapy involves much more than writing a prescription for EEN. A clinical dietitian who is experienced in IBD and experienced with EEN is a vital member of the care team who can provide comprehensive nutritional assessment and guide the patient who are appropriate for and desire for this EEN therapy. This is an EEN algorithm depending on the type of IBD type, maybe CD, maybe UC. So for CD, consider EEN 6 to 12 weeks, which I have already said. And for UC, for active patients, consider at least 1 week of EEN. If planned for surgery, for malnutrition, or if the patient desiring to avoid steroid therapy, consider EEN for 4 to 6 weeks. So patient has to be ready to accept the surgery, has undergo the surgery. Prescription, once the nutritionist prescription has been developed, the next step is in initiating EN is to choose the formula. So what we need to consider, nutritive value of the content of the product, the cost, availability, allergies and intolerance, medical or surgical history, palatability, patient preference when selecting the formula. It may be beneficial for the patient to try multiple formulas options before deciding on which to use for the EN treatment. Depending on the tolerance and the cost, of course, we need to consider. Introduction of the formula, the patient should be provided with instruction on how to start the EN. If the patient regularly consumes caffeine, he or she may want to wean off caffeine in the days before starting EN to avoid caffeine withdrawal symptoms. The approach would be recommended if the patient severely malnourished or at high risk of refeeding syndrome. Strict adherence to EN should be encouraged. No other food should be included when patient is on exclusive enteral nutrition. So transition is not a sustainable long-term therapy for most of the individuals. So there is a lack of evidence to recommend an evidence-based specific strategy for food reintroduction after EN. Discussions about how to transition off EN can happen at any point during patient's journey, but should commence prior to the end for that EN. And in conclusion, is a safe journey, effective therapy for IBD with the potential to induce clinical, endoscopic and histological remission, heal fistulas, and when used perioperatively to improve nutritional status and surgical outcomes while avoiding steroid effects. So thoughtful implementation of EN guided by and supported by the multidisciplinary IBD team is likely to maximize adherence and therapeutic success. Thank you for a patient hearing.
Thank you, Shepshita, for the wonderful presentation. You highlighted the prevalence of malnutrition in the IBD population because they're perpetually afraid of eating, they're confused. So this is a subset of patients who certainly require us to assess them, how malnourished are they when they are hospitalized, then following algorithms, whether it is Crohn's or ulcerative colitis. Crohn's, we need to be really concerned about the micronutrient deficiencies. Of course, macronutrients will have to be taken care of. And then you spoke about exclusive enteral nutrition. Now, exclusive enteral nutrition is again a tool in the hands of dietitian, because a lot of us who are practicing in gastro patients know that these parents of pediatric population are extremely concerned. They don't want to start steroids. And if they are educated, certainly there are very good studies to say that if you give exclusive enteral nutrition for 8 to 12 weeks, these are compared to steroids and you can probably get benefits, and there are good studies. So, and it doesn't necessarily require you to put in a tube, you can give through oral also. Very difficult to do because the patient is, and this is more, the studies are in pediatric population, the results are in pediatrics. So thank you, Ipshita, you covered everything in such a short period of time. Thank you so much. Any questions anybody wants to ask in audience, or any comment that, yeah.
So, I'm a pediatric gastro, as I mentioned earlier. So I will take that liberty because I don't see any other pediatric gastro in the house. So I just wanted to know how many of you have advice about the exclusive pediatric in a pediatric population or in a patient. Yes.
Sir, I have completed around 70 patients pediatric Crohn's disease with exclusive enteral nutrition. That's my PhD topic also.
Okay.
And we do for 6 to 8 weeks. So it's successful in the pediatric population. My youngest was from 2 years of age. The youngest child was 2 years and we had till 17 years. So this population.
No, just fine. That's what I wanted to highlight. It's a very difficult thing to do because it's very kind of time consuming. You have to counsel them because recently I have a 12-year-old child who had Crohn's. I advised him because nothing was working. Anyway, we found some other cause for his Crohn's. And when he came to me after 6 weeks, he asked me whether he will be able to eat rice and dal or not. That was his question because after meeting me. So that it could be very difficult. And we don't have many formulas available. What we normally use, either Peptamen or Pediasure, because in the worldwide the formula which is most commonly used and most of the studies which have been done is Modulin, which is not available. And apart from that, just remember, the enteral nutrition is not about ulcerative colitis much. Ulcerative colitis is mostly iatrogenic malnutrition, which we see because of the restrictions and because of blood loss, continuous blood loss and everything. It's the main role is in Crohn's. And because the Crohn's involves small bowel predominantly, that's why the main role in Crohn's, just to understand. And they will have the both malnutrition as well as they will respond to exclusive enteral nutrition. So the role is mainly in Crohn's. That's all. Thank you.
Thank you so much.
Thank you. Thank you, organizers. Thank you, everybody.
On the behalf of organizing committee, I would like to express our sincere gratitude to all the insightful presentations and thoughtful discussions which had made this session very, very expressive and very, very knowledgeable. I hope you have gained the knowledge regarding the session, and I hope you would be practicing the same. Thank you, everyone. Thank you, our chairpersons and speakers. Thanks a lot. And one more thing, as we are running little late, so the lunch is open for 2 to 2:30. So 2:30, by 2:30, I want everybody to be in the hall. Thank you.
Okay, welcome back. I know it's the post-nap tempting, nap session, but this session is going to be better than a cup of coffee, I suppose, right? So starting with the session on emerging trends and technologies, new technologies like artificial intelligence, blockchain, Internet of Things, and 5G are changing the way we live and we work. Virtual reality and augmented reality make learning and entertainment more interactive, while green technologies help protect the environment. So, starting with this session, we welcome our chairperson, Dr. Bhavna Gandhi, on the stage. She is Chief Dietitian at Lokpriya Hospital, Consultant at Meerut Cancer Hospital, and Director of Omnibus Healthcare. So please welcome please welcome Dr. Bhavna Gandhi. Can we have a set of applause, please?
Good afternoon, one and all. I know post-lunch आकर बैठना is quite difficult. So आप सब पानी पी लें, that is required, because after hypo एकदम से जब खाते हैं तो gush of sugar जाता है. So we have our eminent speakers जो आपकी नींद खोल देंगे. So the first of all, I'd like to welcome Dr. Sanjeev Sharma. Sir is a competent and a versatile medication management research and administration professional with extensive experience of over 24 years in setting and managing multiple functions in Apollo hospitals,
Currently, he is working as a clinical pharmacologist and pharmacovigilance and meteorovigilance center coordinator. Sir has Doctor of Medicine degree in pharmacology and an MBBS degree. He is an internal assessor for Apollo Hospitals for Medication Management and Ethics Committee, inspections for clinical trials. He is having 19 publications in reputed journals and 6 book chapters to his credit. We welcome you, sir. Thank you very much. Over to you.
Thank you, ma'am. I know after having such a nice lunch, right, this will be the condition. That's the challenge for me. Yes, let me see what can be done for this. I'll try my best. So you know what's the goal of parenteral and enteral nutrition. I need not tell you that we maintain adequate nutrition, we support anabolisms, and we prevent deficiencies of fluid, electrolyte, vitamins, and trace minerals which you do day in and day out. And as you know, nutrition status is very, very important, is as good as like another drug. Probably time will come when we'll say one of the drug is nutrition. That soon is going to come. And already it is very important aspect. And we give it enterally and parenterally for long term and short term. So when you give either enteral or parenteral, it shares the same delivery pathway with my medications. That's where the problem starts or the challenges starts. Along with, you must have heard yesterday you were discussing nutrition in renal failure, liver failures, short bowel syndromes, and obesity, malnutrition, the alteration of pharmacokinetic aspect. And there are certain drugs which will reduce your vitamins, their levels, and there are a lot of drugs which are going to alter electrolyte imbalance, making your job more difficult. And this alteration in electrolyte imbalance is going to affect my response to other drugs. So what's the basic mechanism how this food and drug interactions happen? One is affecting the blood flow in your gut. When you make more blood flow, there's more absorption, not only for nutrition, for drugs also, and affecting that. Second is chelation of my drugs by calcium and iron, which you give through your nutrition. And there are certain, like vitamin K, that antagonize the effect of very important drugs like warfarin for me. When you change the pH in the GI tract, it is going to alter absorption of the drug from the stomach as well as from intestine. There may be changes in metabolism of my drugs, and the nutrition may also change gut motility, and that any change either through drugs or through nutrition, that is going to affect the absorption of the drugs. All the literatures, what we have regarding the drugs is, we don't have this route when we do clinical trial through nasogastric tube, what you use for enteral nutrition most of the times. And these are results of different surveys where these questions were asked to different people, and there are a lot of knowledge gap. When to start the feed, how long I have to stop when I have to give phenytoin through the Ryle's tube, how much volume to be given, what will be the dilution of these particular drugs, how I will do my pharmaceutical need assessment when you are giving your feeds through the Ryle's tube, what will be the different drug incompatibilities with parenteral nutritions, what are those drug interactions which may happen when we give a total parenteral nutritions. Is there any warfarin resistance when we give TPNs? These are the things probably during this we will see. What happens if you involves in your care, become a part of the team, and pharmacologist or clinical pharmacist is part of the team, what you can achieve. He is the one who can advise what is the best route for those particular drug when you are giving enteral nutrition. If you want to change the route, what other route can be given, what will be the different timing of this particular drugs, what need to be monitored, what toxic effect may come, what efficacy parameter, and providing knowledge to the nursing team, important part of multidisciplinary team. And when discharge happens, educating the patient and healthcare providers the different administration technique of medication when nutrition is going on in the house. Very important is when you are using enteral nutrition, that route you are using and you are giving continuous feed, first thing we need to ask is this my medication important? Can I stop this drug for some time? That's the first thing. Or I can use the alternate route for this particular drug. There are many drugs which can be stopped. Like statins are drugs which you can stop for some time and later on you can restart. Warfarin is the drug. If possible, we try to give through subcutaneous route, low molecular weight heparin or IV infusion if patient is in ICU. Or there are certain drugs like hormone replacement, myoinhibitors or certain ACE inhibitors, alternate drug we have to use in those cases. Alternate route, IV route is a preferred route in such case, but it is very costly. The cost of the therapy goes up. You have to see, can I use a transdermal route? Can I use rectal route? Can I give my drug through nebulization? Can I use subcutaneous, intramuscular or infusion? Buccal, sublingual route of different drugs can change. So that I don't compete with your nutrition in the gut. That's the whole idea of this. Gelatin capsules and similar preparations, many times you may not have exactly same drug. I will like to substitute my drugs. Somebody is on sucralfate syrup, I will prefer to give him Rantadine rather than sucralfate when somebody is on this. When somebody is taking tablet Biscodel, I will give him suppository rather than tablet. So that's a different route for doing this. What happens many times, we stuck up, you have to use the same route what you are using for the feed. The problems start at that particular, and you will find that there is a lot of drainage also happening in that particular time. What is the best time? So best time is when you have done, remove those aspirates and immediately you will give drugs for the time to act when you are doing such things. And we always use, when somebody is on Ryle's tube, lot of cisapride or metoclopramide, erythromycin drugs. And very important aspect is looking, three aspect is, one is type of tube, it is a narrow bore tube or wide bore tube what you are using, where it is exactly placed. Is it going up to stomach, going up to jejunum, or which place it is going, very important. And where is the site of absorption of my drug. Remember, no drug is licensed and there is no clinical trial when we give them through enteral feed. So there are expected lot of ups and down. Very, very important. More the fine bore tubes, they are unsuitable for thick liquids, dispersible tablet. They are the one which are going to clog them. And once they clog it, you have to use, the cost will go up because you are going to put percutaneous endoscopic jejunostomy, PEG tube. You have to go and better you use alternate, as I told, and there are many drugs. If there is a PEG tube like digoxin, ketoconazole, phenytoins, and many anticonvulsants are not going to get absorbed because you are bypassing the stomach there. If you see carbamazepine, the enteral nutrition formulations, their interactions, you, if possible, try to give suppository of this. Is still not possible, you can use the liquid formulation of this and proper dilutions. Digoxin, if you have to give along with enteral nutritions, better to use syrup and diluted syrup of that, and you have to monitor the drug level of this particular drug. If you are giving lithium, you have to give multiple times, frequency will increase, and you have to monitor the levels. Similar way for levodopa, we have to multiple times you have to give, frequency will increase. Phenytoin, we'll discuss in great detail because this is a drug which causes lot of issues when you are using enteral nutrition along with this. PPIs, we know lot of PPIs we give. Lansoprazole suspension is too viscous to be administered through enteral tube, and sucralfate liquid if you are giving, it causes Bajor formations which is indigestible concretions which may affect and clog the tube also. Appropriate, you have to change the different drug for such particular therapy. Augmentin syrup, very commonly given, you have to use double the dilution, half the strength of that particular drug. Diazepam cannot be used, even liquid cannot be used because it get absorbed on the tubes what you are using for feeding. Very, very important, and there are certain different salt of the same drug which can be used when we are converting them into liquids, can be used. Very important, what we don't look into is sorbitol content of those liquid preparations, because it causes diarrhea, bloating, stomach cramp, delayed gastric emptying, and your nutrition get blamed for this. So that's probably when this happens, look into your syrups, look into sorbitol content of that, look into the osmolarity of those particular drug. Is it more than 1000, which is going to create trouble for you? Or what is the technique you are using? How much dilution you are using for this particular drug? So in such case, dispersible tablet or a drug like digoxin, though their osmolarity is very high, dose is less and we can dilute it. That can be given. That aspect we have to see. If you have three preparations in liquid, elixir, suspension or syrup, it is elixir or suspension which is better rather than syrups, and look at the pH of that particular syrup. Anything which is 4 or below is going to clump your tube, going to affect the tube and going to affect your nutritions. Entry-coated tablets, there are a lot of them. When you dissolve them, basically we do entry coating for preventing degradation from stomach acids. But when you you mix that and you make powder of that preparation, chances of clogging of the tube becomes very high. When you use slow release preparation or modified release, dose dumping effect comes, sudden deterioration in patient health you will find by checking that. Buccal or sublingual preparation, they are better. If you have to use tablets or you don't have any alternate, you have to use capsule or tablet. Make nice powder of those tablets and open those capsules and dissolve them and flush the tube. That is very important. No cancer drug can be crushed. This is dangerous for the person who are handling them. Hormonal preparations, prostaglandin through this particular route when you are using them through the Ryle's tube is better. Amiodarone is very, very bitter and it affects your nutrition also. Light sensitive drugs are the another one which get exposure and doesn't affect, and make sure that you use tablet crusher in such particular case. Very important aspect, the maximum errors happen is when we are giving this liquid preparations, we use same IV syringe, and there are chances that you may use that IV. So best thing is to use oral syringes. Unfortunately in India we don't have oral syringes. That's another issues with that. Water can be used for tap water can be used for dilution of that, but for ciprofloxacin, doxazocin, it is the sterile water which has to be used. Very important, whatever dilution you are doing, that has to be mentioned in the sheet and that has to be calculated on total amount of volume you are using for volume restricted patients. So what's the process of administering this? Very important for you to know, otherwise your tube will get blocked. So you have to ask your colleagues who are doing that. So crush those tablets or capsule and dissolve them 10 to 15 ml for adults, 5 to 10 for pediatrics. Shake them with oral syringe. First flush the tube with 30 ml of water, give this and then flush again with 5 ml. And in between, if you are giving more than one preparation, keep on flushing this. That's very, very important. Timing is very important when you are giving those medications, how much you have to hold those preparations, and break in feeding is very important. And for certain drugs, we have to change the frequency. What does empty stomach means when we are using Ryle's tube? At least 30 minutes before you have to stop the Ryle's feeding, give the drugs, and at least 1 hour after that, you should not give anything. That is the empty stomach when you are giving nutrition through Ryle's tube. And it may be extended in case of gastric mortalities. Poor and empty stomach doesn't mean anything if you are using PEJ tubes rather than it going into the stomach. It's very important, I'll just complete fast. It's very important. You should not add any drug into enteral nutrition because it may cause microbial contamination, it may cause lot of interactions, and there are lot of risk of tube blockage. Alternate routes are better, and 15% cases to get blocked when you are using drugs, and then cost will increase. Tube blockage, how we can prevent it? Use appropriate route for the drugs. Ensure tablets are fully crushed. We fully flushed technique is used appropriately. No acidic fluid, pH less than 4 are not used. And alkalinized pancreatic enzyme may be used for opening those tubes. Docusate sodium, simethicone doesn't have any role. Cranberry juice, carbonated drink doesn't have any particular role in that. So what kind of interaction may happen? Always, I told you, check for pH, check for osmolarity, check for sorbitol content, check for narrow therapeutic index drugs, which may have lot of your drug food interactions when you are using them. Ciprofloxacin absorption almost 25% lesser when you are giving with enteral nutrition. Hydralazine concentration reduces. Sucralfate never should be given together. Theophylline, because of amino acid, 60 to 70% metabolism changes. Warfarin resistance may happen because you have vitamin K content in your enteral nutritions. You never give antacid when you are giving you are using enteral nutritions, because it is going to make protein aluminum complex, and it is also going to cause hypophosphatemia because it binds with phosphate. Phenytoin, very important drug, cause lot of such interactions. One is because of low albumin. Always we have to shake this. It may also bind with the feeding tube, and there may be inadequate dissolutions, and there may be decreased transit time because of hyperosmolar feed. So it's very important, if you are better to use parenteral formulations, or if you have to use because enteral nutrition we are giving, we stop usually at the night. Midnight, if you give at 12 o'clock this phenytoin and single dose, that's always a better strategy for using phenytoin. Same way for carbamazepine, suppository is better. Liquid, you have to give a gap, otherwise it will get adhered to the tube, proper flushing, or use alternate anticonvulsant. Warfarin, because of vitamin K content in the feed, dose suddenly increases, and when you stop the feed, bleeding may happen because of high dose of warfarin. So proper monitoring of INR is very important when somebody is on oral feed. Few words about TPN and their nutritions. Nothing should be added in TPN. That we always say it is sanctum sanctorum. So it is nothing should be added in when you are giving TPN from outside. One, it may be microbial contamination, lot of exposure to the light and stability issues, and we don't know, in the lipid emulsion may get break also, and if there is a precipitation of this particular drug, it won't be visible when we when we are using this. What is strategies in ICU specifically? It's very difficult to keep only single line for TPN. What can we do? We can use multi-lumen catheter, more than 2. And it is found that phenytoin interaction in single lumen or or 2 lumens is very high compared to triple lumen. Or another particular strategy is Y-site connections can be used in such case, and make sure that you don't add anything. Only data available is for adding ranitidine in TPN, that data is available. I told you 3-in-1 admixtures, incompatibility problem because of fat contents are very high. Your emulsion also may get disturbed, and there is a precipitate. If it happens, you can't see those precipitate. There is a death because of one calcium salt precipitate. It's reported in literature because of that. And I told you, as in enteral nutrition, parenteral nutrition, there is a warfarin resistance. It is because of intralipid preparation. If you are using that, that has vitamin K content, and when you stop that, suddenly INR will be very high and bleeding chances will be there. So you have to be very, very careful. And when you are using TPN and using propofol, very important. Propofol also has soybean oil, 10% in that. Make sure that it causes high loading of lipids in that particular aspect. Very, very important, large doses. Theophylline, because of amino acid content, their concentration get changed. Similar way, I told you phenytoins in that. And of course, every mother says that, right? If you don't eat, I'm going to give you IV. But remember, all this, you are sharing this with medications. Make sure that what medication, it's not only knowing your nutrition, knowing those drugs which are sharing the same pathway with your nutrition may affect your nutrition also. Time to collaborate with pharmacologists, I know. Yeah.
PPI. I remember my doctor telling me, "Kuch nahi hota, ek goli kha le." And when you read about it, you realize it's not good for your bone health. So should these warnings come on the tablets, and you, with that positions that you hold, do you think you can make that change?
Very important.
People keep taking painkillers because they were advised at one time, but nobody realizes the kidney is what's happening.
Absolutely.
So should these drugs come with a warning on the tablets, not on Dr. Google?
Very, very important aspect, ma'am. And if you see, for PPIs, they are usually clinical trial data, maybe 3 months, 6 months maximum, and we have seen people using it for years together. I know many people. So what we have done is we have started people training on how to de-prescribe drugs. So we have moved away from prescription, telling them how to de-prescribe. Of course, it's a good strategy for writing on labels that long-term use. If you see all this NaCd, on the label it has come not to be given more than 7 or 10 days. It's there on many, and especially in older people, especially people who have cardiac issues that already started coming in.
Thank you, sir. Sir, I have one question.
I have one more question.
Sure.
Can I? Thank you very much. See, I have attended this 2 days, 1.5 days program very sincerely. I'm a GI surgeon. First, I'm telling you one example. We manage a lot of cases of portal hypertension because of extrahepatic portal venous thrombosis. We give them warfarin. So if you do some other surgery, intestinal one, put a tube. And then one patient, we came up to 4 milligram, but still his PT-INR was not picking up. And then finally we had brainstorming sessions, and then we understood that it was being given through this tube. Everything was getting stuck in the tube. We just changed it, and then things became all right. There were many good sessions over 1.5 months, 1.5 days. And this is one of the best sessions for me as so far as knowledge is concerned. I think all my dietitian colleagues, I'll ensure that they have a monograph of this sort always with them. It's very difficult to remember what you presented, but always good to check what they are giving, whether it has interaction with the tube or not. So a little bit unfortunate because a lot of people, they went away, they couldn't hear this one. But we are recording this one. If you give permission for our future presentations to people, who can disseminate this one and keep it as a monograph. This is a very extensive compilation, and it's very important to the clinicians as well as the nutritionists. So I congratulate for the program preparators who have done it for you, and say the very good work they have done. My question was, we use many types of, I didn't attend your earlier part of the presentation, whether it differs between a Foley's catheter which you put into the feeding jejunostomy versus an India rubber catheter. Nowadays we're having polyethylene catheters. So does it vary the absorption sticking to the tube?
Very important question, and unfortunately we have very less literature on those drugs because no one has done. And this is the area where a lot of research can be done. If you give us what kind of tubes you are using, and we have to do a lot of studies and produce the data on that. Let me tell you, on this particular subject, I was searching a lot of literature. When I was given this particular things, I could find, unfortunately, very little on that. So this is the area of researcher, and no manufacturer says that my drug will get absorbed on the surface of such and such tube. Only academic center like AIIMS or Apollo can produce this kind of research for the benefit.
Yeah, that's where I agree with Madam's vision that some sort of specification should be there on the tablets or something, not to be used through tubes, or should be carefully specific protection on that. That should be there. Maybe that's a thing to discuss later.
Absolutely. We have very less literature, and whatever has come, it has come from academic institutes, not from manufacturers.
Thank you very much, sir. To continue with the sir question only, actually after seeing the data, even I want to know, are there any guidelines regarding the usage of salts? That this salt can be used with this feed, like warfarin cannot be used with green vegetables and all that, with vitamin K. So is there any guideline or any specific thing which you can tell us so that can be used by our dietitians?
Yeah, there are standard, if you see drug food interactions, and you have to search monograph of that, and you will get very little information on that particular. That is available, but extensive data on that is lacking, definitely.
Sir, actually the problem is this, the staff, the nurses, what they do is, for keeping their work on a easier side, once the feed is being given, they just crush the tablet and do it with the feeds. So over there we are telling them not to do it, but they are doing it. So is there any guideline, or is there any specific documentation that what kind of interaction, or like for warfarin we do have vitamin K ka. So any kind of that guideline is available?
There is some literature, but again, it's not very extensive. It's not very extensive.
We had searched for that at the time of warfarin. We didn't find any guideline, and I was suggesting, see, that we should have it like we have done for things. Then one of the guidelines should be done drug and food and tube interactions.
Exactly. And one more question is, as we are saying to flush the tubes, Even after our feeds also, we tell them to flush the tubes. So if we are adding the water after giving the medication, so are we calculating that also?
We need to document everything. Otherwise, how
Exactly,
will know?
this is what I want, that
Yes,
should be made.
absolutely, it should be documented.
It has to be documented, right? It is not being done.
That's why I told part of process of giving drugs. That is important.
Exactly. And
Documentation.
this is a very good idea to bring pharmacologists also as a part of a team. It is need of an hour, I believe. Thank you very much, sir, for this excellent session. Thanks a lot.
Thank you.
So after pharmacology, now we have our next session. I'd like to invite our next eminent speaker, Ms. Ankita Ghag. She is MSc in Clinical Nutrition and Dietetics, and even her topic is need of an hour because what she's going to talk about is personal IV nutrition. We have been seeing extensive EE and we have been listening about personalized nutrition, but this is a very new topic, that personal IV nutrition. She has done a master's in IV infusion and drips in aesthetic medicine. She is registered dietitian and gut microbiome expert. She is a body composition analysis specialist. She is a leading dietitian at the Gut Lab, working a lot with gut microbiome. And she has multiple research papers published in national and international journals and have contributed one chapter in IAP in India's nutrition care processes. Over to you, Ankita.
Thank you so much for introducing me, Bhavna ma'am, and thank you the organizer, Shiva sir, for having me here as a speaker. So today we are going to talk about personalized IV nutrition. It's a future precision towards the nutrition therapy. So when I say IV therapy, it's not only intravenous where we require to give it to the patient, but it is more for a holistical approach, how it is going to help you in your day-to-day basis. So let's understand why we need the personal IV therapy. Because of our lifestyle, all of us get stressed up. If I ask any one of you today here, what are your stress level on the scale of 1 to 10? Everyone will say probably 7, 9, or someone will cross the line and say 11. Because we don't get enough amount of sleep, we have Netflix and chill, we have altered dietary patterns wherein junk has played a major role of your diet part, no balanced meals. So what is happening because of that? The gut is getting compromised. We don't have enough amount of energy. At the very same time, if we want to do something but still we cannot do, we blame it on our lifestyle, but actually no, it is in our body because we are lacking certain things and there is malabsorption. Even though we are not patients, but there are depletion of the nutrients in our body. That's where IV therapy steps in as a wellness solutions. It bypasses your GI tract and make the nutrients more bioavailable in your body. And what is the science behind it? I believe sir has just covered pharmacokinesis. So it is basically for cellular uptake. Whenever we give the IV therapy, it is directly being used and utilized in our body. The bioavailability is high. If we talk about the nutrients like NAD+, which boost our energy, which helps in ATP production, that is on a higher side. Glutathione, it is a mother of antioxidants. We don't take glutathione on day-to-day basis. People take glutathione for skin whitening. But the major role of glutathione is to work like an antioxidant. And it also requires certain more nutrients to work more efficiently. And how practical it is? It is 100% practical and can be clubbed with our enteral nutrition, proper diet, and if we monitor their lifestyle, so inclusion of many more things to it, it is properly delivered to the individuals. And if I see from the functional medicine lenses, so how it is helping me? First, we understand the root cause. But to understand the root cause, we need to also look into the biochemical parameters of an individual. Biochemical parameters play a major role before we plan any kind of IV drip or any kind of wellness solution for any individual. Targeted IV blends should be prescribed to the individuals. So for example, tomorrow when you walk in the clinic, various wellness clinics, they will tell you, okay, you want it for hair loss, you want it for weight management, what is the purpose you want it? but there is no framework done, no biochemical parameters are checked, no BCA is checked, no history has been taken. That's why we get faltering results. But if we do it, if we measure it, and then we modify the individual's requirement, and then we monitor it for prolonged period, then this IV with the functional medicine lenses works wonders. And what are the key components of your IV therapy? It is your multivitamins, basically your B complex, your vitamin C, vitamin D, though it is written into IV therapy, but we would suggest you should be taken IM because of the better absorption out there. Certain minerals such as magnesium, provided you have checked the magnesium profile, zinc, calcium, selenium can be added directly to your IV in your IV infusion formulation. Your multiple amino acids and certain additives additives are nothing but your NS or RL depending upon which solution you are taking to maintain that osmolarity and maintaining the electrolyte balance. What is the personalized framework? First and foremostly, whenever you are planning for any IV nutrition, always do the basic assessment. Basic assessment starts from the comprehensive history, what the patient was suffering, the family history, any medications taken, what are the dietary patterns, what are the clinical signs and symptoms, their body composition analysis. We also do their gut microbiome test. We see the certain lab results such as C-reactive protein, B folate and everything in order to design their personalized IV nutrition. As sir was discussing, PC sir was discussing about precision nutrition. So those things should be considered before planning any kind of IV therapy. And what are the clinical indications where we can use it? If someone is having fatigue, probably after certain illness or probably after any kind of sports, then we can suggest for NAD+, wherein it will give the mitochondrial boost. For immunity point of view, we can actually give them glutathione mixed with certain more multivitamin. For GI detoxification, so I work in gut microbiome, so GI detoxification is mandate. Out there, glutathione along with N-acetylcysteine plays wonders in order to detoxify the body, along with methylene blue if the person is having any candida infection. Aesthetic applications, this is widely known because if we open the Instagram today or any other social media platform, we will see people are promoting the wellness drips, especially for skin whitening. What exactly happens when we give them vitamin C, which is again an antioxidant, when we give glutathione, people think glutathione is for skin whitening, but no, it interacts with melatogenesis and that's how you get the skin whitening. It actually gives the hydration to the skin. It gives you that glow, not because it is designated for that, no. It is healing your body internally and that's how it has been seen on your skin. For energy, NAD+ is very much essential. Along with your B complexes, you cannot only give NAD, it should be clubbed and then only it should be given along with your magnesium and carnitine. Carnitine will also help you for your fat loss as well as for your energy boosting. This is a small case study of 34-year-old who had a gut dysbiosis, who also had brain fog, dull skin. First we did initial IV, there was an assessment. And we planned for 6 weeks. In the 6 weeks, we initially started with a small dosage. Whenever we initiate the IV, it is very essential to start with small dosage, do the skin patch test. For example, certain people cannot take certain drugs. So when we do a skin patch test, we understand, okay, this IV is going to suit this individual. If the person is not suiting, then it's ideal to not to give that drug to the individual. So that was done. Then we checked how it was going. We started with vitamin C, magnesium and glutathione initially. The energy levels were slightly improved. Then we added more things. We added glutathione on higher dosage. We gave methylene blue for clearing the brain fog. And in the final session, what we figured out was energy levels improved by 78%, skin radiance by 70%, mental clarity, means the person who was having mental fog, she also had candida infection, her vitamin D and her vitamin B12 were also low, that also improvised. Her dysbiosis also improved by 85%, but this was not alone done by IV. It was always clubbed with proper medical nutrition therapy. What are the safety regulations? Because it is very essential if someone comes to you, okay, I want IV, but we are a dietitians, we cannot directly give them IV. We need a proper physician on board. Or if you have done your master's in IV infusion, you are you are okay doing that, but not everyone can do that. Safety protocol is very much essential. You need to have certain backup plans if the person is going, person doesn't suit with certain drug. Then you need to have a backup drugs ready. You also need to have proper nurse with you in order to administer that IV. Compliance should be kept. And then when we look into medical researches, it has been shown that whoever has taken the higher dose of vitamin C are having more antioxidant properties. In fact, there are researches going on in the tuberculosis wherein the individuals are given glutathione and vitamin C on regular basis. 600 mg of glutathione and 400 mg of vitamin C is given IV in order for them to recover faster, and they have seen a positive results. Mayo's cocktail, this is one thing which has been given to the individuals and it has shown major results. Mayo cocktails is nothing but you add, and cocktail means mixing the things. And Mayo's cocktail is, Mayo is the person who invented it. So in Mayo's cocktail, what has been added is your glutathione, your vitamin C, your vitamin D, your B complex, zinc, magnesium, calcium as per the requirements, and it should be calculated what is the requirement of the individual. Then only it should be administered. Any fat soluble vitamins should always be preferred given through IM, not through IV. Then if we see the integrated approach, it should be always blended with your proper nutrition therapy. You should be adding polyphenols to the diet in order to have a better polyphenols and phytonutrients in order to have a better cellular support. For a gut restoration for the people who are having SIBO or SIFO, IBD, dysbiosis, it is very essential to add certain antimicrobials. For antimicrobials, NAC does wonders. At the very same time, you need to add digestive enzymes as and when required for the individuals. We also need a proper prebiotic fiber such as sun fiber. We need acacia fiber or baobab for certain individuals depending upon case to case. Lifestyle intervention is mandate in this individuals. If the person is taking IV, doing the diet but not sleeping properly, then also it goes on waste. So it's very essential to follow all the cycles of the lifestyle rather than just monitoring one. What are the challenges? IV therapy is just picking up, so not enough publications or evidences are available. Safety concerns should be there. We need to follow proper, like you have used the needle, you need to discard it. You need to discard the proper cotton, not to use that IV line again. So such ethical things as well as safety concerns should be there. Overuse is something which has not been advised. People at times they overdo it. Suppose for example, abhi shadi hone wali hai, I want to take IV drips regularly. No, you cannot. You need to give that gap. You need to also calculate, okay, this is the requirement for the body, or else what happens, the person goes on the peak and there is drastic fall at one go. That is not advisable. We need to take them to the peak, maintain it, and then slowly come down, not drastically. That also falters, and many individuals have landed towards the liver issues. So in such cases, we also need to monitor what are the dosages given. You will go to the market, some people will sell 600 mg, as well as there are companies which will sell you more than 1 lakh mg. So it is very essential to give the proper dosage while calculating, not randomly. Responsibility should be taken, a proper things should be signed, a proper form should be signed, audit to be done in terms of products also, in terms of how it has been administered with your internal clinic is also mandate. And if I have to bring the nutrition science together, it is very essential we as a nutritionist work together along with the holistical approach for giving a better lifestyle to the individual or better state of living to the individuals, wherein we integrate the cellular nutrition, precision nutrition, work towards the proper assessment protocols, dietary protocols, and the lifestyle protocols. I'm open for the questions. Thank you.
Thank you, Ankita, for such a wonderful, crisp presentation. I can say this, that this is again need of an hour, because you are right. If you see Instagram, it is loaded with vitamin C drips, and
Correct.
especially for the brides to be. So I just want to ask one question, that why can't we maintain that vitamin C with the diet beforehand? Why they are landing up with the IV drips? It's more in the aesthetic looks what we are seeing the users.
Correct. What you are saying is actually correct. Why we cannot do it with the diet? First, if we see the bioavailability of the vitamin C of what we are consuming with our natural foods is on the lower side. We say amla is the richest source of vitamin C, then comes guava, but how many of us consume it on daily basis? No. Then if we look at the multivitamins which are available, again the bioabsorption is on the lower side. So IV, it becomes highly bioavailable to our body. That's why that along with the oral supplementation, it has shown better result as compared to just the oral supplementation. It just boosts the process.
Okay.
Yeah.
So does it have any side effect or any contradictions or any limitations?
So
Are they being documented or any literature available on
if
that?
we are looking for the healthy individuals, then no. But if we are looking for the individuals who have got metabolic disorders or any kind of lifestyle ailments, then we need to be very much conscious in order to prevent the side effects of the same, rather not to give only in certain cases. So we need to actually mark our group whom we are going to give IV, whom we are not going to give the IV. That is also very crucial. Patient just walks in for the IV and we give them no. We need to assess and then see if the patient is actually eligible for that IV or no. So that plays a major role out here.
So exactly my question is there any literature or guideline or anything available?
There is a literature for administering the dosage, how much dosage should be given. It is very much established and multiple research papers are available online where you see that, okay, if the person is coming for the glutathione and looking for melatogenesis, then probably per gram you need to give 6 gram per kg body weight or so. That is established guidelines. So that guidelines are available. Safety precautions, limited guidelines are available. That's why it is a way ahead for research, as previous speakers are also correctly said that there is a lot, there is scope of research in terms of all this. When we have a synergical approach, there are no more research papers available, hardly 1 or 2 we can see in the market as of now.
So can this be given by a dietitian or it can be, is
So-
there any specific course which is being provided? So can
Yes.
you give us
So ideally, we need a physician on board to do that. But if you have done your master's in IV infusions and medical aesthetics, then you can do that yourself, provided you also have a nurse in your facility and you have studied, you have all the safety things with guidelines with you. Then as a dietitian, you can practice, provided you have done the course. Otherwise, dietitian will play a role in terms of assessment, in terms of planning of the thing. Talking about the institute which is giving this, Skill India project is available for this, where the dietitians can practice this. In Mumbai, there is a MAC International Academy which is offering this course for a dietitians and the medical professionals who has the knowledge about all this.
So you say you need a team actually. You need a team and a proper center to be given. It's not so.
You can practice it at your place also. I'm not saying no for that, provided you have all the safety guidelines ready at your place. Then you can administer. Otherwise, team is mandate.
One last question from my side. Is it a placebo effect? Can we say that?
So, when we talk about NAD+, when we talk about glutathione, certain places it can play placebo, but for your vitamin B12 levels, your C-reactive protein, your ferritin, those may not come down. There is no placebo effect for that. It will just show whatever is there on their biochemical profile. Only for your energy levels wise, it can show, but not for your biochemical profile.
Thank you. Any question from audience?
Validated tools for assessment of the individuals, correct? So for So tools and assessment techniques which we do is, first we take the brief history of the individuals, then we do their BCA, we check their biochemical parameters, a proper profiling as per the functional nutrition, we check their entire biochemical profile, and then we move ahead. If there is any existence of any multiple disorders, then we don't make that person eligible for having this kind of therapy. It's just for healthy individuals or someone who has got multi-nutrient deficiency, then we plan it accordingly. For example, I had the individual, she had wedding, as well as she had to shoot for certain things. She is a social media influencer. So now she wanted that look. But when she came in, we figured out she has, one, she was excessively overweight because we could see with BMI, and also her body fat was on a higher side. Then she constantly she was having body fouls, she had sugar cravings, At the very same time, she had PCOS. So now such individual, okay, I can assess that individual, I'm assessing, I modified her diet. Then we planned a therapy for her, which was IV therapy, wherein we genuinely started with minimal dosage. Though she was asking for higher, but my first answer was no. We started with minimal dosage, then we increased it, and then her target was 1 month, but we took it for 3 to 4 months, because that's how the process will go. Just because someone is saying we will not do that. At the very same time, there was one cancer patient walking in asking for glutathione on a regular basis. My first answer was no, we are not touching it, because first we need a doctor's intervention, and these are the things which cannot be given just as a free will, even if the individual wants it. So no, if you get certain critical ailments, then answer is no, not to do that.
Any other? Sir.
Very, very interesting for me. You mean till today, what I am seeing in the ceremonies all are vitamin C? And so nowadays, after taking, I frequently take oranges, then after taking one orange, I have to look at my mirror whether I am looking better or not. Is it for only ladies or for gents?
All genders, sir. Most welcome. It's for all genders.
Okay, now coming to a serious question. Suppose my marriage is after a month and I have to start preparing. So I am taking vitamin C injections for how many days? 3 days?
No, sir. If the wedding is planned after 1 month, and if you're visiting first, after doing the biochemical profiling, it will be once a week or twice a week, depending upon the requirement.
Okay.
Along with that, the oral vitamin C will be continuing.
So my question is, suppose obviously a little bit obese, is very difficult to get the veins, and if another person has the same thing and he or she starts with a vitamin C tablet, 500 milligram 3 times a day, so how much time she would need or he would need to have the effect of this IV vitamin C?
IV vitamin C along with the other nutrient, not only one. I will be clubbing it with couple of more nutrients, as I just mentioned, such as glutathione, magnesium. I will be also clubbing it with vitamin B complex. So the results will be seen after 3 to 4 drips. You will start seeing slight results in your body, and energy level wise you will start seeing it after 3rd trip.
But what is the parameter to know beautiful, less beautiful? How do you know? If I am to do a research, then I have to document.
So
then what are the parameters to document?
We take the images of the individual, face images, skin images. You will see there is lightening seen, or probably what we also do is we also check the BCA, wherein we also assess the body fat, we assess the muscle mass, we see the inflammatory levels. So when the vitamin C is administered, sometimes we also give curcumin, so we also see the inflammation is also coming down. So we're monitoring each and every parameter of the individuals, and there is a questionnaire. What are your energy levels now before you walked in? What are your energy level improvements? Each session there are the questionnaires which one needs to fill in. So that's how we track
would be influenced by the camera, all these
the
things.
images
also.
are influenced by cameras, but the questionnaires are not.
Questionnaires.
So
then that is individual.
helps it.
That is individual dependent. But I think now in this area, maybe AI would come into the picture to see, because they can analyze thousands of.
When you take the image of the individual, the lighting also matters, sir. So if you have a specific setup of the clinic or at your place where the light is also constant, then we won't have any issues. The camera is same, lighting is same, the background is same, then we will get a proper thing irrespective of AI or no. But yes, AI will actually work more precise, provided there are tools in AI for screening your skin, which is available right now at various shops such as Nykaa or probably Tata Click. You enter the store, they do your face scan, and then you get all the parameters. I guess many of us would have visited that for skin assessment. It is done there.
Plus, sir, to add to that, aesthetic looks are being visible and they can be very well changed by the AI tools and the filters. But it is, as she is saying, it is the health part of a person.
But
on the health part, what they say, that how are they feeling, right?
Yeah, but till date, I was taught that beauty lies in the eye of the beholder.
That is there, sir. I believe we really need to do a lot of horizontal, extensive work needs to be done.
Exactly.
Oh, it's a very, very, very interesting topic.
I can talk for hours. There are so many things of IV which I couldn't cover because of time constraints. But there is too much for IV to
Then
cover.
if it will be too much, the repercussion would be, then you bring in your blood level of vitamin C before I agree for marrying, whether you are really true or you are artificial.
So, sir, we have a topic for our next IAP and Delhi chapter now.
Yes.
Which can be kept in extensive part, right, Ankita?
Correct.
With all your colleagues to present the data.
Done.
Is that cosmetic nutrition? Is this? Or it's something else?
So, anything else, sir? Yeah, wants to ask. Yeah, Ankita, before you leave, you need to answer her query also. Your topic is like this, very new, and we have so many questions.
Surely, please come.
Hi, Ankita. Thanks for the insight. I wanted to know, recently there was a high-profile case. We know it all.
Yeah.
And something wrong happened with the lady. So I need to know about the precautions for a normal human being they should take when they are considering IV.
Okay, so as you mentioned the high profile case, it was also published later that she was on multiple drugs. So it was not only one. Previous speaker also spoke about drug nutrient reaction. So that's why when I started my talk, I specifically mentioned that you also need to see what are the drugs which individuals are taking. If you feel there are higher chances of any kind of drug nutrient reaction, then you shouldn't be giving that. There was one case in my clinic wherein again a high profile client was there at my setup. We gave her the IV and all of a sudden she started developing the fever. Though I had a safety guideline ready with me, we administered that, and that day she never told me she had certain issues, so she had taken the medicines prior or some of the other ailments was going on. Had she told me, the IV wouldn't have been given to her. But when you give the IV, you also monitor the individuals. I personally follow up with my patients after they have done the IV. I also follow up with them after 1 hour, or probably next day also I give them a call just to check on them how they are doing, because that is very essential in order to prevent such kind of disasters. It's not only with her, there are a couple of more high profile cases which happened this way, but IVs were nowhere related. It was one, they were taking some drugs which reacted with it, and secondly, because of certain lifestyle issues or probably certain addictive habits, it happened. I don't want to say anything out for the person who has passed away, but there are things to it. We have seen just 10% which is just shown to us.
So, thank you IAPN, thank you IAPN Delhi chapter and SEPN for conducting this wonderful feast. So, thank you very much.
Thank you.
I thank Dr. Sanjeev, Ms. Ankita and Dr. Bhavna for this very interactive session, I must say. Although the last session for the conference, but I believe this was the most interactive session in the conference. So once again, thank you to all the speakers and our beloved chairperson. As we are coming to the end of this conference, I would request our dear Anita Jatana ma'am to please come and give the vote of thanks.
Wow, I think before I say thank you to anybody else, I want to say thank you to the participants who are still here. 3 cheers for the participants who are still here. Yes, it's really bad because a lot of work goes into planning. Ask Shilpa. Shilpa, come here in the front. How much work goes behind planning, and when you see a little khali hall, maza nahi aata. Anyway, I think with ladies, the shopping takes the priority. So they run away. A big thank you, really. Let's get serious. Just want to say a big thank you to Mr. P.C. Vijay Kumar, Mr. Shiv Shankar, Dr. Shilpa, who were there always guiding us, Dr. Dash. 10 o'clock, 10 p.m. meetings. Thank you for giving us time after the OTs. So we used to coordinate at 10 p.m. with all of us to make the program final. So, and the entire NEC team who's worked behind this conference. the SAPN Council members, all the foreign delegates, the participants, the speakers, of course, and Shilpa, a big, big, big hug to her for putting tireless work she's put behind it, and the AV help, all the stalls outside, and absolutely a big thank you to all the sponsors who helped us. Otherwise, I don't think this would have been possible. There was a lot of learning from the physicians. I think it's a lot of take-home messages for the dietitians, because really seeing how things go, the tubes go, we just know enteral feed hai, peg hai, pedge hai. But what is the problems that go behind inserting those tubes, how well we should look after them. And we had an excellent 2 sessions last, which were also eye-openers. So a lot of take-home messages, and doing this to collaborative with the physician and the dietitians together, I think makes IPN absolutely a big success. So looking forward to the next Congress, now in Nagpur, and of course, keep on learning and keep on taking home messages, and a big thank you again. And would like to have all the participants who are here on the stage for a final photo shoot. So I think this photograph is the one that's going to go on to the page. Big thank you. Lekha, I thought you'd left. Thank you. Part of the NEC, but then yes, a big thank you to you. I think this is the photograph we should put on. Yes.
आप थोड़ा आगे जाइए ना, वो पहले हम ले लें।